Now, ano lang, a quick overview ng mga topics to be discussed, okay, for this morning and for this afternoon din po. It will be all about basic trauma. Yeah, usually on a pre-hospital setting. And then tomorrow po, we will discuss some of the intra-hospital setting din po ng mga basic trauma na mga cases. Kasi as we all know, di ba, pag trauma, usually mga motor vehicular accidents. So from pre-hospital, then hanggang sa papasok po yung patient natin sa ER. So yung mga certificates po na marireceive today ay of course na well acknowledged po ng the Department of Health, especially for accreditation. And for abroad din po, yung mga basic trauma ng mga certificates. So this will be a combination of the actual, and of course the ideal one, especially for the primary and the secondary assessment po natin. Kasi may mga updates po based on the 911, pwedeng locally and pwedeng internationally po. So may mga topics po tayong kailangan i-discuss. And we will be following the COVID protocols din po, in which it's very timely, diba? Very relevant po, especially now we are facing the pandemic din kasi. So we still have 6 minutes before we start. Sir Gilbert, police ka ba, sir?
No, sir. Nurse po.
Nurse. Nasa hospital ka ba ngayon, sir, or nasa bahay?
Nasa bahay po ng boss ko.
Nice. Sir, naging estudyante ka ba namin, sir? Sa Btls ACLS?
Nag-training ako, sir, ng BLS ko sa Red Cross.
Okay. Pero sa amin, sir, never ka pa nakapatrain?
Ngayon lang po.
Nag-train? Ayan lang. Okay. May notebook ka na ba dyan, sir?
Meron, sir.
Okay. Good morning po, Miss Marie Claire Bueno.
Morning po.
Morning, ma'am. So yun po, coffee po muna tayo and then your notebooks din. So lahat po ng ito ay recorded po. Expect later, meron po tayong mga assignments, let's say for mga trauma cases po. Because tomorrow there will be a quick, may mga quick sharing din po tayo regarding sa mga trauma cases po natin. Especially more of the updates din. Kasi you need to do your part as well. Since this will be an interactive din na lectures po. Plus seminar din. So good morning, guys. I'm Mark Adlawan. I'll be your instructor po for the basic trauma course. It will be a 2-day activity po or a 2-day online lecture. And ideally kasi, usually weeks kasi yan, including the training po. So for today and for tomorrow, it will be more of concepts po tayo. Okay? So paano na lang po? Pa-chat na lang if ever kung masyadong mabilis pa or hindi po ba clear, let's say, it might be sa connection po natin. So by the way, I would like to acknowledge po yung mga nurses po natin na nasa hospital from more of Bicol areas po. Ayan, kasi yung from vegan po natin, community-based po sila. Tama po ba, ma'am? Ayan, sige po. So let's begin. So by the way, guys, for the basic trauma, when we say trauma kasi, that talks about physical injuries, right? It might be or it can be so distressing. So we have several types of trauma kasi. Pwedeng physical, pwedeng emotional trauma. Let's say mga heartbreaks po natin. Yeah, emotional trauma po yan. Pwedeng psychological trauma, let's say for abuse din. Na? And so there are a lot of forms of trauma. But for today, we'll be discussing kung ano yung pinaka-common talaga na trauma. Na? Ayan, based on the Philippine setting kasi, ayan, motor vehicular accident pa rin ang pinaka-common. So guys, for today, my objectives, okay, are as follows na po. So basically, we need to be updated dapat. Na ito yung pinaka-focus natin eh. So we have the updates po dapat. So aside from updates guys, so it should be okay related din okay sa COVID issues po natin. And so we will be discussing okay updates okay on the said okay trauma, basic trauma course plus okay ano pa itatandem po natin sila okay with the COVID issues. Let's say ngayon guys, may protocol kasi ang EMS or the emergency medical services. Let's say if you have a suspected patient na may COVID po, usually that begins with 'di ba, yung mga special na mga protocols po natin na yung mga direct contact precaution, no? Ayan yung mga contact precautions po natin. Ano pa ba ang pwedeng okay, 'di ba? Pwedeng i-airborne or pwedeng i-droplet. Pero guys, ang updates kasi nila ngayon, if ever kung suspected lang ha, na walang aerosolization. So ang gagawin po natin usually mga direct contact precaution plus your okay, the droplet precaution. But if ever you want to let's say ventilate na the patient, may aerosolization na, the suspected po siya na COVID patient. So mag-iiba po yung precaution po natin. It should be direct contact plus okay, it should be on an airborne na siya. Okay, na precaution po. Sige lang, i-stress po natin siya later. Na that's based on okay, the Pan-American hospitalization din na protocols po. Kasi may mga ano din tayo eh. May mga let's say PDFs po tayo na i-share po sa inyo. Okay? Ayan. Yung iba po ay working sa hospital at saka yung iba po ay for updates lang po na tinatawag na the trauma cases din natin. Ayan guys. So we have the introduction. So basically when we say trauma, that refers to a physical injury guys. So since madami yan, so we have the physical injuries. It can be brought about by the energy na kasi ang energy guys, you cannot destroy the energy eh. Kasi may impact yan sa sarili mo. It can be low energy. Ano ba mga example ng low energy natin? Let's say mga stab wounds. Na? And bigla kang kinuchilyo, may mga low energies yan. Pag mga gun lang, mga medium energy yan. Pero pag mga high energy po, ito yung let's say mga Armalite, di ba? Yung mga grabe talagang impact sa'yo. So it can be brought about by energy na kaya nagka-trauma ang patient natin. Now, ayan, based on the Philippine scenario guys, as you can see, may mga from 911 po tayo na mga corresponders. By the way, I'm from Davao City. Ayan, so yeah, I have a brother who's working in 911, brought about by referrals na din. And by the way guys, 911 is now they are hiring now, especially for nurses and for doctors also. Ayan, maganda naman yung pasahod nila, 911 sa Davao. Ayan, so as you can see, may nakikita po tayong mga patients dito guys. Ayan, very common causes of mortality, no? And based on the Philippine setting, it's always the motor vehicular accidents po. Example, let's say mga, di ba, pag ulan-ulan, na? And may mga na-discrash sa mga motor, no? Magulat ka, yung iba nasa daan lang, and then yung iba din guys ay nasa nasa ilalim na ng mga truck, mga ganun po. Ayan. So yeah, it's very morbid talaga na makikita ang mga cases na ito. So basic requirement po, ayan, para sabihin, responder ka or EMS responder. Ayan, or from 911, na ito yung mga trauma team po natin. Ayan, na dapat, syempre, susugod ka sa isang case, dapat guys, or sa isang scenario, you need to be no, ready ka na dapat. Diba? Dapat protektahan mo sarili mo at protektahan mo din si patient. So there should be a scene safety. Hindi lamang sa'yo, pati sa kasama mo na din. Na, kasi it's tantamount eh. When we say tantamount, dapat parehas lang. Ang personal, safety mo at saka personnel kasama mo, dapat parehas kayo in a safe dapat na environment. Kompleto. Pag sinabi mo bang safe, dapat sir? Dapat ba may mga PPEs po? Yes. Familiar with the PPEs, guys? Or the personal protective equipments? Or the PPDs, or the personal protective devices? Or commonly known as the BSI. Familiar with BSI? This is the body. Ayan, substance. Ayan, isolation po. When we say body substance isolation, that's the wearing of what? Yung mga gloves natin, yung mga goggles, yung mga mask po natin, na in which of course mahal po ngayon lahat ng mga PPEs, 'di ba? They are gold, sobrang gold lang sila. Pero mas gold pa rin po ang alcohol ngayon. And then of course, na yung pinaka-issue ngayon guys is the 3M. Yes, kasi yung standardized talaga, ayan, yung pinakamagandang mask kasi will always be 3M. Kaso kasi ang 3M ngayon guys, million din ang capital niya kaya tinawag na 3M kasi hindi ka makakuha pag wala kang milyones for the 3M. And by the way guys, 3M should be manufactured kaya syempre sa US. Pero may kumakalat po ngayon na made in China. So hindi ka sure kung gaano po ka-effective or let's say, 'di ba, safe ka bang gamitin ang 3M na 'yon? Or baka humihigop siya mismo ng virus. So, yeah, extra careful na lang po tayo. Okay? Now, for me, as a responder kasi, you need to be knowledgeable. Aside from being knowledgeable, guys, you need to be confident din. Kasi for me, pag yes, knowledgeable ka lang, pero wala kang confidence, then it will all be useless. Na? Ayan, so yun yung mga basic requirement po natin. Right? Ayan, so syempre kasi, pag may sinabing mga trauma, ayan, ano ba, what comes in your mind ba pag may mga trauma, pag may mga accidents? Syempre ikaw, kakabahan ka rin. Pero kasi, as an EMS responder kasi, it should always be sequential dapat, no? Ayan, may ifa-follow ka na sequence. And then dapat, everyday, dapat yung sequence na yun ay ginagamit mo. Kasi para may consistency. Di ba? Pag may consistency kasi, the rest will follow eh. Na? Yung tipong hindi ka na mga confused kasi nga consistent na ganito, ganito, ganito. But of course, with that consistency kasi, dapat you need to be updated din. Kasi if you're not updated, then that will all be useless na. Okay? So if ever po, sa mga interesado na mag-work sa 911 sa Davao City, I can actually refer you ayan, sa HR nila or let's say sa mga, alam mo, nakataas-taasan nila. Na, kasi I have several friends who's working with 911. Okay? Ayan, sige pa. So here are the phases of trauma management. So guys, this is a quick overview na kung ano ba yung mga i-discuss later. So hindi pa ito yung pinaka talaga main natin na topic, but rather overview lamang. So when we say phases po, number 1, we have the word, preparation. Ayan, the scene safety of course. Na ito yung scene size up po natin. Right? Next, we have the triaging. Guys, when we say triage, di ba may mga different colors po tayo. Let's say, di ba, from Germany, iba po yung triage system nila. Na from HK or let's say Hong Kong. Na, ayan, tapos Canada, iba-iba po yung mga triaging po nila. Right? When we say triage, it comes from the word trier, di ba? Ayan, so that means prioritizing a patient po. Now, paano ba mag-triage? Ayan guys, familiar with the triaging? Ayan, may mga sandals po tayo na pinibenta. Ayan. So when we say triaging po, ayan, so we have the T1, which is actually, ayan, the red one. Ayan. Next, we have the yellow. Review lang po tayo. Next, we have the green. Then next, we have the blue. And then we have the disease one. Guys, pag sinabi po natin disease, malamang patay po ang patient natin dyan. Alright? So, of course, we have you have the urgent, di ba? Yung mga non-urgent po natin. We have the minor injuries and then we have the severe. Sino nga yung severe dito? It's basically the red one. Na? So, pag sinabi po natin, red, that means acute danger for life. And that means, or that requires an immediate dapat. And usually, guys, 0 minutes ang kailangan dyan. So, pag sinabi mong 0 minutes dapat mabilisan dapat. Na? Ideally kasi, pag sinabi mong dispatch, di ba? Hello, this is dispatch. Ayan na. And patient, ganito. Dapat ilang minutes ka dapat mag-arrive sa scene. Ideally, guys, dapat 5 minutes. Na? Pero brought about by circumstances na usually maximum will be 10 minutes. Alright? Ito na yung mga pinaka-maximum po natin. So ulitin ko lang, pag sinabi po natin 5 minutes, that's the ideal time na mag-arrive ka sa isang area. Alright? Ayan. So we have the red, which is, that requires an immediate management po. Now, next we have your, with severe po. Ayan. Ayan, severe injury, and that's the yellow one. We have the green one, which, requires, ayan, may mga treatment, pero with minor lacerations lang naman guys, pag green. And then pag blue one, syempre, no or small chance of survival na po si patient dyan. Kasi anytime, anytime, pwedeng, patay na po ang patient natin dyan. Alright? Ayan, so ito lang yung diniscuss ko kanina guys. Pag sinabi mong red, ayan, we have the resuscitation that requires 0 minutes. Ayan, di ba? So we have the emergent, we have the urgent, we have the less urgent, and then we have the non-urgent. So yan lang yung diniscuss. Based on, Canadian naman to. So sa mga magmamigrate po sa Canada, so ito po yung triaging nila. Guys, tignan mo yung number 2 emergency or emergent. Alam niyo ba pag sa Australia ka, dapat within 10 minutes. Pero pag sa Canada, within 15 minutes po, pag emergent nila. So yun lang naman yung napansin ko na pag here in the Philippine setting, do we triage by a patient? Of course, na ayan, pero yung ibang hospital, ayan, wala namang ka-triage, pero feeling ni patient na triage siya, na it can be brought about by the scarcity of nurses na din po. Right? Ayan. Pero for me, somehow, no, it's okay na may triaging. Pero pag ikaw na po ang patient, guys, ikaw na mismo ang hirap po Lalo na pag as in like, nag-present ka lang to na abdominal pain. So mamaya ka pa talaga. Unless, kung dumating ka doon, na nagdrama ka at nahihirapan kang huminga, di ba? So malamang ikaw talaga ipaprioritize. Kasi as we all know, di ba, if the patient is conscious, it's basically ABC, na airway, breathing, circulation, if conscious. Pero pag unconscious pa ang patient natin, guys, magbabago na po siya. Hindi na po siya ABC, but rather CAB protocol. We have the circulation, the airway, and then we have the breathing. Alright? Yan, so pa-shoutout na lang po guys kung masyadong let's say, hindi na ba clear ang connections po natin. Ayan. Hindi po ako yung bata guys, kanina kumanta sa sa prayer po. Medyo kamukha ko lang siya na yan, nakita ko din yung sarili ko sa kanya. Pero for sure, hindi naman siguro bading yung batang yan. Okay? Ayan. So, mamaya na yan. So, ano ba yung the usual problem guys pag online lectures po? Ayan, number 1, sa makikita nyo sa screen, wala pong filter. Ayan, so nagsasabi po talaga siya ng totoo kung ano tayo, right? Ayan, ano pa ba ang problem po natin? Pwedeng connections din talaga. That's the number 1 problem. So right now, I am using the Converge. Yeah, sobrang bilis ng Converge, guys. I'm actually using the 75 Mbps. Yeah, sobrang mabilis lahat sa downloads, no? Name it, kung ano yung mga gusto mong i-download. Okay? Ayan, so yeah, aside from triage, na-discuss ko na yung triage, so we have the primary survey. Guys, when we say primary survey po, that talks about A, B, C, D, E, right? So we have the airway, ayan, we have the breathing, we have the circulation, then we have the letter D. Ayan, yung letter D natin. So we have the disability, and then we have the letter E, the environment, you need to expose the patient. Ayun, I guess parang nagkagulo ata sa rapu-rapu. Nagkagulo ba dyan?
May Zoom ka?
Nawalan ba kayo ng connection, ma'am? Ayan. Next, we have you need to resuscitate the patient. Kasi guys, in resuscitating the patient kasi, lalo na pag na-check mo na the patient is unconscious, no pulse, no breathing, na? So therefore, you're going to start with your high-quality chest compression. Okay? Ayan. Next, we have the secondary assessment or the survey. Pag sinabi kasi natin survey, that means assessment. Na? Ano ba yung mga ginagawa natin on the secondary survey po. Ayan. On the secondary survey po guys, usually that begins with the checking of the vital signs. Na? Yeah, yung mga vital signs po natin, chine-check po on the secondary survey. Although, iti-check siya later. Okay? Ayan. On the secondary survey naman po, guys.
Sir,
Yan,
sa
may mga...
RRTH po, maluyaw ang sound. Mahina po
Ma'am?
ang sound.
Mahina ang sound, ma'am.
Opo.
Paano kaya yun?
Baka po sa speaker nyo.
Baka sa speaker, ma'am.
Naka-full
ma'am?
ano na po.
Naka-full na ba?
Ito po ba yung sounds?
Ito, ma'am. Okay na ba?
Mahina pa din po.
Paano kaya ito? Hello, ito.
Bigla man lang daw po naghina. Humina.
Biglang naghina. Hindi kaya sa connection yun, ma'am?
Ano po?
Hindi kaya sa connection yun?
Connection daw ate.
Ma'am, naka-speaker po ba kayo dyan, ma'am?
Tingnan po ulit namin, sir. Wait lang po.
Mm-hmm. Alright, guys. So, ayun po. Pasensya na may mga technicalities lang po tayo. Ma'am Aquino, okay naman yung signal natin dyan, ma'am? So, para tayong mga reporter nito, na. So, from Vegan, kamusta po yung signal natin? Guys, paano po? Pa-chat na lang kung may mga problems with the connection po. Ayan. Siguro naka-wifi to sila, Ma'am Aquino. Okay? So, recap lang tayo. So, we have the preparation. Ayan, kung gaano ka ba ka-prepared, na? Especially in battling, di ba? The trauma issues po. Kasi guys, sa preparation pa lang natin, guys, ito, pinakamahirap na to eh. Di ba? Dapat full gear ka dapat, na? The same safety, di ba? The PPEs na gagamitin mo. Ano yung general impression mo sa patient mo. And then, you need to, kailangan maging ready ka. Kasi, sa patient kasi natin, guys, pwedeng dramatic kasi yung scene na yun eh. Di ba? Pwedeng may mga umiiyak na mga, let's say, family members ba? Or it might be, let's say, yung accident na yun ay kahina-hinala. It can be what? No, andun pala yung, ba't siya, bumulagta? Bakit siya may gunshot? Kasi yung killer pala, guys, is within that scene na din. So, at stake din yung life mo. Diba? Siyempre, makikita ng killer, bubuhayin mo pala yan. So, dapat kayong dalawa, ang babarilin. Right? So, we have the triage. Now, for the triage, na-discuss na po natin kanina, we have and that requires na yung mga life-threatening po natin, from life-threatening up to the deceased client po. So, just be reminded lang with the colors, and then yung mga minutes of resuscitation dapat. Next, we have the primary survey that talks about the airway, breathing, circulation, disability. Familiar with disability? Now, everybody say disability. Very good. When we say disability, guys, it talks about the GCS status of the patient. Na yung pupillary reaction po, kamusta naman? And next, we have the exposure. Right? The environment din. Sige lang, mamaya. Himay-himayin po natin na pagka-discuss sa primary survey po natin. Next, we have the resuscitation. Basically, it's the high-quality chest compressions po natin. In which later po, I will be discussing a few lang din. Okay, a few more tips, especially sa updates po ng high-quality chest compression. Next, we have the re-evaluation. Guys, when we say re-evaluation, that means the reassessment of the patient. So once you reassess a patient kasi, you're going to reassess ulit the vital signs. Babalik po tayo sa primary assessment po natin. You need to stabilize that patient. Usually, ang re-evaluation, nasa loob ka na ng ambulance niyan. Okay? So, pag nasa loob ka na ng ambulance, gagawin mo ulit yung mga ginawa mo. Anyways, ita-transport mo naman din ang patient nasa nearby na mga trauma, na mga hospitals po natin. I know for a fact na sa Bicol, ang alam ko talaga, the BRTTH is the number 1 po na trauma center. Yeah, in the whole region. In the whole Bicol region po. Kasi pag sa Manila, iba na naman 'yon. Yung mga number 1 na mga trauma na mga centers po natin. Okay? Pero ang alam ko sa Bicol talaga, it's the BRTTH na ang pinaka number 1 na who handles ng mga trauma. Kasi number 1, it's a government hospital. So malamang it's funded na din, na Ayan, Ma'am Joy.
Yes, sir.
Ma'am, I guess nawala yung mga rapo-rapo.
Nandyan pa rin po sila.
Nandyan pa rin pa. Okay. Ayan,
Nakamute.
pero nakamute lang. Pero anyways, ma'am, recorded naman to, ma'am, no?
Apo.
Okay, so they can actually review them later, right? And so we have the definitive care, guys. The definitive care, ito na yung nangyayari sa sa emergency room, na. So it's outside the hospital. Ayan, outside 'yan. Pero pag ito na po, okay, intra na po ito. So meaning, ayan, si dispatch, i-refer na po natin si patient, guys, sa tinatawag na hospital. Ayan. So, I guess may gumagamit na po ng speaker. Ayan. So, parang loud and clear na po ata. Ayan. Parang nawawala yung signal nila. Alright? So, again, guys, we have, okay, the phases, okay, in trauma, okay, management po. Now, yeah. So, let's begin na po sa ating first topic. Ayan, as part, okay, of what? Now, of our discussion po for today, guys, that talks about, okay, the patient assessment dapat. Okay, sulat natin. So, we have the patient assessment. Na, ano ba yung mga topics po natin, okay, under the patient assessment? So, number one, we have what we call as the scene size up. Ayan, we have the scene size up. Aside from the scene size up, we have the primary, okay, assessment po natin. Ayan. Aside, okay, from the primary assessment, we have the history taking. Ayan, so we have the history taking. Aside from the history taking, guys, we have the secondary, okay, assessment po natin. Aside from the secondary assessment, ayan, we have A, B, C, D, E. So we have the reassessment, okay, reassessment of, okay, the said patient. Now, this is, okay, actually the first topic known as the patient assessment. Guys, okay, under, okay, patient assessment, so we have the scene size up. Ayan, pag sinabi po natin scene size up, you're basically approaching a scenario. Na? If you're going to approach a scenario kasi, dapat ready ka. Ano ba yung magagawin po natin? So mamaya, na discuss natin yan. Next, we have the primary assessment. Ano nga yung sabi ko? The ABCDE. Ayan, pero may bago po tayo doon na ginagamit po ng 911, especially sa Davao. Because this is part of the updates po ng EMS po nila. Next, we have the history taking, guys, okay, ng patient po natin. Are you familiar with the focus, okay, medical, okay, assessment? Yung mga sample, yung mga OPQRST when it comes to pain. And i-discuss din po natin yan. Next, we have the secondary assessment. Ayan. So aside from secondary assessment, so simply, okay, we need to what? Na reassess a patient na naman. Okay? Ayan, sige pa. So, we'll proceed na sa scene size up. Guys, pag sinabi po natin scene size up, ayan, scene, okay, size, okay, up. Now, that talks about number one. Ayan, syempre yung mga topics natin, of course, you need to properly, okay, execute and don your PPEs po dapat, or commonly known as the BSI. Ayan, example, mga gloves, okay, goggles, mask natin in approaching a scene scenario po. Pag sinabi po natin scene scenario, huwag mong kalimutan ang scene safety po natin. Diba? Is the scene safe? Kasi, syempre, we will be dealing with what? A chaotic environment kasi. Kaya before ka guys, na bababa sa isang, let's say, sa ambulance mo, dapat i-check mo na din. Diba? Kung, okay, is the scene safe ba? May mga potential na mga hazards ba tayo? Kasi if ever guys, huwag ka na lang bababa or else na ikaw din later ang mapapahamak. So aside from that, we have the mechanism of injury. So we have the mechanism, okay, of, ayan, injury. Aside from the mechanism of injury po, so we have the nature, okay, of illness. And nature of, okay, illness guys. Pag sinabi po natin nature of illness kasi, let's say ganito. Sa dispatch, sabi niya, ayan, so we have a patient, okay, tapos i-approach mo daw yung patient na yon. The patient, guys, biglang naging unconscious, pero may history of travels. So anong i-expect mo? It might be suspected what? COVID patient. So pag may suspected ka, guys, okay, na COVID patient, na malamang na you need to detect, di ba? You need to isolate, and then you need to report. Usually may technique yan, known as the DIR. Detect, okay, isolate, and then you need to report. Anong i-detect mo, sir? I-detect mo, right? 1 meter away from that patient, na-unconscious ang patient. Tapos, ayan, tinanong mo ang what? Na ang kanyang, let's say, guardian, or let's say, yung friend niya. Ayan, may mga travel history ba to? Ayan. Basta, sir, bigla na lang siyang bumulagta with shortness of breathing. Tapos, may fever kasi siya, sir, eh. Tapos, may history of travel. Okay, so we need to isolate and then you need to report. So, we have a suspected, okay, COVID patient pa. So, the nature of illness kasi, guys, na is highly relevant now para maprotektahan mo din yung sarili mo. Now, itong mechanism of injury naman, is it a blunt trauma ba? Is it a penetrating trauma? Kasi pag blunt kasi, mas malaki yan ang impact na may energy. Ayan, let's say mga motor vehicular collision, yan, mga mechanism of injury, usually mga blunt trauma yan. No? Nasagasaan, blunt trauma. Pero pag penetrating kasi, mga maliliit yan, tapos biglang, let's say, na-puncture, yan, may penetration, may open wound ka, ang tawag doon penetrating. So we have the nature of illness. Aside from the nature of illness, guys, ayan, sir, we have the number of patients. So that natin. So we have the number, ayan na, of, okay, number of patients po. Ilan ba ang patient natin dito? Is it a mass casualty ba? So the question is mass, ayan, casualty. Ayan, kasi pag mass casualty yan, guys, malamang kulang, baka kulangin kayo, na yung mga personals po natin, baka kulangin. So aside from, okay, the number, okay, of patients po, ayan, we have to what, na consider. Ayan, you need to, okay, consider additional. Ayan, additional what? No resources din po, right? Additional or specialized. Ayan, specialized okay, resources po natin. Na, ayan, especially yung mga C-collar, the collar, ayan, ayan, braces, neck braces po natin, or the C-spine, the C-collar, okay, neck braces natin. Pakulangin yung mga spine board po natin, guys. Ayan, so, basically, ayan, tapos na po tayo sa topic known as the scene size up. So, again, ito yung first, okay, na, i-reconsider, kailang i-consider rather, not i-reconsider, but rather, i-consider mo dapat na as your priority assessment, known as the scene size up, that usually begins with protection, right? The PPE, the BSI, right? The scene safety, the mechanism of injury, whether if it's blunt trauma ba, penetrating trauma ba, the nature of illness, may history ba to ng travel? Kasi kung may history, malamang COVID nga ang patient na to. Kasi guys, 'di ba, sa ngayon, sa era kasi ngayon, pag umubo ka lang, COVID agad, right? Nilagnat ka lang, COVID agad, 'di ba? Kaya nakakatakot kasi parang ubo now, abo later, right? Yun yung mga nangyayari na. And then mahirap din kasi especially in our part, especially for those who are working sa hospital, pag nilagnat ka, Diyos ko Lord, paranoid ka na, sobrang paranoid ka lang. I have friends po guys na syempre negative po at first, tapos hindi nag-ingat, na nag-duty, tapos na-expose na naman sa virus. So ayun po, on the second test na, ay nag-positive na po ang friend ko po sa EMS din, na responder din. Pero ano naman siya, okay naman na siya ngayon din. Na ang problema niya na lang ngayon is, syempre na-quarantine, sobrang tagal ng quarantine guys, ayun, hiniwalayan siya ng jowa. Na? So mas masakit yun compared sa COVID, right? Ang may walay sa jowa at hiwalayan din ng jowa, okay? So we are done now with the scene size up. So what's again the next topic guys? Yung sinulat ko po kanina. And that's your, what? Yung second po natin, guys. And that's your number 2. Ay, yung sinulat ko. And that's your, ayan, number 2. Ayan, sulat natin. And that's your, the what? Now, the primary assessment. Ayan, introduction pa lang to ulit, ha? So, we have the primary, ayan, assessment. Now, when we say primary assessment, guys, this is basically the general impression sa isang patient po natin. This is the general, ayan, impression. Now guys, if this is the general impression, You can actually determine whether the patient is conscious ba or unconscious ba ang patient natin. Ayan, so the general impression. Next, you need to introduce yourself. Ayan, introduce, okay, self. Hi, sir. I am Mark Adlawan. I will be your EMS, okay, provider. I am here to help. Na? Ayan, or simply, ayan, base, pwedeng patagalog din. Ako po si Mark Adlawan at ako po itutulong sa inyo. Na? Ayan, aside from introducing self, guys, do we need privacy here? Do we need privacy? Ayan, not totally privacy because the privacy, and mamaya na yan sana sa exposure. But again, guys, na patients what? Cooperation. Ang importante dito. Ayan, kasi if the patient won't cooperate, guys, that will be what? A different problem. Na? And okay na lang sana na ang patient is unconscious para at least dire-diretso ka. What if the patient is what? Conscious pala. Ayaw niya magpagalaw. That's another problem. So how do you handle that? Na? So again, guys, you need to what? Na provide consent then. Ayan, so you need to introduce yourself. Na? Dapat may consent din. Especially on the C-spine. Na? Kasi maglalagay kasi tayo ng the cervical collar spine po natin. So, pwede mo sabihin, if ever kung patient is what? No conscious, sir, maglalagay po kami ng C-spine. Na? Tapos, ayan. Aside from that, we have the mental status. Ayan, of the patient. Guys, kamusta ang patient mo? On the first scene pa lang, pag sinabi mo, nung nag-introduce ka, sir, I am Mark Adlawan, I'll be your EMS provider po. Nung sinabi niya, at lumingon ang patient mo, okay. Ayan, so, conscious ang patient po natin. Pero what if ang patient mo, guys, upon approaching at the scene po, si patient is what? Na? Hindi naman siya nakadilat, na? So, malamang tulog ang patient. Tapos minsan, guys, may mga agonal gasping pa yan. Ano ba yung mga example ng agonal gasping? Look at me. Ganito usually agonal gasp po. Unconscious ang patient, may motor vehicular accident, tapos biglang gagana. Ayan, so may mga agonal gasp. Nangyayari po yan on a motor vehicular accident, which is really common po. Right? Ayan, i-share ko lang ha. My father kasi died brought about by motor vehicular accident. It's kind of traumatic on my part. Na? And then whenever, guys, let's say I'm in Davao City, ayan, yeah, pero I'm totally based din kasi sa Manila. Na? So, conducting lectures po, like, let's say for NLE, for NCLEX, na? For the Btls, the ACLS, the ACG Pharma, and I'm more of sa Manila na din po. So, whenever I got a chance na to witness let's say mga motor vehicle accident, ayan, ang ginagawa ko na lang po pag nasa Davao, guys, ay nagda-dial na lang po ng number. Kasi di ba may mga dial po natin, may dial po tayong numbers, usually 911. Na? Ideally, it should be 911. So, pag tawag ko, guys, ayun lang, nare-report ko lang kasi ayaw ko namang lapitan. Kasi parang it brings back na all the terrible memories na yung mga traumatic na mga events din, especially with my father po. Na? So, usually, nagda-dial na lang ng number 911 tapos i-report mo na lang yung said scenario. Okay? Ayan, so we have the mental status of the said patient. Ayan, guys, for the men, kaya careful po, especially sa mga nagmomotor. As we all know, in Bicol, guys, very common po yung pagmomotor nyo dyan. Na, dobling ingat po. Kasi, syempre, mas masarap po mag-drive, lalo na paglasing. Ibang drive naman yon. Na, baka hindi motor ang ida-drive natin. So, we have the mental status. Next, we have the LOC, di ba, the level of consciousness of your patient po. Now, are you familiar, guys, with the mnemonic AVPU? Ayan, kasi may encounter po natin ang mnemonic na AVPU. Sir, ano ba yung mnemonic na AVPU? Sulat lang natin ha. So, when we say AVPU, sige nga, kaya nga, everybody say AVPU. Okay. Ayan, letter A4, is my patient alert? Is my patient verbal ba? Let's say, nag-introduce ka. Okay, let's say, sir, na, nung pag-approach mo pala kay patient, bigla siyang lumingon sa'yo, malamang alert po patient natin. Ayan, pag verbal naman po, good morning, sir. I am Mark Adlawan, your EMS provider. I'm here to help. Sabi niya, okay. So verbal, yes, nakapagsalita ang patient natin. Pag hindi naman po, pwede ka mag-inflict ng pain. But again, guys, the sternal rub is somehow an issue now. Pwede ka namang mag-pinch kay patient. Huwag mo namang i-punch. Na? Pinch is okay. But sternal rub kasi, that can cause, a rib fracture. So from rib fracture, baka magkaroon ng tension pneumothorax ang patient natin. So that will be another problem. So pag nag-introduce ka ng pain, pwede naman mag-pinch ka lang. Or pwede sa kamay ni patient. Di ba, ma'am? Ma'am? Ayan. Or basically, pag wala talagang response ang patient natin, so we have the unconscious patient, guys. Okay? So we have the alert patient, we have the verbal, we have the responsive to pain, and then we have the unconscious patient. Anong mnemonic natin, guys? And that's the mnemonic of who. Okay? Ayan. So on the primary assessment po, we have the general impression. Is my patient awake? Is my patient conscious? Is my patient unconscious? Kasi pag unconscious yan, check for pulse, check for breathing. Diba? Pag unresponsive ang patient, proceed with high quality chest compression. Ayan. Pero pag conscious naman po, you introduce yourself to your patient. Diba? Ayan. Tapos pag okay si patient, you what? You provide consent. Na? And you ask for consent also, ma'am. Can we what? Can we put the C-spine? Because the spinal immobilization, guys, is what? No? Highly important talaga siya eh. One of the priorities lang din, aside from the vital signs, aside from maintaining the airway, breathing circulation, there should be spinal immobilization. Kasi as part of our training din kasi, the importance ng tinatawag na the neurologic assessment, di ba? Because there's a saying goes na, pag may high spine ka, let's say na na-affected po yung high C-spine mo, di ba, yung C3, 4, and 5, to keep the diaphragm alive, kailangan daw protektahan si C3, 4, and 5. So yun yung parang rhyme eh. To keep diaphragm alive, meaning functional, so you need to protect your C3, C4, and C5. Okay? So C3, 4, and 5 to keep your diaphragm alive. So meaning para pag para pag guys, pag okay yung respy efforts natin, yung respiratory mo, dapat protektahan mo yung mga C-spine. Kasi pag si C3, 4, and 5 nagka-problema, expect for what? Respy failure later. Okay? Ayan. So aside from the mental status, the level of consciousness, so let's proceed na po sa mga important topics natin under the primary assessment. Then what are they? Are you familiar with the airway, the breathing, the circulation, guys? Next, ito bago, the rapid scan of the patient. Next, we have your letter D, and then we have your letter D, and then we have your letter E. Bakit daw A, B, C, R, D, D, E? Ayan. When we say A, B, C, R, D, D, E, ito yung latest po. Okay, na protocol. So number one, we have the airway. Ayan, kamusta bang airway ni patient, guys? Is it patent ba? Can you open the airway? Ayan, kasi if the patient talks po, meaning to say, walang obstruction po sa airway ni patient. Pero kasi if the patient cannot phonate, or let's say if the patient cannot talk, then expect for what? Baka may bleeding, baka may airway obstruction po si patient, or baka mismo ang dila ni patient ang naka-obstruct kasi na-stroke pa lang patient natin. Okay? Next, we have the letter B, the breathing. Ayan, kamusta ang breathing ng patient natin, guys? Na usually breathing kasi that talks about the oxygenation eh. Na? Ayan, kasi pag circulation, perfusion naman yan. Na? So pag breathing naman po, guys, it talks about kamusta ba yung oxygenation ni patient? Kaya dapat po na you check for the RR later, na? And dapat meron kang yung guys, yung mga pulse oxy po natin, yung mga Bluetooth po, right? You have the wireless, di ba, ng mga O2 sat po natin, and or the pulse oxy, na oximeter po natin. Next, we have the circulation. Ayan, kamusta kaya ang circulation ng patient po natin? Na aside from the circulation, guys, we have the rapid scan. Ayan. Pag sinabi po natin rapid scan, that usually takes place for about 60 seconds dapat ito. Ayan. Within 1 minute dapat, na-scan mo dapat ang patient. Na it should be from head to toe dapat, as in like mabilisan po dapat yan. So next, we have the decision making. Ito, guys. So we have the decision making. Ayan. So decision making naman po natin, pwedeng stay and play. Ay, gusto natin to. If you want to stay, then you need to play. Meaning to say, if you want to stay, then you need to manage the patient dapat. Or if ever that requires immediate management pa na hindi mo kaya, then you need to what? Load and go. So you need to transfer the patient, guys, sa longboard and go na po. Right? And so, depende yan. Ayan. So, next, we have the letter D, the disability. Guys, paano ba mag-check ng disability? Of course, you're going to check din kasi for the pupillary reaction. Now, pupil. So, here for the pupil. Ayan, reaction po. Next to pupil reaction, guys, you have the GCS or the Glasgow Coma Scale natin. What's the perfect nga ulit? It's the 15, di ba? Pero pag GCS of 3 ka na, guys, ayan, meaning to say, pangit na po ang GCS mo, you are what? Comatose. Na? Ayan, next, guys, we have the exposure. Ayan. Next, we have the exposure, or basically expose mo ang patient natin. Na? Ayan, para kasi makaperform ka ng tinatawag na okay, the head-to-toe assessment po. Na yun yung pinaka-crucial din na part. Guys, so we have the airway. Next, we have the breathing. Next, we have the circulation. Next, we have the rapid scan for about 60 seconds dapat. Mabilisan dapat yan. The decision-making kasi, ayan, na there should be a treatment na dito eh. Na? So you need to treat the patient and then you transfer the patient po, okay, or load the patient sa isang long board na, yung spine boarding po natin. Yan, sa decision making, okay, dapat sa ano pa lang guys, sa rapid scan pa lang guys. And na-scan mo na ito lang kailangan ni patient, pwede ka mag-treat na doon. Pwede ka mag-treat na, sir, pwede ka ba mag-intubate? Ganito. That's the issue now. If ever guys, kung paramedic ka, yes, you can intubate. But, okay, if nurse ka ng isang hospital, tapos ikaw lang ang pinadispatch kasi malapit lang sa hospital niya, tapos kayo yung tinawagan guys na hospital, ayan, ikaw yung ambulance nurse, then you're not allowed to intubate. Only if you're a paramedic. So, sino ba yung mga allowed mag-intubate? Number 1, physicians. Diba? Next, yung mga ER, okay, MDs po natin, or mga doctors in the na emergency, okay, room. Ano pa? Yung mga ano po natin, guys, diba? Mga paramedics po natin, they are allowed to intubate. Na? Pero, kung ano po, let's say, ikaw na nurse, ikaw ng paramedic, so nag-intubate ka, so hello intubation today, hello jail tomorrow. Na? So malamang guys, di ba kakasuhan po tayo. Ayan, kasi it's part of what? Na the malpractice kasi. Nurses are not allowed to intubate, but only the doctors po. So we are allowed to what? Na to assist the doctor. Kung gusto mo talaga mag-intubate, pwede mag-med ka. Na? But sa states, guys, yes, they're allowed to intubate, especially if you're an ACLS trained provider. Na? So sa mga ACLS po natin dyan, yung mga nakapag-training, especially with rapu-rapu, na sa mga nurses po natin sa tabako, di ba? Yung mga nag-intubate po, especially during our lecture po. Yeah, lalo pag certified po. Depende din depende din yan guys sa hospital. Kasi, atin natin lang ha, char. So, sa Davao po, may sikat na hospital doon. Ayan, and nurses are allowed to intubate. Kasi, ganito, sa ER na yun guys, it's a government hospital. Kasi like sobrang dami ng patient. Kasi like even doctors na po ay nahihirapan na kasi, di ba, the doctor, okay, ratio. So, pag senior nurse ka doon, pwede ka mag-intubate. And then, ang updates po kasi ngayon, especially for the 911 responders ng Davao and in Manila din, alam niyo ba na magpa-paramedic level na po sila. Kaya yung friend ko guys, nakasamahan ko din na trauma instructor din, ay nasa US ngayon, nag-train for the paramedic para siya mag-train din ng paramedic level sa 911 po sa Davao. So, anytime this year, pwede na silang mag-intubate. Diba? So, yeah, fulfilling din talaga sa part na yon. Lalo na kasi ngayon guys, as part ng Btls protocol kasi, based on the 2020 guidelines pero wala pang COVID issues nun. Rapid intubation is para mas successful daw ang BLS. Yun yung based on the 2020 updates. Pero wala pang COVID nun. So, pagpatak ng 2020, ang sabi ng American Heart Association, it should be high quality chest compression, defibrillation plus rapid sequence intubation para mas maganda po ang let's say prognosis ni patient. Pero nung nag-start na at pumasok na po si let's say si COVID, syempre guys, natakot na lahat mag-intubate. Di ba? Sabi nga natin, once you intubate a patient kasi, para mabuhay ang patient. Pero ano nangyari ngayon? Once you intubate a patient, kamatayan na po ng mag-intubate. So, mas nakakatakot ngayon. Okay? So, aside from the rapid scan, decision-making, whether you're going to stay and then you play, guys, when you play, hindi ka maglalaro but rather you're going to what? Reassess pa ulit the patient, di ba? From primary assessment, and then you're going to perform the secondary assessment, di ba? Yung sample, yung mga silent symptoms, yung mga allergies. So you're going to interview the patient now. Yung mga history takings po tayo doon. Okay? And to be exact. So, pero pag kailangan niya ng immediate management, guys, it should be a load and go. O ganito. Ang nangyayari kasi ngayon, guys, sa EMS po, and minsan na lang po, nag-stay and play. Ba't mo pahihirapan ang sarili mo? Diba? Pwede mo namang i-refer na agad yan. Kaya bihira lamang po na nangyayari ang load and go. Depende din kung sobrang skillful ka, sobrang confident ka. Let's say may hemorrhage po ang patient natin, nag-apply ka ng direct pressure, di ba? Tapos aside from that hemorrhage pala, ang patient mo pala guys is suffering from tension pneumothorax. If you want to stay and play, then you're going to na insert, di ba? At the second intercostal space, mid-clavicular line, yung tinatawag na mga needles po natin. And that's your the direct needle aspiration, guys, or needle decompression, especially for my signs and symptoms of the tension pneumothorax. But we will be discussing tension pneumothorax later pa po. Okay? Ayan, next we have the disability. For the disability, guys, ayan, usually ang question po natin dito, di ba? Approach the patient na, ma'am, can you squeeze my hand? If no response po ang patient natin, then the patient's GCS is 3. Alam niyo ba, pag GCS 3, malamang comatose ang patient. Pero based on the GCS, guys, kailan ba tayo usually nag-intubate ng patient? If the GCS is below 8. Now, if the GCS is less than 8, guys, that's the best time for you to intubate the patient. There will be a separate discussion, guys, on the intubation later. Ayan, pero kasi dapat, di ba, naka-full gear ka dapat pag nag-intubate ngayon. Kasi sobrang andami dapat na nagagamitin po. Next, we have the exposure, and then we have the environment, guys. When we say exposure naman po, ano ba ang pinaka-issue dito? Of course, the privacy. Pero kasi, guys, a battle between privacy and the and the general assessment of the patient head to toe, anong pinaka-importante sa'yo? Is it the privacy or the na assessment talaga? Kaya nga ang disability and exposure, lagyan ko lang ng star at saka ng asterisk po. The disability, guys, and the exposure, po ito highly masyadong issue to Kasi for the disability and exposure, depende na lang po yan. And this is not the priority. So hanggang decision making ka lang. Kasi if ever kung stable naman ang patient mo, then yes, then you can proceed with disability, you can proceed with exposure, with the general assessment pa kay patient. Pero kasi highly controversial to Kaya ang mga magagaling po na EMS, guys, hanggang decision making. Kasi load and go, okay, ilagay na sa ambulance, and then let's load, and then you go na you proceed na, you dispatch na sa isang hospital po. Right? Or isend mo sa isang hospital, that handles trauma patient. So ulitin ko lang, pag gusto mo talaga magtagal, then you proceed with disability, you proceed with exposure, or the environment din ng patient. Pero kasi sa exposure pa lang, guys, what if nagkaroon ng hypothermia ang patient? So it's another problem, right? So, sa mga magagaling po na EMS provider, guys, hanggang decision making lang sila. You load, and go. Or stay, and then you play. Okay? Ayan. Now, aside from the primary assessment, another assessment also, guys, will be the history taking na. Ito yung mga diniscuss ko lang kanina, guys, ha? So we have the history taking. Paano ba mag-history taking? What is the chief complaint? Ayan, chief complaint of the patient. Ano bang chief complaint niya? Ano ba yung tinawag sa iyo? Ano ba yung nirelay sa iyo ng dispatch? Sabi kasi ng dispatch, so we have a patient, na, ayan, who suddenly collapses. Okay, no pulse, no breathing daw. Tapos, ayan, nasabi din ng may fever daw kasi ang patient prior to that. Tapos may pa, meron pang travel history. So malamang, alam mo na kung ano ang chief complaint ng patient. And you will assume na, ano kaya ang sakit ng patient? Okay. So kung may travel history, guys, malamang, wala lang ibang sagot doon. Okay? Ayan, sige po. So, basically, pag sinabi po natin history taking, these are the focus, okay, medical, okay, what, na mga assessment po natin sa CHAS, okay, the sample. Ayan. Ano bang ibig sabihin ng sample? Letter S, A, M, P. Letter L, and then we have your letter E. Anyone guess for, okay, letter S, guys? So we have the signs, okay, and then we have your, okay, the symptoms po. What are the signs and symptoms ba? Na? Guys, usually nagpo-proceed lang tayo sa sample only if you have a conscious na patient. Right? Pero pag unconscious naman po ang patient, malamang hindi mo na siya i-interview, 'di ba? Ayan, so we have your the silent symptoms. Next, we have your pag conscious ang patient natin. Ayan, allergies. Okay? I-ask mo si patient, ma'am, may mga allergies po ba tayo sa pagkain? Ayan, sa food? Ayan, no? Or let's say sa medication, para at least guys, magbibigay ka ng epinephrine. Diba? Let's say may mga allergy pala siya, and then ang patient mo, nagkaroon ng, okay, so anaphylactic shock pala to. Okay? Or let's say before nag-shock ang patient, nagkaroon mo na ng anaphylaxis. So therefore, okay, to prevent anaphylactic shock, then therefore, diba, what's the drug of choice for anaphylaxis na ulit? Or anaphylactic reaction, it's basically the bronchodilator of choice, which is the epinephrine. Now, sa States kasi guys, may tinatawag po na EpiPen or epinephrine pen, which is actually costly. Na yun lang, in-IM lang nila for 10 seconds po. Right? Ayan, especially kung may mga allergies. Next, we have the medications. What was, okay, the latest or the last drug na ininom ng patient po natin? Okay? Next, so we have your letter P. What are the past, okay, medical history? Ano ba ang medical history ng patient na to? Guys, ganito. Sa past medical history kasi, alam niyo ba one of the assessments din is to check the glucose level? Kasi bakit na-aksidente ang patient? It can be brought about by what? No? Hypoglycemia. So baka ang patient nyo, no, ay may diabetes. Right? Kasi I have this friend po, babae guys, ikakasal na sana siya eh. Dapat kinasal na siya last December. Alam niyo nangyari? Namatay po siya 3 months before siya ikakasal. Kasi sa Dubai actually nangyari. No, not sa Dubai but rather sa Saudi. Ayan, kasi 'di ba hatid sundo doon. So ayun guys, car crash actually nangyari. Tapos dalawa sila Pinay na naaksidente. Kasi yun pala guys, a 95-year-old male patient drove along the highway. And then yung patient na yun daw guys, is having parang nagkaroon ng hypoglycemia. So, nag-hypoglycemic attack si patient, nawala ng consciousness, hanggang sa yung speedy talaga, as in like over-speeding pa. So, na-crash sa kanila. So, dead on arrival, dead on the spot talaga yung friend ko. So, nakakasad lang. Kasi, okay pa sana eh. Kaso kasi, ayan, syempre, alam mo, kahit gaano ka-careful na mag-drive, pero yung diba? Ayan, ka-decide mo ng direction, guys, is syempre nagkaroon ng problema, then, yeah, so pag-time mo na din talaga. Ayan, so we have here the letter L, so we have here the last. Ayan, the last meal. Ayan, what was the last meal ba? Ano ba yung pinaka-last, okay, intake mo? Last meal or last, okay, oral intake? Ano ba yung kinain mo kanina? Depende sa kinain mo, na kung pagkain ba yon or whatsoever. Basta may kinain ka. What was the last meal taken? Or let's say, letter E, event. Guys, when we say event, ano ba yung mga mag-predispose nito? Ano ba yung factor? Ano ba yung mga activities na I am referring to activities kasi eh. What are the activities, okay, prior to this, okay, scenario? Okay? So, ulitin ko lang. What are the signs and symptoms? Tanungin mo. Ayan, only if conscious ang patient natin, guys. So, we have the allergies. Ako, honestly, may allergy ako sa itlog. So pag may allergy ka sa itlog, malamang, okay, bawal ka sa chicken, na? Ayan. So we have your, syempre, saan ba manggagaling ang chicken? Malamang sa itlog, di ba? So we have the medications. Next, we have your, okay, the past medical history. We have the last, okay, meal taken or last oral intake. Ano ba ang what? Ang kinain ng patient natin. Ayan, next, we have the events, okay, or activities. Ano ba ang nag-precipitate nito? Ano ba ang nag-trigger, okay, sa scenario na to? Ba't nagkaganito si patient? Na? Ayan. So we have your, aside from the sample history, guys, ayan, we need to determine pain also. Ayan. Everybody say pain. Siyempre, pag pain kasi, di ba, we have different thresholds din kasi, di ba? Yung iba, para sa iyo hindi painful, pero para sa akin, sobrang sakit na. Tulad nung ex ko, guys, sobrang OA lang, hindi naman gwapo. Pero anyways, ex na nga, na isang kurot lang, like, sobrang mag-i-exage na siya sa pain niya, na? Ayun, kasi kung sino pa yung pangit, yun talaga yung mga maarte, right? Ayun, kung sino yung mga magaganda, sila yung mga, alam mo na, sanay na pong masakta. Anyway, so we have your, yeah, pain. Na, so sa mga taga-Rapu-Rapu, ayan, di ba, the last time I went there, syempre, blooming pa yung love life ko. Pero all of a sudden, na parang nawala, na mas okay na yun. At least na mapupunta tayo sa tamang tao, right? Sa tamang panahon. Na, ayan, anyway, so we have the pain. When we say pain,
Hugot.
ay, hugot pala yun, ma'am. Ayan, so we have the pain, guys. So basically, pag sinabi po nating pain, ayan, it's more of the what? Subjective or objective? Is it subjective or objective? Anyone? It's basically what? Subjective. Na? And if that's subjective po, ayan, syempre, iba-iba talaga ang level ng pain thresholds po natin. Now, if that's your pain po, then definitely, I have my mnemonic po, known as your, the O-P-Q-R-S-T. Ayan, O-P-Q-R, ayan, S-T. Now, guys, when we say O-P-Q-R-S-T, these are, okay, the sample questions din kasi. If you want to know, kamusta ba ang pain ng patient natin? Number one, we have the word onset. Na? When did it begin? Kailan ba siya nag-start, ma'am? For how long? Diba? Ganito yung mga question eh. When nag-start, ma'am? For how long kaya, ma'am? Na? So may mga onset tayo ng pain, guys. Next, okay, we have your what? Na the provocation. So we have the provocation. Ma'am, what provokes? Na? Ano ba ang nag-provoke, ma'am, ng what? Ng pain na to? Next, we have the quality. Ma'am, is it stabbing? Ayan, is it stabbing ba? Is it crushing? Ayan, na, is it stabbing? Okay, is it stabbing? Is it crushing pain ba? Na? Is it excruciating pain ba? Is it radiating? Ito na, letter R for radiation. Ayan, ma'am. Ayan, ano bang exact location, ma'am? Na? Location. So we have your ayan, location. Sulat ko lang ha. Ayan, saan kaya siya nag-radiate, ma'am? Palikod ba? Padjaw ba? Ayan, so we have the location. Ayan, ang pain natin. Ang pangit na handwriting ko. Char, ngayon ko pala napansin. So we have the location. So aside from the radiation, so we have the severity. Ma'am, on a scale of 1 to 10, how would you rate your pain? And so we have the word severity. Ayan, for a while. Ang pangit na handwriting ko. Ayan, the word, okay, severity. Na? Parang wala naman nagbago. So we have the 1 to 10. So tanongin mo, ma'am, on a scale of 1 to 10, how would you rate your pain? Sabi ng patient mo, 15. Ma'am, bobo ka ba, ma'am? Ang sabi ko, 1 to 10 lang. Pinahirapan mo pa ako. Na? Pero kasi guys, na, if the patient, okay, tell you to what? Na, let's say, sabi niya, 15 naman talaga, nurse eh. Na? So meaning, you need to accept that. Kasi 'di ba? Syempre it's subjective eh. Na so meaning sobrang in pain talaga ang patient mo. And are you aware na ketorolac po ang pinaka-best, 'di ba? Na mga narcotic na ibibigay ngayon, guys, na especially pag may mga pain po on the emergency setting. It's basically the ketorolac. Ayan, next we have a letter T. Na so we have a letter T known as your anyone. And so we have the severity and then we have the timing. Ayan, ilang minutes ba? Okay, ang pain na to, ma'am. And then lastly, guys, PQRST, may bago po, and that's your the letter U. So we have the understanding. Ayan, so you need to understand din. Na, Ayan, ma'am. Ayan, ganito ang pain po natin, ma'am. Understanding, okay, for, okay, treatment po. Kasi explain na po natin kung ano yung mga gagawin po natin kay patient, guys. Okay? So again, so we have the, okay, OPQRST. So we have the onset. Next, you have the provocation. Ano ba nag-provoke nito? Next, you have the quality. Is it stabbing? Is it excruciating ba? Is it crushing? Ayan. Next, we have the radiation. Nag-radiate ba siya sa jawline mo? Or nag-radiate ba siya sa likod mo? Next, you have the severity. On a scale of 1 to 10, how would you rate your pain? Next, for the timing. And then we have the understanding, okay, for the said treatment. So, we are done na po, okay, on the said, what the topic to na sure the history taking, guys. Now, aside from, okay, the what? Now, aside from the history taking, now let's proceed now with the secondary assessment. Ayan, secondary, ayan, assessment po tayo. Ang secondary assessment ba, pang-apat na ba? Yes, kasi since size up. Next, okay, we have the primary assessment. Next, you have the history taking. Ito na po. Ayan, pang-apat na pala to. Okay? Anyways, guys, ayan, lahat po ng ito ay recorded po. So, pwede kayo mag-ask, okay, for the recorded, okay, video, or the recorded discussion. So, pag sinabi po nating secondary, okay, assessment, ayan, ano bang naiisip nyo, guys, pag may word na secondary assessment? Siyempre, dito na magsa-start ang tinatawag na what? Na you need to know whether the patient is conscious or unconscious din. Di ba? Kasi sa secondary assessment po, okay, you're going to obtain vital signs na. Okay, obtain vital signs. Ayan. Included po dito ang tinatawag na the glucose. Okay, so we have the glucose level. Kasi nga sabi ko, di ba? Ayan, baka, okay, na ano po, one of the precipitating factor pala kung bakit nagkaroon ng aksidente ang patient mo is that masyadong baba ang kanyang glucose level. Kaya bigla siyang nawala ng malay. Kasi may DM pala ang patient natin. Tulad ko lang. So we have the glucose level. Okay, next we have the O2 saturation. Matanong ko lang, guys, what's the normal O2 sat? What's the normal O2 sat? It should be 95 to 100%. Di ba? Pag less than 94% po, this is the best time for you to give the O2 therapy. Magbibigay na po tayo ng O2 therapy. Ano yon? Pwedeng nasal cannula. Ayan, nasal cannula po. Aside from nasal cannula, guys, we have the simple face mask. And then we have the non-okay rebreather mask. Now, this should be properly regulated based on the American Heart Association. For the nasal cannula, 2 to 4 liters per minute dapat yan. Next, pag simple face mask at 6 to 10 liters per minute. Next, okay, we have the non-rebreather mask. Okay, it should be, okay, regulated at 11 to 15, okay, liters per minute pa. Diba? Ayan. So, pag less than 94%, pero pag ang O2 sat mo, guys, less than 84%, or GCS, okay, less than 8, ayan, GCS, less than 8, this is the best time. Sulat natin ang maayos. Ayan, GCS, less than 8, this is the best time for you to what? Intubate the patient. Ayan. So, maririnig nyo always ang word na what? Na intubation dito. Okay? So, we have okay, secondary assessment, obtain vital signs. Ayan. Example, lost na. Aside from vital signs, ano ba yung mga example ng vital signs natin, guys? We have the secondary assessment, guys, you need to obtain, okay, what? A quick din, okay, na vital signs po natin. So basically, that goes along with the temperature, the RR, the pulse rate, and then we have the BP ng patient natin. So, you include also, okay, the glucose level. Kailangan, kasi baka hypoglycemic pala ang patient natin at ito yung reason kung bakit pala na-aksidente ang patient natin. Now, aside from that, okay, you check also for the O2 sat, whether kailangan na bang intubate ang patient or hindi mo na i-intubate. Na? Ayan. Pero pag less than, okay, 94% naman, guys, may mga options po tayo. Pwede kang magkabit ng nasal cannula, simple face mask. And then we have the non-rebreather mask. Pag nasal cannula po, 2 to 4 liters per minute, ideally based on the American Heart Association. Pag simple face mask naman, 6 to 10 liters per minute. Tsaka pag non-rebreather mask, we have the 11 to 15 liters per minute. Pag less than 84%, intubate the patient. Pag less than 8 ang GCS niya, you intubate the patient also. But again, are we allowed to intubate? Depende po pag paramedic level na po tayo. Guys, on the unconscious patient, you need to have the full body scan. Ma'am, nakikita naman ma'am na? Ma'am Joy?
Yes,
Ayan,
sir.
Yes,
ma'am.
sir.
Yes, ma'am. Nakikita naman ma'am no, ang screen sharing, ma'am.
Yes po.
Yes po.
Ayan, sige po. So we have the full body scan. Thank you. So we have the D-cup BTLS. Ito na yung always nating maririnig po. D-cup. Ayan, BT. Ayan, D-cup BTLS. Iba naman yung BLS, iba naman yung ACLS, guys. Ayan, pag sinabi po natin D-cup BTLS, it's part of the what? No, full rapid trauma assessment. Ang tawag dito, these are your, okay, the rapid, ayan, trauma. Ayan, rapid trauma, okay, assessment, guys. Pag sinabi mong rapid trauma assessment, D-cup, BTLS, D-cup, BTLS, D-cup, BTLS, you're going to check for letter D. Number one, you're going to check for, okay, deformities. Ayan. Are there any deformities po? Next, you're going to check for letter D, in discoloration. Diba? Check for the discoloration, especially on the what? On the said circulation kasi. Is it bluish ba? Is it pale? Is it perky? Is it pinky? Perky or pinky, guys? The same lang yan. Next, we have your, ayan, the contusions. Ayan. Next, we have the letter A, may mga abrasions po ba tayo? Ayan, we have the word abrasions. Ayan, or laceration. Huh? Or scratches rather. No? Scratches. Kasi abrasion, scratches yan. Next, we have the letter P, the puncture. Ayan, kung may puncture po ba tayo? Ayan, pag wala pang word na puncture, guys, hanapin mo ang word na penetration. Ayan, may mga penetration po ba? Okay? So aside from puncture, penetration, we have a letter B. So we have the burns. Ayan. May burns ba tayo? Kasi pag burns kasi, ayan, pwedeng inhaled, di ba? Pwedeng thermal injury. Na? Ayan, next, we have your letter T. Okay, for your letter T, guys, ayan, we have the tenderness. Ayan, aside from tenderness, next, we have the word lacy, okay, the lacerations. And lastly, we have the word, okay, swelling. Okay? So, ulitin ko lang. If, what? No, on the secondary assessment, guys, tapos ka na mag-check ng tinatawag na, let's say, obtaining vital signs, pero ang patient mo pala is an unconscious patient, then therefore, okay, you need to, okay, what? No, have your the full body scan. Ang tawag doon the rapid trauma assessment, known as your the D-cup BTLS. So, paano ba mag-D-cup BTLS? Unahin mo muna the head-to-toe assessment, di ba? Are there any deformities? Na? Or let's say, no D-cup BTLS. Na? Tapos, ayan sa likod na naman, no D-cup BTLS. Pero pag may nakapaka, tapos may bleeding sa what? Under the nape of the patient, then, na? Okay, present na po ang D-cup BTLS. So, dapat may proper management po tayo. If there's a bleeding, you need to what? Apply direct pressure dapat. So, D-cup BTLS, nasa chest na naman, pababa, na? Hanggang sa aabot po tayo sa mga what? Na sa mga areas, yeah, na that means what? Privacy din. Huwag mo namang i-expose ang genitals ng patient mo. No? Porn yon, pornography na yon, hindi na yan what? Not rapid trauma assessment, guys. Diba? Ayan, wag mo naman matagalin yung pag-expose kay patient kasi that leads to hypothermia. It's another problem. Diba? And so we have the D-cup BTLS only for unconscious patient. Anong tawag ulit dito? The rapid trauma assessment. Letter D, may deformity ba? May dislocation ba? May fracture ba ang patient? Or discoloration rather, guys. Not dislocation, but rather, ayan, discoloration. Deformity, pwede rin, okay, dislocation, di ba? Ayan. Next, we have the contusion. Ayan, we have the abrasion, the puncture, penetration, the burns, tenderness, laceration, swelling. These are the rapid trauma assessment. Next, we have the conscious patient po. Pag conscious patient naman, guys, ayan na, syempre, di ba, nakapagsalita ang patient. So, you proceed with the sample. Familiar? Ayan, D, O, P, Q, R, S, T, U. Di ba? Ayan, proceed if ever kung conscious po ang patient natin. Basta ang pinaka-importante, guys, on the secondary assessment, the priority should be if ever kung stable ang patient mo dito, you need to continuously monitor the patient, okay, every 15 minutes pag stable. Pero pag unstable po ang patient natin, guys, it should be Q 5 minutes dapat. No? You reassess the patient dapat. Ulitin ko lang, pag stable si patient, every 15 minutes. Pero pag unstable po ang patient natin, it should be ayan, mas grabe po yung na pag-reassess ng patient natin. So we are done na po with the secondary assessment. Ma'am Joy? Nakikita naman po, ma'am?
Yes po.
Yes po.
Okay. So let's proceed na po. Okay, sa next topic po natin, guys. Okay, known as your. Ayan, this will be the last topic before our break po. And so we have your assessment. So recap lang ha. Kanina po, nag-discuss tayo ng physical assessment, guys. Okay, di ba? We have the scene size up. Ano pa? We have the primary assessment. Next, we have the history taking. Pang-apat po will be the secondary assessment. Next, we have the reassessment. Ayan, of the patient. Ano ba ang nangyayari on the reassessment? Malamang, guys, you are inside the ambulance na. Inside, okay, the ambulance po ang nangyayari dito. Ano bang nangyari inside the what? The ambulance. Malamang, nasa loob ka ng ambulansya. Ano bang gagawin natin? Siyempre, you reassess the patient. Now, ano bang gagawin natin upon reassessing the patient, guys? You repeat primary assessment. Ayan. You repeat, okay, the primary assessment. Ano nga yung technique sa primary assessment? A, B, C, D. Okay? Ayan, letter E, pero hanggang A, B, C lang muna tayo. The airway, the breathing, the circulation po. Ayan, next, aside from, okay, repeat, okay, the primary assessment po, you need to reassess vital signs. You need to assess, ayan, the vital signs. Aside from the reassessing the vital signs po, and record. I-record mo na yan kasi i-endorse mo na yan sa dispatch na hospital or dispatched hospital na na i-refer mo yung patient doon. So you need to reassess vital signs and record. Guys, dapat ang vital signs natin, i-check talaga natin. Kasi nangyayari ngayon, di ba, sa sobrang galing mo, di ba, yung tipong nag-assume ka na lang, kasi okay ang patient mo, edi okay lahat ng vital signs. Mali yun. Na pangit din. Tulad ng pag ang patient mo NSR, do you think NSR ang patient mo? Okay? For the rest, okay, of the what? No? Let's say sa duty mo, no. Pwede ang NSR na yan ay maging dysrhythmic later. Right? Ayan, so aside from that, you need to what? No, reassess. Okay, chief complaint din. Sulat natin. So you reassess. Ayan, reassess. Puro reassessment tayo. Okay, the chief. Ayan, the chief, okay, complaints. Okay, of your patient po. Mag-reassess tayo. Next, you perform, okay, interventions po. Ayan. You do, okay, interventions here. Aside, okay, from what? Na interventions po. Ayan, you properly document dapat. Importante din to, guys. Sulat natin. So, there should be a proper, ayan, documentation. Wanna know why? Kasi i-endorse mo ang patient, di ba, sa ER. So, there should be a proper document. Ayan, proper documentation po. Okay, and endorsement. Sulat natin. And, okay, endorsement. So, basically, okay, last na but not the least po, you need to inform. Anong inform po natin, sir? Dispatch. Ayan, di ba? Hey, this is dispatch. Okay, ganito, ganito, ganito. Ayan. Inform mo ang tinatawag na hospital. Ayan na, papunta ka na doon. And you need to inform also na you're going to leave, okay, the hospital na din. Kailangan mo sila na iiwat kasi mag-endorse ka doon. Some of you here po nag-work na sa ER, di ba? Yung iba ay what? Na ini-endorsean po ng, let's say, mga ambulance na, or let's say from 911, or let's say from parang trauma center po, na, or let's say trauma ambulance po, di ba? Some of you here po naka-experience na sa ER po. It should be properly, okay, endorsed dapat na. Ayan, last but not the least, guys, there should be an aftercare na of everything na po. Okay? Ayan, so Ma'am Joy?
Yes, sir.
Yes, sir.
Yes, ma'am. Tapos na muna ako, ma'am, sa first part po. Ayan, so we need to have a 15-minute break lang, ma'am. And then try to guys, try niyong buksan yung link po na pinakita ni ma'am. So next topic will be more of, okay, videos na naman tayo. Okay? Sige po. 15-minute break, ma'am. And then guys, pa-chat na lang po kung may mga topics po bang hindi clear sa inyo or nawala na ang signal po natin. Kasi sabi nga ni Ma'am Aquino, ang last po daw na signal is yung sa ano guys, sa O2 SAT na. Sige po. 15-minute break and then pa-view na lang po muna ng mga downloadable files po natin. Sige guys.
Guys, may sinend po akong link. Pa-view na lang po sa chat. Tapos pa-validate naman po ng list of names for your certificates and IDs.
Morning.
This is Daniel Johnson, a 25-year-old student. He was knocked off his bike by a bus and has been brought into ED by the paramedics.
Do I have any assistants?
Yes, you have an ED nurse who's willing to help.
Okay, excellent. And I'm gloved, gowned, and I've got eye protection. Is it safe to approach?
There's a small amount of bleeding which appears to be arising from the left thigh, but otherwise there's no other threats.
Okay. Mr. Johnson, can you hear me?
There's no response. He appears unconscious.
Okay. And just looking in his mouth.
Okay,
Can I
there's
see
nothing obvious to see in his mouth.
Okay. And look, listening and feeling.
The chest wall's moving, but not spectacularly. He has some stridor, and you can't feel much in the way of breath on your cheek.
Okay. And if I perform a jaw thrust?
The chest wall's moving much more freely now. Breath on your cheek is stronger, and that noise has disappeared.
Okay. Could you take over manual immobilisation for me? Okay, I'd like to size a Btls airway. Okay, and I'd like to put on.
He's tolerating the airway.
I'd like to put on 15 litres of oxygen via a rebreathable mask. Sorry, non-rebreathable mask. Okay.
The mask is fogging, the bag's inflated, and there's no extraneous sounds at present.
Okay. Because of his compromised airway, I'd like to call an anaesthetist for a definitive airway, and
Okay.
while I do that, I'll put on triple immobilisation of the C-spine.
Someone's going to call for the anaesthetist.
Okay, just size a collar. Okay, that's stabilised. Okay, I'd like to move on to breathing now.
Okay.
Could you put on pulse oximetry for me, please? Thank you very much. Okay. And inspecting the neck, is there anything obvious to see?
There's no obvious abnormalities on visual inspection.
And palpating the trachea?
On palpating the trachea appears to be deviated to the left.
Okay.
There's also some surgical emphysema.
Okay. And what's the expansion like?
The right side of the chest doesn't seem to be moving much. It seems to be hyper-expanded, and the respiratory rate is 32.
Okay. And is there any blood on my gloves?
On palpation, you could feel a little bit of crepitus again over the right side of the chest. There's no blood on your gloves.
Okay.
Resonant, hyperresonant, resonant, hyperresonant, resonant, hyperresonant, resonant, hyperresonant.
Okay. Thanks.
Normal breath sounds, absent breath sounds. 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 Heart sounds are normal.
Okay. Clinically, I suspect he's got a right-sided tension pneumothorax, so I'd like to perform needle thoracotomy, thoracentesis, and...
Okay, can you talk me through that, please?
Excellent, thank you. Taking a wide bore cannula on the right-hand side, I'll find the angle of Louis and second intercostal space. Then in the mid-clavicular line, just above the third rib, I'd like to insert the cannula down and listen.
Okay, as you do that, there's a hiss of air.
Okay, and then I'd like to fix the cannula in place. Excellent, thank you very much. Okay. And from there, I'd like to reassess the breathing. Has his appearance improved?
On reassessment, he's still tolerating the airway. His mask's still fogging. His bag is moving. The pulse oximeter reads now 92%. His trachea is now central, and the right side of his chest appears to be moving, although not as much as the left.
Okay. Could you prepare a formal chest drain kit for me? And could you also call the trauma team to come and help?
Okay, so the trauma team have been called. The nurse is going to set up your chest drain set, but that's going to take a couple of minutes. So.
Okay. Well, I'm happy with the airway and breathing from the reassessment, so I'd like to move on to circulation.
Once you start CPR, you want to really make it count because patients are much more likely to survive if you perform high-quality CPR than if you perform poor-quality CPR. And there are 5 major determinants of CPR quality, which we're going to discuss in some detail. The first is the rate of compressions. 100 to 120 is the rate that every rescuer should be aiming for. 2 is adequate compression depth. We want to go about 2 to 2.5 inches or 4 to 5 centimeters. 3 is continuity. You should be performing CPR for a minimum of 60% of your total resuscitation time, if not more. 4th is chest wall recoil. That's diastole in cardiac arrest, and that's what allows the heart to refill. So we want to make sure that we allow the chest to recoil so the heart can fill normally, making each compression count. And last is hyperventilation. Hyperinflating the lungs decreases cardiac output and is another variable that produces adverse outcomes in cardiac arrest. So let's start with compression rate. There have been a number of studies looking at rate, and this is one example. In this study, they looked at the mean rate of chest compressions among a large sample of cardiac arrest patients, and they found that the patients who had compressions at a rate of roughly 100 to 120 had the highest probability of ROSCE, which stands for return of spontaneous circulation, and they also had the highest probability of survival to hospital discharge, or having a longer-term positive outcome. So 100 to 120 is the rate you want to go for, and there's actual science showing us that patients are more likely to survive when we use that rate. Compression depth, we have a similar study looking at depth as an isolated variable. Again, for patients getting return of spontaneous circulation back, the optimal compression depth was just under 5 centimeters. And same thing for survival to hospital discharge. The optimal compression depth was just a little bit over 5 centimeters. And what they found in general is that any compression depth over about 4 centimeters or 38 millimeters produced an odds ratio of 1.91 of survival to hospital discharge, meaning that if you have compressions of greater than 38 millimeters across the board, you're twice as likely to survive. So it's a really important variable and a really easy one to optimize. This graph is about chest compression fraction. So in this study, they looked at the percentage of time in the overall cardiac arrest that the patient had active chest compressions being performed. And they stratified according to the percentage. So 0 to 20, 20 to 40, 40 to 60, et cetera. And they found, not surprisingly, a linear increase in the likelihood of return of spontaneous circulation as the chest compression fraction increased. So if you spend more time during the code performing CPR, you're going to get a better outcome and a higher probability of survival. This is the same data, but this is actually a survival curve rather than the group stratified data. And once again, chest compression fraction of 0.8, 0.9, or 80 to 90% of the time produce the highest likelihood of return of spontaneous circulation. In another study looking at chest compression fraction, the outcomes were a little bit different. In this study, they found that actually a 60 to 80% chest compression fraction produced the highest odds ratio of survival to hospital discharge, and that's what the current guideline recommends. So you want to be at a minimum of 60%, ideally closer to the 80% range for your chest compression fraction. The bottom line, though, is you're clearly never going to know numerically what your fraction is during the course of a resuscitation. You just want to make sure that your CPR is as continuous and uninterrupted as you can possibly make it. So chest wall recoil is a physiologically important variable, but there's actually no human studies on it that demonstrate improved survival because it's kind of a difficult phenomenon to study. But basically the idea is if you lean on the chest in between compressions, you're going to increase the patient's inner thoracic pressure, right? You're smashing down on the chest, so that's going to raise the inner thoracic pressure. Well, we all know that positive pressure ventilation also raises the inner thoracic pressure. So if you cram more air into the lungs, you're going to raise the thoracic pressure. And the bottom line, what brings blood back into the heart during diastole? It's negative inner thoracic pressure, right? It's that negative pressure gradient that pulls blood from the periphery back up to the heart. So if you raise the inner thoracic pressure and make it not negative, you're going to prevent the heart from filling and you're going to decrease your cardiac output by decreasing your stroke volume. The ultimate effect, again, is going to be impaired cardiac output, and that means less blood flow to the heart itself, less blood flow to the brain, and less likelihood of spontaneous circulation. So, bottom line, high quality CPR is what you need to do to optimize your chances of survival. And the determinants, once again, are push hard, 4 to 5 centimeters, push fast, 100 to 120 compressions per minute. Keep it going. You want to make sure your chest compression fraction is a minimum of 60%, if not more, during the course of the arrest. And avoid hyperventilation and chest wall leaning. If you do those 5 things, you're going to increase your patient's odds of survival. So, once you have really good quality CPR going, what's the next question you need to answer? You've already decided your patient is pulseless. You've already initiated compressions. What do you need to know now? The answer is, of course, what is the cardiac rhythm? And specifically, is it a rhythm that we can treat with electricity? Is it a shockable rhythm? So, shockable rhythms, like we said before, are more likely to survive. Patients who can be shocked are more likely to live through a cardiac arrest. But defibrillation is a very time-sensitive intervention, meaning the faster you do it, the more likely it is that your patient's going to benefit from it. So for shockable rhythms, we consider defibrillation to be more important than anything else you can do. More important than CPR, more important than ventilation, more important than drugs or IV access. It is the single most important thing that you can do. So if you have a shockable rhythm, you need to know early and you need to treat it early. Here's one of our shockable rhythms. This is ventricular fibrillation. It's very easy to identify. It's randomly fluctuating. It goes up and down. There's no pattern. There's no rhyme and reason. There's no QRS complexes. It's just a disorganized squiggle. The second one is ventricular tachycardia. Now, in VTach, there actually is organization to the QRS complexes, but they're wide and bizarre looking. So anytime you have a fast rhythm with wide QRS complexes, you should suspect that to be ventricular tachycardia. And by the way,
Ayan, kasi yung mga ibang estudyante po ay kaka-BLS lang po nila. Yeah, 3 to 4 days ago lang po. Na? Ayan, so let's continue na. So basically, ano ba yung mga ano natin, yung mga next topics po natin. So guys, ayan, this is actually a slide na based on the pre-hospital or the PHTLS po talaga na training course. So when we say pre-hospital, okay, training course po, and it's outside the hospital setting, guys. So we usually begin with what we call the scene assessment lang. This is ano lang, a parang very a comprehensive lecture na based on on the Philippine setting talaga siya. Pero inadapt din po ang American setting po dito. So number one, guys, now you need to determine the scene safe talaga dapat. So we have number one. Next, you have the pre-arrival information po, in which dapat may mga information ka na about that scene. Kasi diba, safety is actually our priority. So before arriving at the scene, there is a assessment na po sa pre-arrival pa lang. So, eto na, nag-arrive ka na sa scene, guys. Ayan, next, is that you need to maximize the available resources. Ayan, next, ano ba yung mechanism of injury? Is it a blunt trauma? Is it a penetrating trauma? Ayan, and last but not the least, ilang patients ba on that scene para at least yung mga personals po natin ay hindi po magkakaubusan. So we have the safety first, we have the pre-arrival information, we have the arrival at the scene area na po. Next, we have the available resources. Next, we have the mechanism of injury, and then we have the patient. Guys, I can actually share the slide if ever kung gusto niyo. And then, mas maganda din if ever kung gusto niyo talaga mag-update, let's say for the EMS, like every day kasi may update po sila. And of course, ituturo po natin today, of course, na may mga updates din po dapat din. So sa Facebook actually yun, yung EMS na group. So ang daming videos doon, ang daming mga handouts, no? Sobrang dami din, sobra. And so we have the components, guys, as discussed po. So we have the safety. Ano ba ang problem natin? 'Di ba? There should be a general impression din kasi on the scenario na. So sa pagtawag pa lang sa iyo, guys, you need to know kung ano ba talaga ang scene na yun. May sunog ba? Is it a motor vehicular collision ba? Na? So may mga may mga let's say mga biological warfare ba? Mga ganon. Or if ever nasabi na doon na may may let's say history of patient na travel, ayan, tapos may mga lower respiratory tract infection, so malamang alam mo na kung anong sakit ng patient natin. Na? It should be thought individually, guys, and perform simultaneously pa. Ayan. So basically, pag sinabi po natin safety, so it's divided into three. We have the pre-incident, we have the incident, and then we have the post-incident. Pag pre kasi, it's more of the prophylaxis. And then pag post naman po, more of na naman siya. Let's say for the treatment na naman, baka kasi nahawa ka din. Ayan, so kailangan may mga follow-up na mga vaccines ulit. So pag sinabi po natin, pre-incident safety, dapat there should be a what? Dito, may prophylaxis na po tayo dapat. Let's say against the flu. Actually, guys, siguro mga next week, baka magbebenta po kami ng mga flu vaccine. Ito po yung mga binibenta ng government. Pero may direct supplier kasi ako. So, naging business na naman. So, ayun po. Baka may ipapalusot kami ng mga vaccines po. Yung mga quadri, mga ganun-ganun po. Ayan. Next, we have the training. Dapat kasi EMS provider ka na para alam mo ang sequence, di ba, ang flow natin. Ayan, so we have the proper training. Next to what? The pre-incident po, we have the incident, which is actually kailangan po may mga safety measures po. Pag crime scene yan, alam mo syempre na dapat andun yung bumaril sa kanya, di ba? Andun yung mga bad guys na nasa what? Na within that crime scene lang din. So be careful, right? Ayan, tapos dapat aware ka na din na medyo ang daming mga, 'di ba, OA on that scenario, on that scene na ang daming mga commotions, 'di ba? May mga mag-iiyakan, may mga pero syempre, 'di ba, ang mga Pinoy kasi ngayon, selfie muna, 'di ba? Videos muna, pictures muna bago mag-activate ng 911. And so nasaan na ang what na ang bayanihan na ayan, so parang nawala. Although kasi sa Philippines setting kasi wala tinatawag na yung Good Samaritan Law, wala po. Na? Kasi ang Good Samaritan Law, di ba? Whatever happens to your patient, na you're not liable. Pero ngayon kasi you are liable, lalo na pag nag-videohan ka. Kaya you better perform it properly po. Or else, na syempre, ang daming magbabash sa'yo. Next, we have here on the incident area, of course, the safety measure, guys, na the proper PPEs, na ayan, of course, we have the incident and patient-specific po, to be specific na paano ka ba mag-handle ng mga body fluids, right? Yung mga blood po natin. Kasi ano bang nakukuha natin, guys? Mga bloodborne pathogens. Ano ba yung mga example ng bloodborne pathogens natin? Di ba, the HIV, the Hep B, na, they are preventable, but they are incurable in nature. So we need to what? Now, you need to protect them. Kasi, di ba, pag sabi mong trauma, you will be dealing with blood. Automatic yan eh. Ayan, pwedeng blood externally or blood internally. Sana ba mas mahirap? Internal, hemorrhage or external? Siyempre, mas mahirap po yung internal. Lalo na pag abdominal, na? Lalo na pag may mga ruptured, kidney, ruptured spleen, ruptured liver, brought about by, the said, na blunt trauma, right? Ayan. Na? Can you still follow pa? And if ever kung may mga questions po, you can actually chat na. Ayan. Pwede naman private, pwede naman in group din, right? For clarification po. But nonetheless, guys, ibibigay ko po yung slide na yan. Kasi tomorrow, may mga gagawin po tayo, right? Pwedeng individual presentation or pwedeng group presentation lang din. Or you can actually send that one to my email din. Kasi I'll be giving you mga trauma cases po later. Next, we have the post-incident. It can be post-exposure po. Let's say, what if may TB pala yung patient na yan? Diba? What if, may blood, let's say, na contact with, an HIV, na patient po, or what if may hepatitis, na? So, may mga tinatawag tayong mga post-exposure din na prophylaxis. Kanina may prophylaxis ka on the pre-incident. Meron din dapat, post, na mga what, na let's say, post-exposure dapat, na? Kasi syempre, yung safety din kasi talaga ang iniisip natin dito. So, on the pre-arrival information, guys, ayan, dispatch information kasi, ikaw yung dispatch. Pero may isa pang dispatcher, yung mga nag-uutos sa'yo. Let's say, hi dispatch, Mark Adlawan. So you have a patient, ganito. Ayan, ano bang location niya? Na, is it a squatter area ba? Diba? Ano bang nature ng what? Na accident na yan? Ano bang nature ng incident to be specific? Is it an accident ba? Is it a fall? Na usually, pag mga tao ba guys, saan ba usually nahuhulog? Sa kama ba or sa maling tao? Malamang sa maling tao. Yun yung mahirap, guys. Na what? Na it-treat talaga. Right? Ayan, so kayong mga nanonood po sa mga screens, na ang awkward lang ng setup talaga pag online kasi ang kaharap mo lang screen na hindi ko alam kung anong ginagawa niyo. Pwedeng yung iba natulog na, pwedeng yung iba sa CR, 'di ba? Ayan, tas feeling nyo din naka-pants. What if naka-panty lang pala ako? So, ang daming mga misteryong nangyayari pag online, guys. Na ang importante ako lang nagsasalita kasi pag ako na ang hindi nagsasalita, malamang ako nang nakatulog din. Okay? Ayan, so if ever pwede naman kayo mag-chat na let's say, sir, may mga binibenta ka ba dyan? Meron akong binibenta, guys, alcohol, pamine na lang po. So you can do online selling na din. May mga bread naman ako dito, guys, na ayun, actually kanina lang kaka-deliver lang po ng ng 50 na boxes ng Adelay ba yan, ma'am? Adelay. Yung parang Adelay na mask. Kasi they're selling it. Actually may main ako, guys, na supplier. Siguro nasa mga lang. Nasa mga 550 na lang si Adelay ngayon. Adelay pala, na. So sa mamaya if ever kung gusto niyo mag-resell, Si Ma'am Joy din, nagbebenta din po. Okay, on Bicol area naman siya. Ako naman, if you have friends sa Manila area, then you can actually refer. Then I'm also selling yung yung mga cheat sheet cards. You can actually use this one. So parang ang lakas lang maka-US guys na the cheat sheet na parang the cards na ayan, so lakas maka-US. Yeah, the Glasgow Coma Scale, andito na din lahat. So if you want to order na. And so we have the location of incident. Next to location, guys, we have the nature of incident. Is it a blast pa? May may bomba bang sumabog? Na? Ayan, so report the situation, issues such as hazards, number of patients, yung corresponder mo na dapat sapat lang. Kasi ganito, in COVID patients kasi guys, ngayon let's say sa Davao na protocol na it's a no-touch policy. So if ever, kung sino yung nag-report, most likely, siya yung una nakakita kay patient. It can be relative yon. And alam nyo ba, since no-touch policy po, hindi mo talaga hawakan ng patient. And alam nyo ba kung sino transport talaga? It can be si patient mismo, guys, na pipilitin niya ang sarili niya na tatayo talaga, if ever kung conscious si patient. Kasi ngayon, grabe ang pagprotekta, guys, ng mga government, especially for those na nag-volunteer lang. May mga nagvo-volunteer kasi ngayon sa government, let's say sa Davao, may LGU na may government doon na team, hindi nurses hindi sila medically inclined po, pero nag-volunteer lang sila kasi brought about by scarcity na din na of nurses, of medical responders po. Ayan lang, mag-arrive lang sa scene tapos syempre may assessment, pero hindi nila lalapitan si patient, nor ita-touch ang patient. It's a no-touch policy. And I also asked my brother, sabi ko, ano ba yung ngayon? Ano ba yung, let's say, ginagawa niyo, especially pag COVID patient na din siya, it's a no-touch policy din daw, guys. Kahit kompleto ka pa ng PPE. So you need to protect. Kasi ganito, pag nag-touch ka kay patient, sinong kasama mo sa ambulance? Siyempre si driver din. So pwedeng magkahawaan kayo lahat doon. So depende na din nasa government if it's a no-touch policy. Pero kasi alam ko sa states, guys, itatouch talaga nila si patient. But sa Philippines, siyempre protektahan nila na ang bawat isa. Well, siyempre sa panahon ngayon, guys, sobrang magulo. Sobrang gulo lang ng mundo. Are you aware na sa ngayon, sa Africa, bumalik na naman si Ebola. Last June 2, so may report na po si World Health Organization na bumalik na naman siya. Na I hope hindi na naman siya kakalat yung Ebola. Although, the reality, guys, especially with SARS, with MERS-CoV, di ba parang nawala siya sa limelight eh. Akala kasi natin dati, na-treat na talaga si SARS kasi MERS-CoV. Definitely hindi pa siya na-treat. It's just that, ayun, tapos na yung time niya, di ba? But still, it's still existing pa rin. Tulad ng COVID, pwedeng mawala siya soon. Ayan, kaya di ba pag may mga uy friend, I'm going to see you next month, or let's say, magkikita tayo sa July. Kailan July yon? July 2025? July 2029? Di ba? So hindi natin alam kung kailan talaga siya mag-stop na. And right now sa States din, familiar with nangyari ngayon, yung kay Floyd na. So the MERS, the COVID, guys, hindi lamang siya pumatay ng tao, but rather nag-cause din siya ng racism. So ang daming mga kaganapan po sa mga nag-ambisyon na mag-states, guys, let's say mag-nurse doon. Syempre, pahirapan muna ngayon kasi number one, may yung mga hold muna, 'di ba, sa mga mag-abroad po, na especially for us, especially for nurses, right? Ayan. So we have the pre-arrival factors, so we have the weather conditions. So kamusta po ang weather niyo diyan sa Rapu-Rapu? Kamusta ang weather sa Rapu-Rapu? Ayan, kamusta po ang weather sa Bicol? Sobrang init ba? Sa Vegan, actually ang Bicol at saka Vegan, parehas kayo mainit para parehas kayo maganda talaga ang places niyo. Rapu-Rapu also, sobrang ganda ng island na yan. As in like madaming kuryente, may aircon, naalala ko dati. Ayan, so we have for the weather conditions. So usually, guys, pag weather conditions, you need to pay attention lang din kasi 'di ba pag umulan, ayan, ano ba nangyayari pag ulan? So, syempre, yung daan, madulas. So, ang daming mga motor vehicular accidents. Kahit hindi naman maulan pero pag time talaga na magkaroon ng accident, well, nangyayari talaga yan. And then of course, na pag weather conditions din, di ba, ang daming inaatake ng asthma, na whether umuulan or whether sobrang ang daming inaatake ng asthma. Traffic conditions, yeah, Bicol, hindi naman nagta-traffic sa Bicol So, makukuha niyo talaga ang 10 minutes or within 5 minutes dapat naka-arrive ka na sa scene. Pero pag sa Manila area, guys, tas dadaan ka ng EDSA, good luck. Baka pagdating mo sa patient, guys, inilibing na lang po ang patient, di ba? Hindi ka man nag-perform ng scene size up, di ba? Primary assessment, history taking, secondary assessment, reassessment. Walang nangyari, na brought about by the delays. Next, time of the day, syempre, pag sobrang busy, kailan ba sobrang busy? Morning, mga rush hour, na it involves traffic na din. Right? So ito yung mga pre-arrival factors po natin. So meaning to say, pag ikaw ang driver ng ambulance, guys, dapat alam mo na dapat mas magaling ka pa kay Waze, 'di ba? Sa mga turn left, turn right, at the roundabout, 'di ba? Take the third exit. Dapat mas magaling ka pa doon. Ayan, kamusta naman po yung mga connections po natin diyan? Okay naman? Ayan, connection sa internet, hindi po connection sa mga sa mga HR, 'di ba? Ayan, sa mga head nurse, hindi yung mga ganoon na mga connections. So we have arrived at the scene. There should be a general general assessment dapat, no? Or basically the global assessment dapat. Ayan, as you arrive at the scene, di ba? What do I see? What do I feel? Di ba? What do I hear? Dapat yung mga senses mo, guys, dapat masyado kang sensitive enough na ayan, may mga mga hazards ba, mga unforeseeable crisis na upon arriving at that area. Ayan, ilan bang involved sila? Na are there any other issues din, 'di ba? Ano ba yung mga additional resources ko? Kulang ba ako sa C-spine? Kulang ba ako sa longboard ko? Na kulang ba ako or baka kailangan ko ng drug or let's say kailangan ko ng medication such as epinephrine. Kasi ang patient pala na to may rash. Guys, do not use the word rashes kasi wala pong word na rashes. It should be rash alone. Sabi yun ng ex ko. Na pero syempre, 'di ba? Karon talaga, you learn from them or from him and then he'll learn from you also. Char. So we have your arrival at the scene. Next, we have yung MOI. Diba familiar with the MOI? Kailangan natin malaman kung ano yung mechanism of injury ba? And kasi ang sabi ko nga kanina, the energy, it can be transported, transferred, transformed, but it cannot be destroyed. Dire-diretso na po yan. Ano ba yung mga examples natin? Ayan, if that breaks the human tissue, guys, that can be brought about by what? By compression. Nagda-drive ka, biglang nabunggo, boom. May blunt trauma na tayo. Pwedeng may tearing, so may breakage tayo, may opening tayo. And then we have the word shearing. Guys, familiar with shearing? And that's basically a pressure. And it's a combination of perpendicular, na pressure, guys, plus, a parallel. A parallel force. So, combination siya. Kaya siya tinawag na shearing. Ayan, it's a combination of a perpendicular force, pababa, and then may parallel force din po siya. Ang tawag doon, shearing. 'Di ba? Shearing, of course, na nangyayari po yan, 'di ba? Saan? Sa party. Sharing yon, Bisaya dong. Ang shearing, guys, nangyari po yan na pag may mga decubitus ulcer po ang patient natin, may mga bed sores. Right? Ayan, pero pressure talaga ang pinaka number one na reason kung bakit daw, na may bed sore ang isang patient. Okay? So, pag sinabi kong MOI, ayan, may only radio ba yon? MOR yon. Okay, pag MOI, guys, the mechanism of injury. Ganito siguro pag DJ ka, no? Parang walang kaharap, right? Parang magsasalita ka lang sa monitor, hindi mo na alam kung ano yung tsura mo, kumukha ka na bang si Shrek or whatsoever, no? Ayan, it's good to know din, 'di ba, na kilala ko ang mga nag-a-attend baka kasi may mga unwanted tayo na mga magjo-join, 'di ba? Siyempre hindi tayo makakapagsalita na baka matutulala na lang tayo na at mga muling ibalik na. So anyway, so we have the mechanism of injury. So we have the blunt trauma. Example na ng mga blunt trauma natin, guys. We have the motor vehicular crashes. Nakita niyo naman si Kuya, oh. Ayan, naka-project pa, nabangga na nga, na parang sumayaw pa, parang naka-cheer dance pa. Pero yung impact niya kasi, pwedeng sobrang layo ng impact niya. So pwedeng sa pedestrian din, di ba, nabangga. Ayan, so we have the falls also, di ba, pag nahulog. Of course, na pag falls kasi, mga motor vehicular accidents, guys, you always expect na may mga C-spine injury yan. So there should be a spine immobilization. Pinaka-importante yun. Kaya dapat may C-spine, cervical collar po tayo, guys. Okay? Ayan. Now, next, we have the contact sports na mga blast injuries such as yung mga biglang sumabog. Di ba? Ayan, mamaya, madidiscuss po natin yan. Okay? So we have the blood trauma. So again, pag blood trauma, ayan, mas generalized, na mas malaki po ang impact nito kay patient. Pero pag sinabi mo namang, penetrating, guys, mas smaller siya. Kasi may may opening tayo na may mga low, may mga medium, may mga high. Ano nga sabi ko pag low, low energy. Pag low energy, pag ginamitan ka ng kutsilyo, tapos biglang nabigla kang, 'di ba? It's a low energy. Pag baril naman, guys, kasi mga pistols, ayan, it's a medium energy. Pag high energy naman, yung mga malalaki na po, yung mga Armalite, yung mga bazooka, yung mga ganun. Ewan ko lang kung buhay ka pa sa bazooka. And so that's a high energy. So may mga trajectory po tayo, may mga pasok, may mga exit tayo. Ang tawag doon mga penetrating injuries. Ayan. Sino kaya dito, guys, ang nagkakaroon ng internal bleeding? Is it the penetrating ba or is it the blunt trauma? Sino kayang mahirap? Kasi itong penetrating, malamang may entrance, may exit din yan. Mas mahirap ang blunt trauma. Kasi nagkakaroon ka na pala ng internal hemorrhaging. Okay? Ayan. So next, we have the patients po. So dapat magaling tayo na you need to know kung ilang patients ba kasi we'll be applying the principle of triage. Ano nga yung mga triage natin? Ayan, we have kailangan. We have the red one, no? We have yellow, di ba? May green tayo, may blue, at saka may black. Pag black na po, syempre, disease na ang client dyan. Na unahin talaga natin, guys, si red, na that needs an immediate talaga na management. Dapat, di ba, within 0 minutes dapat. Na dapat andun ka, dapat nag-render ka agad ng treatment. So we have who needs attention first. Malamang si red yan based on triage. Okay? Ayan. So may mga questions tayo. Can you gain access ba? Let's say, biglang si patient, shockable rhythm kasi nag-attach ka din ng AED, guys. So dapat may mga AEDs ka rin na ready. Hindi yung pumunta ka lang doon all by yourself na walang mga equipment. Okay? Ayan, so can the patient move ba? Can the patient get out from that scenario? Is my patient conscious ba? So ang daming pwedeng itanong, guys, na regarding sa patient po natin. So next, we have the initial impression. Sa initial impression pa lang kasi natin, pagkakita mo pa lang sa scenario, unconscious na to. Conscious to. So malamang pag unconscious yan, baka mapo-perform ako ng high quality chest compressions nito. Pero pag, conscious naman to, so malamang mapo-perform ako ng secondary assessment. Right? Ayan, so pag immediate, guys, up to primary assessment ka lang. Pero pag okay naman si patient, pwede namang mag-last up to secondary assessment, then proceed. So, ito yung mga tanong natin. Is my patient sick? Kasi if your patient is sick daw, then therefore, it's a critically ill patient. And if the patient is let's say, sick, or let's say, not yet sick naman ang patient, potential naman for harm pa rin. Baka nga si patient ay not yet sick, pero later, biglang nag-desac ang patient natin. So we have the not sick patient, or let's say may minor, or basically no injuries at all. Ang dami kasi pwedeng cause nito What if nahimatay lang talaga ang patient brought about by heat exhaustion? Ayan, ang daming pwedeng cases talaga, right? Right now, sobrang init po. Yung iba, sabi nga nila, pag nahimatay, COVID agad, di ba pwedeng na heat stroke din ang patient, which that's really common. Pero kasi, bakit always COVID? Kasi kailangan kasing protektahan din ang sarili, right? Kasi it's highly contagious. Take note, guys, it's viral. So tanong ko lang, is COVID a direct is COVID airborne ba siya or droplet? Ayan, 'di ba? May mga kumakalat kasi na issue, guys, based on World Health Organization na airborne daw talaga siya, pero may mga nagsasabi din daw talaga na hanggang droplet lang talaga siya, 'di ba? Ayan. Tapos meron ding, 'di ba, pag droplet kasi dapat hanggang 1 meter lang. And alam nyo ba, may study daw na abot hanggang 7 to 8 meters siya. So parang naging airborne na din siya. Ang importante, whether if it's airborne, whether if it's what, na droplet guys, ang importante protected tayo. Ano bang gagamitin? Of course, the N95 mask. Ayan, produced by the US. Pero meron kasing yung FFP2 ata yon, right? Ayan, that is produced by Europe. So mamimili ka lang kung gusto mo. Gusto mo ba Europe? Ayan, the FFP2. And then we have the US guys, which is the N95. Na mamimili ka lang doon. Pero pag si China kasi, it's the KN95. Na? So mamimili ka na lang din. Okay? Ayan. So we have the principles, guys. So we have the machinery of life. Siyempre, sabi nga nila, we need to live life na to the fullest. Kasi ang life kasi natin, it's really precious. Your body kasi, they are so dependent to one another. Example, this is your body. Na? Ayan, if that's your body, ayan, kailangan alagaan daw ang body. Kasi pag nagka-problema ang heart mo, automatic magkakaproblema si brain, automatic magkakaproblema si lungs, di ba? So they are interdependent to one another. They are not independent, but rather, they solely rely on each other po. Di ba? Pag maganda ang heart mo, okay, sige, maganda na din lahat. Maganda ang brain mo, maganda ang circulation mo. Pero pag nagka-problema ka sa airway mo, malamang magkakaproblema ka rin sa what? Siyempre sa heart mo, at saka sa brain mo. And that's the machinery of life. Kaya dapat alagaan dapat ang sarili. Right? Ayan, next. O, ito na. Ayan, the primary assessment po. On the primary assessment kasi, this is basically na perform immediately. Diba? This is to what? Check for, what na mga life-threatening situations po. Na whether si patient ba ay may internal bleeding ba, or si patient ba ay may traumatic brain injury, kaya affected po ang neurologic, vital signs po natin, especially the GCS. Kaya nga as part of the assessment din, kailangan mo ding i-check later ang disability, na especially yung the four na quadrant na movement din, or the four body movements po, dito, left leg, and then we have the right leg. Kasi para ma-determine natin ang na kung ano ba yung mga parts ng brain na affected. Ayan. So we have the primary assessment, guys. We have the airway, breathing, circulation, disability, exposed, and environment. Sir, bakit pa ulit-ulit yan? Kasi kailangan ulit-ulitin to kasi this is the highlight ng tinatawag na basic trauma course. Kasi, di ba, from Btls or the basic trauma, course po, ayan, meron kasi tayong tinatawag na PHTLS, tapos may mga ITLS, na International Trauma Life Support. Nung ako naman, guys, nag-train ng International Trauma Life Support, I can vividly recall, nangyari yan sa Zamboanga. Na? So, mas worse na po ang International Trauma Life Support, na as in like, sobrang nakakapagod. Like for almost 2 weeks ako nag-train doon. As in like may mga hospital, may mga car extrication pa kami, how to manage a patient po, motor vehicular collision. Na-try ko guys na as in like gumapang talaga sa ilalim ng sasakyan. Tapos ang ending, ako pa lang na-trap sa sasakyan. So sobrang laki ko at sobrang bigat ko din. Kaya akong gawin na ang trauma life support. Mahirap siya, mahirap. Ayan, masyadong panlalaki yan. Ayan, so we have here the airway, breathing, circulation, disability, and then exposure. Mamaya kasi guys, i-discuss ko pa sila thoroughly pa. Ayan. So, in the airway, breathing, circulation, sige lang, napahapyaw na naman ulit tayo. Ayan. So, for the airway guys, syempre mag-C or mag-cervical spine tayo dito or the C collar, spine po tayo. Ayan. So, we have the airway. Next, for the breathing guys, syempre, you need to check for the bilateral breath sounds. Kasi pag absent po ang isang breath sound sa isang lung, then you need to expect that your patient is suffering from what? Tension pneumothorax. Next, we have the circulation. Ayan, the general appearance of the patient is my patient pale. Diba? Kasi pag pale ang patient mo, malamang baka may obstruction na nga talaga tayo. Okay? Ayan, or baka may problem tayo sa perfusion ng patient natin. The capillary refill time, familiar? Ayan. Next to circulation, guys, we have the disability. O, ito na. We have to determine AVPU, yung mga GCS po natin. And then we have the exposure, or let's say sa environment po. But again, the privacy here is actually the main issue na, ayan. Sige lang, pahapyaw lang to. Ayan, mamaya, magta-thorough tayo discussion. Next, we have the primary assessment. Do not be distracted by the dramatic scene kasi ang daming OA on that scene. Para mas marami sir, ang OA or ang mas maraming magpipicture? Mas madaming magpipicture talaga. Sobrang dami lang. Yung mga chismosa guys, na yung mga bystander, hashtag, mga chismosa, hashtag, mga, ayan, naglalaro na yung mga pusa. Anyway, so, ayan, sige lang, isi-share ko tong slide na to later. So we have the decision making then, whether if it's a what, ano nga sabi ko, whether if it's a stay and a play, or a load, okay, and a go, right? So it's up to you to decide. So again, ano yung pinaka-common? It's load and go. Na ba't ko papahirapan ang sarili? Di ba? Kung feeling mo kulang ka sa mga gamit, well, okay, mas maganda, mas mataas din po ang survival ni patient pag diniretso mo na siya sa what? Sa ER. Right? Kasi pag, sir, gusto ko maging hero, na gusto kong i-save talaga si patient, and then you stay and then you play. Tapos kulang ka pala sa gamit, kaya sana you stay and then you pray. Di ba? Nag-pray ka na lang. Do not play. Right? Ayan, so we have the patient severity, whether you have a sick patient, and not yet sick, pero pwede maging sick later. And then we have in not sick, okay, na patient. Next, guys. Ayan. So we have the transport decision kasi. Usually ambulance na to eh. Alam na mag-tricycle kayo. Di ba? Pumunta ka doon na magwat na nag-ambulance, malamang, ito-transfer mo si patient na dapat naka-ambulance din. Na for sure yung mga hospitals niya may ambulance. Di ba? Rapo-rapo may, may ambulance ba? For sure may ambulance naman din. Na, ayan, basic requirement kasi yan eh, na ng hospital. Yan, naalala ko yan. May ambulance po ang rapo-rapo. Although it's a small, island, pero yeah, with very nice people, na very accommodating na mga people. Sobrang na-miss ko yung dyan guys, yung mga seafood. Siyempre seafood kasi island. Pero nung andyan ako guys, hinanap ko talaga yung pork. Tsaka chicken, no? Medyo mahirap din silang hanapin. Okay? And anyway, so we have the transport decision po. Ayan, whether if it's a ground, ayan, by land, or by air. Sana all may helicopter. Diba? Sana all makasakay ng if you want to transport a patient. Right? Magandang experience din yan. Wag lang mag-crash ang helicopter na yon kasi dalawa na kayo. Right? Na patient. Na ayan, so whether if it's an emergent ba or a non-urgent case that requires specific minutes po. The spinal immobilization, as indicated guys, kasi pag what if may mga high, C-spine pala tayo ng mga affected po, or let's say mga injury, then expect na may breathing, difficulty ang patient natin. Kasi malalaman mo yan eh. What if kumanito ang patient, may efforts guys, it can be may mga tension pneumothorax, or it can be ang patient po natin is suffering from a C-spine or high C-spine. Na injury. Diba nung sabi natin, C3, C4, C5 to keep the diaphragm alive. Diaphragm guys is the muscle that supports breathing. So pag wala na magsusupport ng breathing, so kamusta naman ang breathing ng patient? So magkakaroon siya ng respite failure. Okay? Ayan, so we have does the patient's condition warrant immediate transport? Ayan, if no naman po, pag hindi naman nangangailangan ng immediate transport guys, ang tawag doon, it's the stay and play. Diba? So basically, you're gonna perform, you're gonna stay because you're going to check for the secondary assessment together with the reassessment pa. Ayan, pero pag kailangan niya na, you need to load and then you go directly sa pinakamalapit na trauma center or basically hospital na pag-endorsean mo pa. Ayan. So, this is based on the receiving facility selection, guys. Kung saan ka pupunta na hospital. So, basically, dapat tertiary. Sa tertiary ka dapat. Pero pag walang choice, you go directly to primary. Pero kasi pag maganda ang survival po, sa tertiary talaga. Kasi, di ba, what if nagkaroon pala ng let's say, tension pneumothorax, di ba? What if si patient nagkaroon ng hemorrhage talaga, na? Or let's say, nagkaroon ng open, pneumothorax si patient, massive, hemothorax. So, kailangan ng chest tube thoracostomy. So, what if kulang ka sa mga gamit? So, pangit din, di ba, ang survival ng patient natin. So, the completeness no, nang i-refer mo din, no, so from the start na nakita mo si patient up to the time na ni-refer mo, dire-diretso, tuloy-tuloy kasi yan sa jackpot round. Kung magaling ka sa umpisa, make sure ni-refer mo din siya sa magaling po okay, na facility. Right? And so basically, summary po. Na? So ang pinaka-importante dito is that before okay, arriving at the scene, dapat nag-assess ka na. Is the scene safe ba? Na? May mga hazards ba? Right? Ano ba yung mga additional resources po natin? Right? Ayan, you need to gather okay, what information prior to the said event. Na? You analyze the scene. Dapat may general, okay, what impression ka? My patient is unconscious, so malamang magpa-perform ako ng high quality chest compression dito. Si patient, conscious naman, so malamang aabot ako hanggang, okay, what, na sample history or the OPQRST, okay, right? So you analyze the scene. Ayan, next, you need to form an individual impression prior to beginning, okay, with your assessment. The same pa rin yan. Ayan, nasabi ko na po, observe hazards. And then we have the primary assessment po natin. Di ba? The airway, breathing, okay, circulation, disability, exposure, environment. Ano pa? Ayan, you identify, you classify a patient, whether if that's a sick patient, not sick, okay, and then not yet sick, or not sick na patient po. Ayan, next. Ayan, kailangan ba ng immediate transport? Or do I need to stay and play or load and go? Kasi anong sabi ko, pag stay and play, you perform secondary assessment. Pero pag load and go, referral na po yan sa pinakamalapit na trauma center. Okay? Yung packaging po natin, ayan, the cervical collar spine. Ayan, whether, okay, si patient ba, nasa long board ba siya? Ayan. So, yun lang naman po. So, questions so far. Sige nga. We will entertain questions muna. Ma'am Joy?
Yes, sir.
Yes, sir.
Questions po?
Guys, question.
Guys, question.
Guys? Questions po? Questions from, okay, ano pa, from Tabaco. Questions from Tabaco? Meron po ba? Questions? Sir Raymart, may question po ba? Sir? Questions? Wala? Wala po bang questions? Okay, I'll proceed na po. Okay? So we have the next topic na naman ulit. So guys, paulit-ulit lang mga topics ngayon. Pero kasi, from a very shallow one na discussion, na hanggang sa pa-deep na po tayo. Kasi pag dumiretso ako sa deep na let's say na discussion, hindi mo ma-appreciate yung wait lang. What's the general appearance pa dapat? No? Kasi baka sabihin mo, okay, so in-depth na ang lecture, so parang in-depth din pala dapat ang assessment. No, dapat alam nyo din kung paano siya okay, mag-grasp no? In a shallow area, but in a more deeper one. Okay? So let's now have the topic known as the primary assessment, guys. Ayan, sir, ba't parang naulit na naman to? But this time, mas comprehensive na ang lecture, guys. When we say primary assessment po, di ba, ang goal talaga natin dito, there should be a what? To identify immediate problem. Na? This is to identify, ito yung goal natin to identify life-threatening situation. Ayan. Ano pa yung next goal natin? So here are our goals. Identify life-threatening situation. Next, to provide immediate. This is to provide immediate na stabilization. Ayan, so you need to na stabilize the patient. Pag sinabi mong stabilization, the airway, the breathing of the patient, 'di ba? Ayan, no? The circulation also of the patient, kailangan mong i-stabilize yan. Right? And so basically, pag sinabi mong primary assessment, that talks about what? The simultaneous, right? Assessment and treatment. Ulit-ulit lang yan. Assess and then treat. Assess and then treat. Assess and then treat. So that's your primary assessment. Guys, In the primary assessment po, let's first discuss okay, the airway. Kasi ABCD ito eh. So we have here the airway. Now, upon discussing the airway po, the first question is, can the patient talk? Ayan. What if the patient can't phonate? When we say can't phonate, okay, the patient can't talk. Okay, what if, okay, can't, okay, talk naman si patient? Ayan, may naisip ka ba if the patient can talk? Of course, if the patient can talk, ayan, yes, the patient can talk. Then therefore, there will be no obstruction. Wala tayong obstruction sa airway, sir. The airway is patent. Pero hindi po sa lahat ng oras, okay si patient. Kasi what if si patient pala, guys, is nag-internal bleeding na siya? So yes, the patient can talk, but later the patient can talk. So we have, what if the patient can talk? Ayan. Sir, the patient can talk po. So therefore, if the patient can talk, guys, okay, you need to get, okay, emergency, okay, na what na airway for? Emergent, okay, airway, ayan, management. Pwedeng mga supraglottic airway, or let's say, pwede mo namang i-intubate ang patient only pag paramedic ka. Alright? Ayan, so ganito. Sa airway pa lang, if the patient can talk or can talk. Pero what if, okay, naging unconscious ang patient pala? Na? So, unconscious ang patient natin, sir. Tapos, syempre, di ba? Okay, automatic, pag-arrive mo sa scene, okay, na? Tapos, ang O2 sat, or let's say, ang GCS niya, guys, is less than 8 pack. Ano gagawin natin? Anyone? Ano gagawin? The best management here is that there should be a rapid sequence intubation. Rapid sequence intubation. RSI, okay, that means rapid sequence intubation. What if nag-failed ka? Now, what if nag-failed yung intubation mo? Don't worry, guys. Kasi 3 plus 1, okay, failed intubation, meaning 4 attempts dapat na mag-intubate ka. Ayan, pag mali-mali pa rin, or let's say hindi talaga nakapasok, then that's the time, guys, na mag-supraglottic airway po tayo. Pag hindi pa rin ang supraglottic airway, then you need to have the emergency cricothyroidotomy. Diba? Sa cricothyroid po natin, at gagamit po tayo ng scalpel 10, number 10. Ayan. Pero done by doctors po yan. Done by paramedics po. Na yung mga, the cricothyroidotomy. Mag-open po ng airway. Kasi, diba, we need to maintain kasi a good airway dito. A patent dapat na airway. Okay? Next, we have the unconscious po. So, basically, pag unconscious, guys, you need to have the rapid sequence, okay, intubation. Now, let's discuss, okay, life threats. Under airway po, may mga tinatawag tayong life threats. Ano ba yung mga example ng life threats po natin? So, number 1, okay, it can be face, no? Neck injury. So, may face tayo. Malamang may face talaga tayo. So, may face, may neck injuries tayo. So, we have the, ayan, high C-spine injury. High. Ayan, C-spine. Ayan, injury po tayo. Aside from high C-spine injury, next one, guys, we have the burns. Sulat natin. Ayan, ito yung mga possible na problems po natin okay, sa tinatawag ng airway. What if si patient ba, okay, anatomically, may mga face and neck injury, na? Ayan, what if si patient pala, okay, may high, okay, C-spine, okay, what na injury? So malamang airway, problem natin. Kasi nung sabi ko, C3, 4, and 5 to keep the diaphragm alive. So pag may problem ka doon, malamang may problem ka sa respiration. Next, we have the burns. Okay, pwedeng thermal, okay, pwedeng inhalation. Okay, ng mga injuries pa. Sige nga. Sa face, okay, and neck injuries, guys, ang i-check po natin, what if, okay, may what? The letter S, letter B, and then we have the letter C, ang patient natin. So you observe for what? Na may swelling ba ang patient? Next, ano ba? Okay, ano pa, rather? May bleeding ba si patient, guys? Ayan, next, may crepitus ba ang patient natin? When we say crepitus, di ba may mga popping sound po tayo? Baka may mga subcutaneous pala na mga crepitus ang patient natin or the subcutaneous emphysema, which is actually a sign of what? Na? Pneumothorax. Baka nag-pneumothorax ang patient natin. So we have the swelling or basically, okay, called the edema. Ayan, so malamang it will obstruct the airway talaga. Di ba? Laryngeal edema. No? Malalaman mo din pa may laryngeal edema. Kasi usually may mga stridor ang patient natin. When we say stridor, ayan, ito ba yung hininga ng mga stridor? Siyempre hindi. Na, ang stridor kasi it's a harsh, shrill sound heard during inhalation. Na usually, mga ganon. Right? So it's your, okay, stridor, which is a sign of laryngeal edema. More so, no, it can be a sign of what kasi mga severe pneumonia, diba yung mga stridor po natin. Na? So we have the bleeding. And usually, it can be a nasopharyngeal na bleeding pala. So, okay lang si patient. Pero mamaya, biglang mag-desat ang patient natin. Next, we have the crepitus. You palpate also for the crepitus. Yung mga popping sound, mga vibrating sound. Na? That can be a sign of pneumothorax po. Next, we have the high C-spine. Okay, na injury. Siyempre, magkaroon ng respiratory failure ang patient natin. Okay, so we have the respiratory failure. Next, we have the burns. Dalawa yan eh. We have the inhalation. Ayan, so we have the inhalation burns. Next, we have the thermal. Ayan, na sa skin. Okay, pag inhalation burns po, okay, or let's say inhalation injury, guys, that leads to hypoxia. Or decrease po ang oxygen sa surrounding tissues po natin. Next, we have the thermal injury. Ayan, that definitely causes, okay, an edema. So pag may edema po tayo, syempre may obstruction po tayo kasi may narrowing. Diba, dadaanan tinatawag na okay, ventilation po. So we are done now with the life threats such as face, neck injuries, okay, high C-spine injury, and then we have the burns. Now, let's discuss okay, the airway management. Ayan, airway. Ayan, management po. Paano ba minamanage ang airway, guys? Okay, based on the primary okay, assessment po. So, very common po, okay, na you need to intubate a patient. Diba? Only for paramedics, only pag physician ka. Next, okay, be ready. Ito na. Be ready, okay, for what? Na difficult airway. Ayan, be ready for difficult airway kasi ang kalaban mo dito bleeding, di ba? Ang kalaban mo dito edema. Okay lang sana kung walking, x-ray ka, di ba? Walking ultrasound ka. Ito kasi with just your naked eye and your naked ear also because you're going to hear for what? Na obvious din kasi changes. Ayan, next we have okay, maintain. Ayan, you need to maintain, okay, spinal. Ayan, spinal immobilization. Sulat natin. Maintain spinal immobilization. Ma'am Joy, clear pa naman, ma'am, na? Ayan, and lastly, guys, we have the surgical, okay, airway po. When we say surgical airway, this is emergency cricothyroidotomy in which gagamit ka ng scalpel, guys, tapos i-open yung cricothyroid po natin. Especially for, di ba, familiar with the tracheostomy. Kung saan pinaperform ang tracheostomy, guys, doon din pinaperform ang cricothyroidotomy. But syempre, okay, performed by okay, physicians po yan or performed by doctors po natin. So, quick recap lang po, okay, with your airway. Kasi primary assessment tayo. So, airway. So, you need to, if the patient can talk, okay, whether the patient cannot talk or unconscious patient, guys. So we have the life threats, na very common, face and neck injury, high C-spine injury, and then we have the burns. You consider them. Ayan, immediate airway management. Simply, you need to intubate the patient if paramedic level na po. Ayan, be ready for. Ayan, you anticipate, okay, for further problems. But again, to maintain, okay, di ba? Maintain dapat spine immobilization to not further cause, okay, any damage pa. Kasi mas nag-damage na, mas lalo madadamage pa, mas lalo magkakaroon ng respiratory failure si patient. Okay, next we have the okay, surgical, okay, airway po. And that's ayan, yung cricothyroidotomy po natin. Ayan, next topic po will be, okay, the breathing. Ayan, breathing na po tayo. Ayan, sige nga. Check muna natin yung mga estudyante natin. Kung, okay pa ba sila? Check ko lang. Ayan, for a while ha. Ayan, saan ba yung mga estudyante natin? Kung sino pa. Ayan, from Rapu-Rapu, ma'am, thumbs up sign na lang kung okay pa. Yes, na-miss ko kayo, guys. Ayan, sa PDMDH, PDMDH, ma'am, kamusta po? Sila, sir, kamusta dyan? Ayan. Ayan, okay naman sila, sir. Hi, sir, good morning po. Sa PDMDH. Ayan. Si Sir Mark Arizala, kamusta naman dyan, sir? Ayan, okay naman, sir. Ayan, si Ma'am Yola, ayan, nakalagay talaga, Yola's iPhone. Si Shal, ayan, yung mga po natin, taga-tabako. Ma'am, kamusta naman po? Grabe na yung social distancing natin dyan, mama. Parang 1 kilometro na ata yan. Ayan, si Sir Gilbert. Sir Gilbert, okay pa naman, Sir Gilbert? Ayan, naka-thumbs up si Sir Gilbert, Ayan, sila Sir PDMDH, from what Anong hospital nga, sir, ang PDMDH? Ano ba to? Sa Ma'am Joy? Ang
Yes,
PDMDH,
sir.
ma'am. Ano nga ang PDMDH, ma'am? Saang hospital nga sila, ma'am? Ano nga yung
Haba po
PDMDH?
ito, sir. Wait lang po. Sino pong participant ang nasa PDMDH?
Ayan, sila sir. So is it ano ba? Piodaran.
Theodoran
Ay,
Memorial.
Piodaran. Saan bandang Piodaran, ma'am?
Sa Albay yan, sir. Hindi nyo kasi
Sa
yan, sir,
Albay.
dinadaanan. Bago,
Sa
sa may
Albay.
malapit yan sa may ligaw, ganyan.
Ay, nice na. Basta
Ang
of course,
nandyan ata sina Sir Jesus and sina Sir Mark Joven.
okay. Ayan, si Ma'am Bueno. Ma'am, okay ka pa dyan, ma'am? Or kagigising mo lang, ma'am? Ayan na. So, guys, expect na may mga ano tayo ha. Let's say, bigla ako nag-screenshot na ng mga pictures po natin, di ba? O dapat ready din kayo. Ayan, kasi nag-screenshot po tayo eh. Okay? Ayan, si Ma'am Aquino. Ma'am, okay ka pa dyan, ma'am? Asan na si Ma'am Aquino? Ayan, all the way from vegan pa, guys. Ayan, sige pa. Ayan, to check lang din kung okay pa ba yung mga kasamahan po natin. Okay, so this will be my last topic before our break, and that's the breathing. Ayan, for a while. Ayan. Pag i-click ko ba to, ayan, mic. Ayan. Naka-on na naman, no? Naka-on naman ang ano, 'di ba? Ang microphone po natin. So we have the breathing, okay, as part of the primary assessment, guys. So ang technique po natin dito, guys, is that you need to look, na. Ayan, next you need to what? Na listen also. Sulat muna natin. So we have ready. Ayan, unahin muna natin si listen. Wag mo muna si look. Okay, listen. Okay, you need to look also. Next, ano pa? You need to count. Aside from counting, okay, you need to monitor also. Ayan, importante to, especially for the monitoring device, di ba? Ayan, ano ba yung mga ililisten po natin? So basically, you need to listen for what? Normal, okay, breath sounds, or basically bilateral breath sounds dapat. Ayan, listen, okay, for bilateral breath, okay, sounds. Pag sinabi po natin bilateral breath sounds, guys, dapat both lungs na should be ventilated dapat. It should be well expanded. Kasi pag absent po yung isa, wait lang, but parang wala na akong naririnig sa isang lung. Okay. That can be a sign of what? That can be a sign of tension pneumothorax. That can be a sign of another problem, guys. That can be a sign of complication. So malaman si doktor, okay, na tapos may hypoxia, 'di ba si patient, tapos may mga chest pain pa ang patient natin. Then you need to have your what? Immediate dapat na needle decompression dapat. When we say needle decompression, to decompress. Kasi masyadong compressed na okay, ang lung na 'yon. Sobrang overly inflated. So you need to decompress by simply having the needle, okay, decompression. Next, okay, we have the look. Na basically, when we say look po, it's the gestalt, okay, effort. Ayan, the gestalt, okay, effort po. When we say, okay, the gestalt effort, guys, it's the overall effort ng patient natin. Ayan, I am referring to the respiratory, okay, effort ng patient po. Pag sinabi natin respiratory effort, di ba, pwedeng gamanito ang patient. Gumaganon si patient. Or pwedeng si patient, guys, nagpo-push up siya para makahinga lang. Na there's something wrong. Ayan, bakit todo effort ang patient mo? Yun pala, guys, may tension pneumothorax na ang patient natin. Gusto niyang huminga, okay, para what? Na para mag-survive lang. Na? Siya mismo anxious din siya. And then, ganito. Sorry. Guys, napansin niyo ba yung nangyari kay Floyd? yung negro po, sorry for the term. Okay, yung African American, 'di ba? Anong ginawa sa kanya? Kinompress lang yung neck niya. Anong nangyari doon? Na-compress actually ang pulse niya. And that's really what? Yung carotid, okay, artery po. Tapos, 'di ba nagmo-move pa yung legs ng lalaki? Guys, that's actually a sign of what? Vagal maneuver. So, pag may vagal maneuver po tayo, na-stimulate po yung vagus nerve, kaya bumagal ang pagtibok ng puso ng patient. Kaya namatay yung patient na yan. Na hindi po siya namatay brought about by neck injury, but namatay po siya sa vagal maneuver na stimulation. And the Valsalva, the vagal maneuvers po natin. Kaya kawawa yung negro na yun. Kaya 'di ba, it caused na a commotion po, 'di ba? Yung iba nagrarally, yung iba nagpo-protesta para some of them are looting, 'di ba? Pag nanakaw na kasi yun, it's a crime already. It's not a protest. Ayan, next you need to count. Eto na, you count for the RR. Some of us here nagka-count ng RR pero hindi naman tumitingin sa relo. So useless lang din, 'di ba? Ang tawag doon magic, 'di ba? Nilagyan mo ng magic sarap para malaman mo. Kasi some of us here sobrang galing sa vital sign. Ma'am, kamusta ka? Ay, okay naman nurse. Okay, okay lahat ng vital sign. Na, sir, kamusta ang ulo mo? Masakit ba? Ayan, okay lang naman nurse. Okay, so BP 110 over 70. Pero pag sinabi niya masakit, okay, 140. Okay, over 110 or 120. Di ba sa American Heart Association ngayon, ang basic requirement po is what? It's your, ilan nga ulit yan? Ayan, pag 130 guys, ang systolic mo, that's already sign of what? Hypertension. Kamusta naman ang BP ko na 145? Pero depende lang. Pag galit ako, 160. Pag normal, 110, pwede na. Pwede na yan. Ayan, of course, that's normal. So we have the monitor. Okay, you need to monitor for the O2 sat. So we have the O2 saturation, guys, with the use of the pulse. Okay, oximeter po natin. Ayan. So aside from your look, listen, feel, and then you count, and then you monitor, guys, I would just like to introduce yung mga life threats po natin. Yung mga pulmonary, life threats. What are examples of pulmonary life threats natin nangyayari po? Because that causes a problem sa breathing natin. Number one, it can be brought about by the tension pneumothorax. Tension. Pneumo. Thorax. It can be brought about by open pneumothorax. Open thorax. Next, it can be brought about by flail chest. Diba? Yung mga flail, di fail. Flail chest. Yung may mga paradoxical movement of the said chest. Next, we have the massive, hemothorax. So we have the massive, hemo, thorax. Guys, pag sinabi po natin pneumo, that means air. Ito, air, pneumothorax. Pero pag sinabi mong hemothorax, that means what? Blood, di ba? So, ito yung mga life threats po natin. So, we have the breathing management. Sulat natin. Sir, ano ba yung mga management natin? These are the breathing management under the primary assessment. So, number one, there should be a supplemental oxygenation. Supplemental O2. Mamimili ka na lang. Whether a high flow or a low flow oxygen. There should be an emergency treatment din. Natapos once stable, if ever kung stable ang patient natin, guys, chest x-ray po tayo. If ever kung stable, pero pag hindi naman stable ang patient natin, ba't ka mapapa-x-ray? Pag sinabi po nating management, supplemental oxygen, emergency treatment, sir. When we say emergency treatment, guys, depende yan, nasa problem po natin. Depende, sa what? May tinatawag na pulmonary, na threats po natin. Ano ba yung mga pulmonary life threats natin? So number one, we have the tension pneumothorax. How do we manage tension pneumothorax? It's basically brought about by the management known as the needle decompression. Magni-needle, decompression ka lang. It should be, what? At the second intercostal space, mid-clavicular line. So this is your declavicle. Second intercostal space lang po. Or basically 1 cm lang yan. Below the clavicle, right? So gagamit ka lang ng gauge 14 to 16 angiocath. And then make sure pagpasok mo, guys, it should be an open one na para diretso labas agad ang air, right? Kasi ang mga needle na yan yung iba kasi gagamit po ng syringe tapos naka-close naman ang syringe, 'di ba? May nakikita ko mga videos na gano'n which is really mali. Dapat needle na diretso, okay? Or yung ibang doctor kasi needle tas may plunger. Tapos, pag-insert, tatanggalin as in like yung plunger talaga para labas agad ang air. Okay, that's for the tension pneumothorax. Kasi, pag grabe ang, guys, pag grabe kasi ang air na nasa lungs mo, papangit po ang what? Na cardiac output mo, ang venous return mo, papangit. Kasi makakompress yung heart Ayan, so damay-damay na yan. Okay, next we have the open pneumothorax. Okay, pag open pneumothorax, guys, there should be an occlusive therapy. Ayan, occlusive. Ayan, therapy po. When I say occlusive therapy, you need to apply direct pressure dapat. Yung mga vaso-occlusive dressing po natin. Familiar? Ayan, yung mga vaselinized gauze, right? Ayan, next we have the flail chest. Question. What if nasa scene ka, tapos wala kang gauze? Number one, tanga ka kasi wala kang gauze. Okay, bakit wala kang mga vaso-occlusive dressing? Pero if ever, guys, na kung ganun na, andun ka na, wala nang bawian, you can actually cover it using the gloved hand. Pwede ka, i-apply mo lang yan. So, that basically occludes, from open pneumothorax na prevent mo na magkaroon ng tension pneumothorax. Next, pag flail chest naman po, there should be a supportive dapat na intubation. There should be a supportive, intubation dapat kay patient. Next, we have the massive, hemothorax. Pag may massive hemothorax, guys, there should be a tube dapat. Okay, that's for the tube, thoracostomy. Costomy. So, chest tube thoracostomy or the CTT insertion po natin. Pag may massive, may hemothorax po. Okay? Ayan, now, to further, supplement po, ayan, I'll be showing a video, regarding, tension pneumothorax. Okay, para mag-end na po ang breathing natin. And after the video po, ayan, we'll be having, the lunch break po for an hour. Okay? Ayan, Ma'am Joy. Ayan, clear pa naman, no? Ayan, naririnig pa naman po. Ayan, sige po. I'll be showing a video po regarding, the tension pneumothorax.
So let's start off with tension pneumothorax, which is probably the most common and the most serious of the pulmonary life threats. How does the tension pneumothorax work? Well, very simply, a pneumothorax occurs when air enters the pleural cavity. In trauma, this is typically happening because of a direct injury to the lung. So if you have a stab wound to the chest, you penetrate the lung, air leaks out of the lung parenchyma into the pleural space. In blunt trauma, it's often rib fractures that will penetrate the lung, causing development of a pneumothorax. A tension pneumothorax is a special subtype of pneumothorax which occurs when you have a one-way valve effect in the pleural space. So basically what happens in a tension pneumo is during inspiration, the patient is able to suck air through the trachea, through the lung, and out into the pleural space. But then during expiration, that one-way valve slams shut and the air that entered the pleural space is unable to get back out. So what happens is with each and every breath, the patient pulls more and more and more and more air into the pleural space, which causes a large high-pressure air collection. So what are the complications of this? Well, one, your patient will almost invariably be hypoxic because the tension pneumothorax will start off compressing the lung on the affected side, but as it gets bigger and bigger and bigger, it's going to shift the mediastinum over to the contralateral side and cause compression on that side as well. So you get significant hypoxia because the lungs are mechanically squished and unable to work properly. You also get impaired cardiac filling. So direct compression of the mediastinum from the large air collection is going to compress the heart and prevent the heart from filling normally. And lastly, you get impaired venous return. So in normal physiology, blood comes back from the periphery into the central circulation because of negative interthoracic pressure. You can imagine if you have a large high pressure air collection in the chest that your interthoracic pressure is going to be positive. So now you don't have a pressure gradient that propels blood from the periphery back to the heart, and this is going to further impair your cardiac filling and your cardiac output. So when we're trying to diagnose a tension pneumothorax, we want to listen for unilaterally absent breath sounds. This is why the first step of our primary survey for breathing is bilateral auscultation of the lungs. If breath sounds are absent on one side, you should strongly suspect a tension pneumothorax. We also want to look for evidence of respiratory distress. Our patients with pneumothoraces are often working very, very hard to breathe because their chest is already hyperexpanded with this big air collection. So they have to work hard to pull air into that overinflated chest, and they'll have clinical distress on exam. They're almost invariably going to be tachypnic for the same reason. We already talked about why they would become hypoxic. And then, as you can imagine, the trachea is going to be deviated away from the lesion because this big expanding air collection is going to push everything off to the other side. So an important thing to remember about tension pneumothorax is it doesn't just affect the lung. In addition to respiratory impairment, our patients are going to have shock. So I already mentioned that you have impaired venous return. You have mechanical compression of the heart. This is going to prevent normal cardiac output from taking place. So these patients are going to be tachycardic, they may be hypotensive, and tension pneumothorax represents a form of obstructive shock. So we want to look not only for evidence of pulmonary compromise, but also for evidence of circulatory compromise in our patients with tension pneumo. Now, tension pneumothorax is not usually a radiologic diagnosis. Usually this is something we diagnose clinically. But if you do happen to get an X-ray, there are some characteristic findings that you're going to expect to see. On this image, we have lines outlining the separation of the lung from the pleural space. Now, this patient must have some underlying lung pathology because you can actually see that the lung tissue is tethered to the pleura in one location. Maybe he has some old scarring in that region from a prior injury. Hard to know. But he's got two regions of air where you don't see any lung markings, and those are denoted here and here. So you can see the line demarcating the lung tissue from empty airspace, and you can actually see inside of the air collections that there aren't any lung markings. You also see inferior displacement of the diaphragm. So on the patient's right-hand side, I've outlined the normal contour of the diaphragm, and on the left-hand side, you can see it's pushed down much lower. And that's because this high-pressure air collection is taking up a lot of room in the chest and actually displacing it inferiorly. And for the same reason, it's displacing the mediastinum, which is normally a left-sided structure, into the middle or right-hand side of the chest. Now, you don't want to get this X-ray. Tension pneumothorax is a clinical diagnosis. Getting an X-ray of a patient with a suspected tension pneumo is only going to delay your treatment for the patient, and it's not necessary. So if you have a clear-cut tension pneumo on clinical grounds, go ahead and treat it. Don't wait around for radiographic confirmation. So what are we going to do to treat a tension pneumothorax? Very simply, the first-line treatment is needle decompression. And what we're doing when we decompress the lung is allowing air to get out of the pleural space. So if I've got a big high pressure air collection here in my chest, the goal of decompressing is to make a conduit between the inside of my chest and the outside world that'll let that air escape. And what's going to happen is that's going to equilibrate the pressure inside of my pleural space with the atmospheric pressure. However, it's not going to make my pneumothorax go away. It's not going to actually restore negative pleural pressure. I'm still going to need a chest tube, but it's going to decompress the large air collection that is mechanically interfering with my cardiac function and my pulmonary function, and it's going to improve the clinical status of the patient very rapidly. So I do want to emphasize, it's a temporizing measure. It's not definitive treatment. What you're really doing when you decompress is you're taking a tension pneumothorax and you're converting it into a simple pneumothorax. Needle decompression is also not indicated for simple pneumothoraces because it doesn't do anything for those patients. We only use it for unstable patients with tension pneumothorax, and the goal is to restore their normal perfusion and normal oxygenation while we go about providing them with definitive treatment. So how do you do the procedure? It's actually a very simple and straightforward procedure, and it's incredibly rewarding to perform because patients go from being an extremis to being stable and comfortable and happy very, very quickly. So if you get a chance to do this, I think you'll find it to be very satisfying. The way it works is you take a 14 or 16 gauge angiocath, or basically any large bore angiocath or needle, and you're going to insert it at the second intercostal space in the midclavicular line. So you're going to palpate both sides of the clavicle. You're going to identify the midclavicular line, and then the second interspace is typically about 1 centimeter below that. So that's what you're going to aim for. You also can use the fourth or fifth interspace in the anterior axillary line if that anatomy is more favorable for your patient. Either one is acceptable. So once you've inserted the needle, this is the really important part. You need to make sure that the needle is open to room air. So you want to insert the needle or angiocath in as far as it goes, and then you want to take off your syringe, take off your needle lock, anything that might be obstructing the end of your catheter, and you want to let the pleural space communicate with the air in the room. The goal, again, is to let air go from the pleura out into the atmosphere. In addition to needle decompression, there are other elements of treatment that you want to perform. Of course, you want to give these patients supplemental oxygen to help decrease their respiratory distress and ensure that they're not hypoxic. You want to avoid positive pressure ventilation until such time as you've addressed the tension pneumothorax. Because as you can imagine, when we put a patient on positive pressure ventilation, we are actually pushing air down into their lungs. And if they have an injury that's led to a tension pneumothorax, we're going to be pushing air out through that injury into the pleural space and expanding the pneumothorax, which is going to make them worse. So if your patient needs to be intubated, if they need to be mechanically ventilated, you should do that after you've already addressed your pneumothorax. You also want to place a chest tube once your patient is stabilized. So you're going to insert a large caliber chest tube onto the affected side, and that's what's going to restore your negative pleural pressure and allow the lung to heal. This is necessary in order to allow the lung to fully re-expand and eventually allow it to seal off the defect that caused the tension pneumothorax in the first place. So just a quick compare and contrast between tension and simple pneumothorax, because it's really important to be able to differentiate between them since the treatment is so different. First and foremost, hypoxia. Patients with tension pneumo often have severe hypoxia, whereas patients with simple pneumothorax might be slightly hypoxic, but typically it's not extreme. Tension pneumothorax causes shock because of the physiology we've already described, whereas simple pneumothorax should never cause shock. Simple pneumothorax does not impair cardiac function, it does not impair venous return, and it should have no hemodynamic consequences. Breath sounds in tension pneumothorax are almost always going to be completely absent on the affected side, whereas in simple pneumothorax, you might have normal breath sounds, you might have reduced breath sounds. If the pneumo is large, you may even have absent breath sounds, but it's much more typical to be able to hear something, whereas in a tension pneumo, you can often hear nothing. For tension pneumothorax, we temporize the patient with needle decompression. So we're going to go and stick a needle in the affected side to allow air to escape from the pleural space. Whereas in simple pneumothorax, that procedure is not indicated and really only carries risk with no benefit. So we would never do it. Patients with tension pneumo always need definitive treatment with a chest tube, and patients with simple pneumothoraces often do as well. It's quite common that we place chest tubes in those patients, but for small pneumothoraces, sometimes you can treat just with high-flow oxygen, or in some cases you can use pleural drains, pigtail catheters, etc., as opposed to a large caliber chest tube. So you've got a few more treatment options available to you for simple pneumothorax. With tension pneumo, you're always going to go for a chest tube. All right, so the bottom line on tension pneumothorax is you should always suspect it in patients with chest trauma who have unilaterally absent breath sounds, hypoxia or severe respiratory distress, or shock. Those are the things that should make you think about tension pneumo. And when you're concerned about a tension pneumo, you want to make the diagnosis clinically. Once you've made the diagnosis, you're going to perform a needle decompression in order to temporize the patient. And then once they're stabilized, you're going to place a chest tube, which will serve as their definitive management.
Okay, guys, so that ends our first part na po. So we need to have our 1 hour break. So, and then mamaya po, introduce na po namin yung exam nila. para ayan, luto na po yung pagkain. So, sige po. Ma'am Joy, mag 1 hour break na po sila, ma'am. So, 8 o'clock na lang din. Okay lang ba? Okay, sige po. Ano lang tayo? Check muna tayo ng mga internet connections nila. Ano po, yung mga tobacco nurses po natin. Ma'am, kamusta po yung ano natin dyan? Internet po? Kamusta naman yung mga pagbuhay, pag-ibig po natin dyan, aside sa internet? Kasi at least kamustahin din natin. Ayan, si Sir Gilbert, kamusta naman po yung internet natin, sir? Okay naman? Pa-chat na lang po ha, pamay na lang po. Ma'am Maria Aquino, ma'am, kamusta naman po ang signal natin dyan, ma'am? Or baka kasi ako lang online, the rest, wala na. And Ma'am Maria, ayun. Ayan, thank you. Masyadong responsive to si Ma'am Maria eh. Parang may good internet connection talaga to eh. Si Sir Mark Arizaga. Sir, kamusta naman po yung internet connection natin dyan, sir? Okay naman ba? Ayun, si Ma'am. Ayan, yung taga PDMDH naman po. Okay naman po ba yung internet connection natin? Ayun. Rapu-rapu. Yung rapu-rapu, di ba? Minsan wala kayong kuryente. Tama? Tama ba? Paghapon ba yon? Or paghapon meron na? Ayan, si Ma'am Caroline Brul. Ma'am, kamusta po yung internet natin dyan, ma'am? Present ba si Ma'am Caroline kaninang umaga? Parang ngayon ko lang nabasa yung name niya. Ay, hindi. Oo, tama pala. Present si Ma'am. Okay? So, guys, I will be showing you a video regarding the open pneumothorax.
Sir, present po kaninang umaga.
Ayun, si Ma'am. Present daw siya kaninang umaga. Sorry naman. Ayan, sige po. Kaya from time to time, guys, magpakita kayo ng picture. No? Pero pag babae, wag na kayo magpakita. Okay? Pag lalaki lang po. Na? Okay, so let's now have the video presentation of the open pneumothorax. So it will be an interactive kasi you can ask questions later. So let's now have the open pneumothorax discussion.
All right, now we're going to move on to some other pulmonary life threats. The next one is open pneumothorax. So open pneumothorax is kind of interesting physiologically. This happens when you have a large open defect in the chest wall. And if we all remember our fluid flow physics, when you have a tube and you're trying to determine the rate of flow through that tube, the primary determinant of flow is going to be the radius of the tube. And then the second most important determinant is the length. So if you think about your trachea as a tube and you think about the hole in your chest wall as a tube, you can imagine the chest wall is a much shorter tube, right? It's a lot smaller than the trachea. So when that wound goes up to 2/3 of the tracheal diameter, it doesn't have to be the size of the trachea or bigger than the trachea. It can still be smaller because the tube is so much shorter. When that happens, inspiration is going to preferentially pull air through the wound into the pleural space rather than going down the trachea and into the lungs. So if you have a large enough defect here, you're not going to pull air through the bronchial tree the way you're supposed to. You're going to pull air in directly through the wound when you breathe. Now, as you can imagine, if you're just sucking air into your pleural space through a hole in your chest, that's going to render your ventilation pretty ineffective. So this can result in lethal hypoxia and respiratory failure if it's not treated promptly. So again, large wound in the chest wall on physical exam, anything bigger than 2/3 the size of the trachea is going to cause air to preferentially flow into the wound. This is also known as a sucking chest wound, and that's because these wounds make a delightful sucking sound during the respiratory cycle. You can actually hear air being pulled in through the wound, and it goes with every respiratory effort. It's going to cause hypoxia and respiratory distress, and you don't need radiologic confirmation for this. You can actually see the wound, you can hear the sucking sound, you can appreciate the patient's respiratory distress. You're going to go ahead and treat it. So the treatment is very satisfyingly simple. You basically just place an occlusive dressing over the wound. And what's going to happen when you do that is when the patient breathes in, now you've got the hole occluded. So it's going to suck the dressing up against the chest wall, but it's not going to let any air go through the wound. Well, if air can't get through the wound, where's it going to go? Now it's going to go down through the trachea into the bronchial tree where it belongs. However, we want to make sure that we allow air to escape from this wound during exhalation, because you don't know what kind of injury there is to the underlying lung, and you don't want to create a tension pneumothorax. So the way we do this is by securing the occlusive dressing only on 3 sides, and that creates a one-way valve effect. So when the patient breathes in, no air goes through the wound, but when they breathe out, air can escape out through the wound if it needs to, and that's going to prevent the development of a tension pneumothorax. These patients always need chest tubes for definitive management. Again, the lung's not going to be able to re-expand and heal unless you restore the negative interthoracic pressure, which is accomplished with a chest tube. And there is a high incidence of underlying injury. You can imagine that any kind of traumatic mechanism that makes a big hole in your chest wall is going to be very likely to be associated with other pathology. So these patients often end up going to the operating room for other reasons. All right, next pulmonary life threat to talk about is flail chest. Flail chest occurs when you have multiple rib fractures. So basically, if you have multiple fractures of ribs that are adjacent to one another, and the fractures are present in 2 different locations, you get a section of rib that is discontinuous from the rest of the thoracic cage. Well, what's going to happen to that section of rib? It's not tethered down to the other ribs now, so it's not going to move normally during the respiratory cycle. It's going to actually move paradoxically. So normally when you breathe in, your ribs follow that bucket handle motion and sort of expand. But now you've got a section of chest wall that's not going to do that. It's going to go and suck up against the lung during inspiration. This is going to directly impair ventilation, right? Because now you have a section of rib that's floating around doing its own thing, and it's going to also be strongly associated with underlying pulmonary contusion because this section of rib, one, it got broken somehow, so clearly there's going to be a high likelihood of transmission of energy to the underlying lung. And 2, you are repeatedly injuring the lung by pulling this section of rib up against it over and over again. So patients with flail chest, you're going to be able to physically see a chest wall deformity on your clinical exam. This is not going to be a subtle finding. You're going to see that paradoxical chest wall movement in the area of affected rib. You're going to see infiltrates on your chest x-ray, which are suggestive of underlying pulmonary contusion. And the treatment for this in the ED is really going to be supportive. We're going to want to make sure that we provide the patient with supplemental oxygen, that we maintain their oxygenation, that we intubate and mechanically ventilate them if they are in significant respiratory distress. But there's not really any definitive treatment that we can offer for this in the ED setting. In many cases, these patients with supportive care will just go on to heal their rib fractures and be fine, although there are situations where surgical fixation of the chest wall might be necessary.
Hello, Ma'am Joy.
Yes, sir.
Yes, sir.
Ayan, ma'am, clear naman po yung ma'am, no? Yung audio, ma'am.
Yes.
Yes.
Ayan, wala namang naririnig na iba, ma'am, no? Like TV or radio. Wala naman, ma'am, no?
Wala po.
Wala po.
Okay. Sige, pa-chat na lang sa mga po natin, sa mga estudyante, sa mga viewers po natin para at least ma-check po namin kung present na ba or online na po sila. Ma'am, are we all set na po, ma'am, no? Complete na po yung estudyante natin, ma'am.
Wait lang, sir.
Okay, ma'am. So basic requirement po, kailangan may coffee or may sachet. Tulad ko guys, may mga sachet po tayo ng coffee. And ang gawin po natin para hindi makatulog, i-open nyo lang po ito, tapos i-buhos nyo din sa mga mata nyo. Na? Nang sa ganon, mabubulag ka rin. Total, matagal naman tayong bulag sa katotohanan. Lalo na sa pag-ibig, guys. Ayan, sige po. So, let's continue na. Ayan, so my next topic, okay, since tapos na po tayo, di ba, sa airway, di ba, sa breathing, tapos na din po tayo. So, next topic po natin will be, ayan, what we call as the circulation. Ayan, for a while, we need to clear throats muna. Clear na po ang throat natin. Pwede nang i-suction. Ayan, excuse me. Ayan, sige po. So we have the word circulation. So guys, ayan, ma'am, naririnig naman po, ma'am, no? Ayan, so we have the next topic known as the circulation. Excuse me. Parang may bumabara. Sorry. Naka-mute naman eh. Ayan, sige po. So let's continue now. So we have the next topic known as the circulation. So guys, tapos na po tayo sa airway. Diba? Tapos na din tayo sa breathing natin, sa look, listen, and feel. So we have the next topic known as the circulation. Now, for the circulation, ano ba yung mga pinaka-importante dito, guys? So number one, we need to look. Ano ba yung mga hanapin natin? Next, we need to feel also for the said circulation. Ano ba dapat i-feel natin? Next, we need to monitor. Ano ba yung kailangang i-monitor dito? Dalawa lang yun eh. Of course, we have the pulse rate, and then we have the BP. Kasi 'di ba, malalaman po natin kung adequate ang circulation pag maganda ang BP at pag maganda ang pulse rate ni patient, pag nasa ideal po, na. Pero pag masyadong let's say, masyadong mabilis na or masyadong speed up na po ang pulse rate natin, then tachycardia will always be a first sign, okay, na nagbi-bleed na ang patient natin. From bleeding, baka magkaroon ng hemorrhagic shock. Okay, so yan, pangit po ang prognosis ni patient natin. Okay? So we have the circulation now. For the circulation, guys, you need to look for what? Of course, you need to look for the color. Ayan. Kamusta ang color ng patient natin? Is my patient pale? Ayan. Is my patient, okay, pinkish ba? Or perky, okay, in nature? So we have the pinkish patient. Or nag-violet na ba ang patient yung guys? No, nagba-black na ba? Kasi pag black na, malamang nag-decompose na yan. Nag-gangrenous na ang patient natin. So we have the color. Aside from the color po, again, you check for the level of consciousness ulit. Wanna know why? Kasi upon checking for the circulation, pag wala pong pulse ang patient natin, that's the best time for you to perform high-quality chest compression. So we have the high-quality chest compression. Ayan, next, we have the capillary refill time. Ayan, capillary refill time. Ideally, guys, it should be less than 2 seconds po. Tama? Kasi pag greater than 2 seconds, okay, that only means na pangit na po ang peripheral circulation po natin. And then you check also for external. Ayan, external bleeding. Ano ang sabi ko? Mas madali pang external bleeding compared to what we call as the internal bleeding. All right? Ayan, kaya vital signs is really essential here to check for bleeding. Na? So aside from upon looking or using the naked eye, you need to feel, na? Especially using the bare hands, or not bare hands, but basically gloved hand dapat, because we need to wear, di ba, yung mga PPEs po natin. Ayan. So you need to feel, for what? For peripheral pulses. So that natin, you need to feel, for peripheral pulses. Such as, ano yung mga peripheral pulses natin? Very common pa pag adult patient, we have the carotid pulse. Ayan. Next naman, pag child ang patient mo, so we have the femoral pulses. Ayan. Next, we have the radial pulses. Ayan. And lastly po, we have the dorsalis pedis. So we have the dorsalis, ayan, pedis. Diba? Ayan, ng mga foot arteries po natin or foot pulses, mga pedal pulses po natin. Okay? Ayan. So, when we say, ayan, ganito guys. Pag nag-check ka kasi ng peripheral pulses, let's say strong na, di ba? Ayan, tapos nakapa mo talaga ang carotid, that only means na pag nakapa mo siya, and that only means na, ayan, na ang kanyang systolic blood pressure is greater than, okay, 60. Right? Pag femoral naman po, pag nakapamo si femoral, tapos mabilis naman, ayan, no? Tapos nakapamo talaga, that only means na systolic blood pressure is above na 70 millimeter mercury. Tapos, okay, for the radial pulses naman po, guys, ayan, pag nakapamo siya, the systolic blood pressure is greater than 80. Pero pag si dorsalis pedis, ito, sir, bakit pinaka-the best si dorsalis pedis? Kasi usually, guys, na pag carotid artery, kasi what if may mga massive bleeding doon, may mga trauma, di ba? So, medyo mahihirapan kang magkapa. Pero what if, okay, dun ka na lang sa, ano, sa may paa, di ba? Ayan, so, ito, kunwari, ito paa mo, ha? Ayan, di ba dito, nakakapa siya dyan. Ayan, kaya nga di ba pag decap BTLS, decap BTLS, decap BTLS, tapos mag-check ka ng pulse, okay, the dorsalis pedis. Ayan, that only means, guys, na pag strong daw, pag maganda daw ang ano doon, ang pagtibok ng pulso doon, then the systolic blood pressure of the patient is greater than 90. Di ba? Basic requirement kasi ng American Heart Association, to know that the patient is stable daw, there should be a greater than 90, na 90/60 millimeter mercury of the said BP of the patient. So therefore, para masabi natin na okay ang kanyang BP, why not go directly? Okay, sa tinatawag na dorsalis pedis. Kaya nga di ba may mga ibang magagaling na EMS na responder? Ayan, pag-check pa lang nila, ayan na, pag mag-decap Btls, and then you need to check for the pulse ulit, for the dorsalis, okay, pedis na pulse. Ayan, masabi nila, okay, it's a strong pulse. So meaning to say, okay, so stable po ang BP ng patient natin. Pero pag pababa ang BP ng patient natin, that can be a sign of what? An obstructive shock. So therefore, okay, you need to manage it, okay, what? Immediately. So meaning to say, for severely traumatized patient, guys, the dorsalis pedis is actually the best pulse. Para masabi mo, okay, stable or unstable ang kanyang BP just by simply checking the pulse. O di ba? Ganun kagaling. Nag-check ka lang ng pulse, malalaman mo na ang BP ng patient natin. It's actually a form of estimation. Na? And then, highly, ano naman din talaga, close talaga daw, according to study. Okay? Ayan. So, we have here to monitor. Ano yung monitor natin, guys? So, number one, ayan, you need to monitor, okay, number one, the BP of the patient. What's the normal BP nga ulit? It's 110, okay, over 70 to 120/80. Pero ang sabi ngayon, pag nag-130 ka na, tapos greater than 90, guys, na ang diastolic mo, let's say 130, 130/90 is actually a sign of what? Na? It's a sign of hypertension according to American Heart Association. So aside from BP, you check the pulse rate also. Di ba? Meron tayong pag negative pulse, okay, not breathing, perform high quality chest compression. Pero pag si patient may pulso, pero hindi huminga, anong gagawin natin? You need to perform rescue breathing. Okay? So you need to monitor the BP and then the pulse rate. Anong sabi ko? What is, okay, the first sign, guys, okay, of bleeding nga ulit? This is actually a very, what, no common question, even sa board exam, sa NCLEX, na? So we have the word tachycardia. Malalaman mo lang daw na may bleeding ang patient pag, okay, mabilis na po ang heart rate ng patient natin. Ulitin ko lang. What's the normal pulse rate ulit? It's 60 to 100, okay, beats per minute. What is the term? Pag masyadong mabagal ang heart rate, less than, okay, 60, anong tawag doon? I can't hear you. So we have the word bradycardia. It's not brady, it's bradycardia. Pero pag masyado namang mabilis, anong tawag doon? Ayan, it's tachycardia. Right? Pag irregular naman ang rhythm, anong tawag doon? Arrhythmia or dysrhythmia. Now next, aside from monitoring po, you need to monitor also for the circulatory life threats. Ayan, may mga tinatawag kasi tayong circulatory, okay, life threats. When we say circulatory, okay, life threats, guys, iikot kasi ang what? Ang tanong sa tinatawag na obstructive shock. Ayan, when we say obstructive shock, okay, this is, okay, brought about by the most common reason known as the hemorrhagic. Ayan. This is brought about by hemorrhagic shock, brought about by trauma, di ba? Ayan. Next, aside from, okay, may mga, okay, related factors din tayo such as the tension, okay, pneumothorax, which is na-discuss na po kanina. And then lastly po, we have the so-called cardiac tamponade. Ayan, the cardiac, okay, tampo. Ayan, tamponade po natin. Now, paano ba minamanage to mamaya, na? Especially sa emergency treatment po natin. So ulitin ko lang. Ayan. Sa circulation po, may mga life threats tayo na you need to watch out. Watch out for obstructive shock. Okay, major cause nito will be the hemorrhagic shock. Next, we have the tension pneumothorax. And then we have the cardiac tamponade. Na? Ayan. So aside from that, let's proceed na po sa circulatory management po natin. Now, when we say circulatory management, okay, number one, you need to control the bleeding. Ayan. Control bleeding. Aside from controlling bleeding, guys, you need to have your IV access po. Ayan. May mga videos po tayo regarding, okay, that said IV. Ayan. Na aside from the IV access, ano ba dapat dito ang i-register sa IV access? Number one, there should be a two large, okay, bore. Ayan. So meaning two sites dapat tayo, ha? The left and the right using large bore. Okay, needle, large bore size. Okay, needles natin. Ano ba mga example ng large bore size needles? Okay, mga gauge 18 po natin. Very common yan. The gauge 18. And then there should be, okay, an IV. Ayan, the IV solution. Itong IV solution, guys, this is highly, controversial. Di ba dati kasi, it's more of plain NSS. Pero ngayon po, ang pinaka-latest, it should be, you need to get ready, okay, with the plain LR 500 ml. Ito kasi ibubolus muna natin initially. Wanna know why? Kasi ang plain NSS and plain LR kasi pareha silang isotonic. Pero pag sinabi mong, okay, plain LR kasi, it battles hyperkalemia, in which, sa trauma patients po, very common ang hyperkalemia. So to battle hyperkalemia, guys, and to alkalinize, okay, everything, ayan, you need to let's say, give, okay, what we call as the plain LR. Pag nasa States ka, ang tawag nila the Hartman solution. Na? And pag sa Philippines po, commonly known as the plain LR or the PLR, right? Ayan, and then, okay, you need to have the BT. Guys, the blood transfusion is actually optional. If ever kung, may ready ka naman, no? Let's say, may ready kang bag, na? Pero kasi it's highly controversial Ang dami, tumataas din kasi ang cases ng deaths. Ayan, ng DT, sa tinatawag na pre-hospital setting, kasi hindi na properly cross-match or it can be ang dugo, na hindi nag-match, right? So improper po yung cross-matching natin. So increase po ang risk din diyan. So usually, the blood transfusion is optional pag ready, as in like super ready. Na? Alam mo ang cross, let's say ang blood type na patient mo. Ayan, diba? Aside from your letter D, we have the letter E, known as the emergency treatment. Ayan, sulat natin. So ulitin ko lang. Now, for the circulatory management po, simply you need to control bleeding. How do we control bleeding? By simply applying direct pressure. Ayan. Magda-direct pressure po tayo dyan. Next to, applying direct pressure, you need to have an IV access line. Ayan, both arms dapat yan. Kasi ganito, at risk na kasi for shock si patient. What if biglang may circulatory collapse? At least, yung isa, ayan, di ba? At least yung isa, patent pa. Kaya dapat both, dapat left and right, dapat may mga IV lines po tayo. So again, control bleeding. Next, we have the IV access. Ayan, two large bore size needle, usually gauge 18. IV solution. Ayan, the plain LR ideal. This is the most updated one known as the plain LR po. Na? Next, we have the blood transfusion, which is optional. And then, we have the emergency treatment. Now, guys, pag sinabi po nating emergency treatment, ayan, no? Iti-treat natin yung mga life threats po natin. Ano nga yung mga life threats natin kanina that leads to obstructive shock? Ano nga yun? Ayan, hemorrhagic shock. Ano pa? Tension pneumothorax. Ano pa? We have the cardiac tamponade. Now, how do we treat them ba? Ayan, let's say ganito. Emergency treatment, for the said hemorrhagic. Ayan, hemorrhagic. Ayan, shock. Paano ba iti-treat yan? Ayan, sir, paano ba mag-treat ng tension? Ayan, pneumothorax. Paano ba mag-treat ng tinatawag na the cardiac? Ayan, tamponade. Guys, para mag-treat ng tinatawag, let's say, emergency treatment for the said hemorrhagic shock, all you need to do is that there should be a direct or localized, pressure to stop the bleeding. Next, kasi ang daming, baka may mga bleeders ang patient natin. So we have the tension pneumothorax. Siyempre, na-discuss na po natin yung kanina. And that's the needle. Ayan, decom. Ayan, needle decompression. Aside from your tension pneumothorax, we have the cardiac tamponade. And walang ibang treatment po, and that's the pericardiocentesis. Ayan, cardio. Ayan, pericardio. Okay, centesis po. Okay, so these are the life threats. And these are basically the treatment po. Pag may hemorrhagic shock, apply pressure, localized pressure dapat. Pag tension pneumothorax naman, there should be needle decompression with the use of the 14 to 16 dapat na gauge ng tinatawag na needle natin. Na? Ayan, na angiocath needle po natin. Next, we have the cardiac tamponade in which kailangan po ng pericardiocentesis, or the pericardiocentesis. Okay? Ayan, questions muna? Questions? Ayan, before I proceed with the next topic known as the disability, and next will be the exposure. Questions muna tayo. And we will entertain questions na po. Questions, clarifications, guys? Ayan, no? Tapos from time to time, you need to chat din kung maganda ba ang connection nyo, or let's say nag-lag, or nawala yung boses ko, or nawala yung sound, nawala ang audio. Okay? Ayan. So next topic will be the disability. Ayan. When we say disability, what comes in your mind ba? It's a neurologic assessment. Na? Usually guys, na para mas madali po, you need to ask the patient, ma'am, can you squeeze my hand? Pag no response, GCS3, comatose patient. Pero nung in-squeeze ang hands mo, or iba ang in-squeeze, hindi ko alam kung anong iba ang in-squeeze. So therefore, maganda po ang sensorium ng patient natin. Di ba? Ayan, so we have the disability. And that only means na, okay, the sensorium of the patient. So basically, it's a form of assessment ulit. Ano ba usually ina-assess po natin dito? So number one, we have the level of consciousness. Di ba? We need to check for mga signs of what? The increased ICP. Kailangan yan. So we have the level of consciousness. So there's a battle between the AV-PU, ayan, na versus what we call the GCS. Next to level of consciousness, we have the pupillary reaction. Ayan. We have the pupillary reaction. What if fixed and dilated na? So malamang tai chi na si patient natin. Next, we have the four extremity movement. Sir, bakit kailangan ang tinatawag na four extremity movement? Para ma-check natin kung gaano ba ka-severe ang tinatawag na damage sa brain ng patient natin. Na? Next, we have the external signs of neck. Ayan, now aside sa neck injury, we have the head also. And you need to look for external signs of neck or head injury such as nag-bleed ba, di ba? Ayan, may mga open ba, mga ganon. No? May mga blunt trauma, may mga penetrating trauma ba? Ayan, next guys, ito, I want you to pay attention with the glucose level. Ayan, kasi ano nga ang in-emphasize ko kanina, kaya na-accidente si patient, baka masyadong hypoglycemic si patient, na baka nagbaba ang sensorium niya, kaya na-hypogly at nakatulog habang nagmamaneho, causing, another accident pa. Ayan, tapos nag-lead ng trauma sa kanya at nag-lead ng death din, especially sa mga makakabangga niya. Ayan. Ulitin ko lang, pag sinabi po natin, disability, so we have to check the level of consciousness of the patient. Ayan. Next, we have the pupillary reaction. So dapat may mga pen light tayo. Ayan. Next, we have the four extremity movement. We have the external signs, neck and head injury. Guys, actually, what if wala ka dong pen light, you can actually use the cell phone. Di ba may mga flashlight naman po yung cellphone natin? In case lang na wala talaga. That will be the last resort. Pero alam mo namang EMS ka, tapos wala kang pen light, so malamang hindi ka competent. Na? Ayan. Pero pag sa hospital naman, wag mo naman sigurong gamitin yung cellphone mo. Nakaka-ano naman kay patient, nakaka-offend naman. Pag gagamit ka ng the back of your cellphone, tapos gamitin mo yung flashlight. Na? Ang weird naman. No? Pero yung iba nga, di ba, alam yung mga pupillary reaction kahit walang assessment. Di ba, ganun kakagaling. Right? Ayan. Sige po, kahit wala nga tanong, di ba? Alam mo na anong GCS status ng patient mo. Siyempre, mas gusto nating ilagay na normal ang GCS status kasi para hindi toxic. Kasi the more na pababa ang GCS status niya, the more toxic ang patient natin. You got me? Ayan. Next, And we will discuss, okay, the neurologic, okay, life threats po. We have the neurological, ayan, neuro, okay, logic, ayan, life threats. When we say neurologic life threats, guys, iikot lamang ang sagot natin sa tinatawag na intracranial bleeding, no, mga cranial injury, ayan, such as number 1, we have the penetrating, ayan, cranial injury po. Aside from, okay, penetrating cranial injury, we have the intracranial hemorrhage. Intracranial, ayan, hemorrhage po. Aside from intracranial hemorrhage kasi, nahahati yan eh. Ang dami pang mga subtypes nito. So we have the subdural, ayan, subdural hematoma, epidural, ayan, epidural ayan, hematoma, or let's say mga bleeding natin. Next, we have the subarachnoid, ayan, subarachnoid, ayan, or the ayan, intracerebral, ayan, ng mga hematomas po natin. So meaning may mga hemorrhage, may mga bleedings nga po. Na kung saan, paano ba i-manage to? Siyempre, di ba, it's the surgical correction, di ba, surgical removal of the said clots na the usual treatment po. So aside from intracranial hemorrhage, guys, we have the diffuse axonal. And the diffuse axonal, ayan, injury. Just so you know, your diffuse, okay, axonal injury, guys, this is the most common po. Ayan. Na kung saan, the gray and the white matter of the said brain na are sheared, may shearing po. So meaning damage nga. And are you familiar with the shaken baby syndrome, yung batang sinushook ng mother, or let's say ng mga yaya, hanggang sa namatay ang bata? And that's okay, the diffuse axonal injury. This is also common sa motor vehicular accident. And that's again, ano yan? It's the diffuse axonal injury, the most common type of brain injury. And lastly po, we have the high, ayan, C-spine. Ayan, the high C-spine, ayan, injury po natin. So once again, what are, okay, the neurologic life threats? Number 1, we have the penetrating, meaning, okay, may trauma tayo. Ayan, may puncture tayo kasi penetrating, okay, cranial injury. Next, we have the intracranial hemorrhage, which causes stroke, malamang. Next, we have the most common one, we have the diffuse axonal, okay, injury. And then lastly, we have the high C-spine injury. Ano nga sabi ko? C3, C4, C5, ayan, to keep the the diaphragm alive. Pero pag, okay, may problema kasi C3, 4, and 5, expect for respiratory failure kay patient po natin. Alright? Ayan, next we have the disability management. Ayan, ability, okay, management. Sir, ano ba yung okay, mga ginagawa po sa tinatawag na disability as a form of na primary assessments po natin? Simply guys, na disability nga, so dapat mag-check ng GCS dapat. Na if less than 8 po, you need to intubate the patient. Alright? Pag less than 8. Ayan. Pero kasi ganito, kung i-apply po natin yan, pag let's say, di ba, sa mga nag-ACLS, para wag niyong makalimutan lang, di ba familiar, pag less than 3, you need to perform targeted temperature management, you need to cool down the temperature of the patient, di ba? 30 to 36. Pero kasi, intra-hospital kasi yon. Pero sige lang, parang naano ko lang. Kasi some of you here were my students din naman sa ACLS po. So next we have wala lang, para may ma-share lang din ako. So we have the supportive, ayan, the supportive care or the supportive management. When we say supportive care, supportive management, the focus is highly, okay, more of the oxygenation. Ayan, so we have the word oxygenation, and then dapat may magandang perfusion po tayo. Kasi pag oxygenation, magandang brain mo, di ba, magandang entire system. Tapos pag maganda din ang perfusion, maganda din ang system, na the rest will follow. Dire-diretso na yan. Next, okay, we have the emergent, okay, treatment po. When we say emergent treatment, guys, pwede naman po ang tinatawag na the non-contrast. Ayan, CT scan. Ayan. The non-contrast CT scan, syempre, ayan, it's a priority only if if andun ka na talaga sa hospital, na pagtapos ka na sa ABC. Ano nga sabi ko? Yung disability at saka yung exposure, nangyayari lamang po yan pag you're going to stay and then you play. Pero pag nag-load and go ka, malamang si non-contrast medium mangyayari na po sa hospital. Alam nga namang magbibit-bit ka ng CT scan, na habang pumunta ka sa isang squatter area, syempre imposible yon. Ilang milyones ang tinatawag na CT scan natin. Diba? It should be a non-contrast dapat. Na? Ayan. So aside, okay, from, okay, what we call as the disability. So, okay, we have the last topic, okay, on the primary assessment. And then after this, okay, we will be having a video na naman po. Na? Just an overview lang, okay, regarding kung ano ba yung mga nangyayari sa patient po natin. So we have expose. Naalala ba yung topic natin? We have the expose or exposure. And sa environment ng patient, sa environment also. So you expose. Wanna know why? Kasi, ayan, paano ka makaka-perform ng assessment? Paano ka makaka-perform? Sa States, yes, hinubara nila. But on the Philippine setting po, the privacy is really important. Diba? Kasi, syempre, pag Pinoy, na masyadong conservative, kuno. So we have the exposed. And then we have the environment. Ano bang ginagawa dito, sir? Remove all the clothing. Okay, remove, okay, all, okay, clothing, okay, after patient po. Pag nag-remove ka all clothing, okay, after patient natin, guys, then simply you're exposing the patient. But except for what? Na kailangan may privacy pa rin. So you keep the parts, diba, na kailangan itago, such as the boobs, diba, the genitals of the patient. Ayan, simply, you need to avoid, hypothermia. Guys, nangyayari pong hypothermia, lalo na pag less than 35 degrees Celsius, magulat ka na lang, si patient po ay hindi na humihinga, tapos very slow na ang heart rate ng patient natin. Ayan, next po, once you expose a patient, tapos sa environment po natin, you need to complete. There should be a complete head to toe. Guys, when we say, head to toe assessment, it should be what? Cephalocaudally dapat. From axilla to perineum, diba? So we have the axilla, to, perineum, at the back of the neck, roll the patient, roll to examine the back, and to examine, the back of the patient, including, sa may C-spine, but, the C-spine, but you need to maintain pa rin the alignment dapat, na yung spinal immobilization pa rin natin. You need to turn the patient to side, as one dapat, lug roll as one. Or else, pag naiwan po yung ulo ni patient, edi mas lalo nagkaroon ng cervical spine, fracture ang patient natin. Next, do not forget also, at the back, of the head. And don't forget, the back of the head. And the back, of the head. Kasi minsan, guys, may bleeding pala sa under ng let's say sa nape natin, sa may batok. Tapos, di ba, minsan nakakalimutan na po natin i-assess yan. Kasi feeling mo, okay na si patient kasi may C-collar. The C-collar, hindi scholar. The C-collar spine po natin. Cervical collar spine. So check pa rin. Check for some bleeding, di ba? Kaya nga tayo may D-cup Btls, di ba? D-cup Btls, tapos, D-cup Btls, hanggang sa pababa na yan. D-cup Btls, D-cup Btls. Okay? Questions. Questions po. Kasi halos lahat na po ay na-discuss ko na on the primary assessment po natin. I would like to encourage din everyone to ask questions po. Pa-chat na lang po if ever kung may mga questions. Ma'am Joy? Okay. So let's now, may mga tanong po ba sila, ma'am?
Wala pa naman.
Wala pa naman. Okay, guys. Since katatapos ko lang na mag-discuss ng disability, why not have, we need to have the lecture po, or let's say the video presentation of the how to check for the alteration
Times when you see someone who comes in. Hi, we're going to be talking about the approach to altered mental status, and specifically, we're going to be talking about how to approach altered mental status in the emergency department. We're going to start out by talking about some definitions here. So, altered mental status means that a patient is presenting confused. They have acute alteration in their higher cerebral function. And what that means is that they are going to have problems with their memory, they're going to have problems with their attention, and they're potentially going to have problems with their awareness. So they may not be able to fully cooperate or engage in an exam or in the history process with you. It's important to note that this is an acute change, so it's something that's different than what happened before. And it's important to distinguish this from dementia. So dementia is when someone has altered mental status that progresses over a longer period of time. Altered mental status is something that happens acutely, so it's something that happens days or hours before the patient comes into the emergency department, not something that happens over weeks to months. It's important to note that this is a symptom. It's not actually a diagnosis. So what that means is this is something that someone's going to be coming in complaining of. And our job in the emergency department is to look back and try and figure out what is causing this altered mental status. Delirium is another definition here, and what delirium means is it means that a patient has waxing and waning altered mental status. It's important to think about delirium in the sense that sometimes when you see someone who comes in, they may be acting normal or reasonably normal when you see them. In these patients, it's very important to get a history or some information from a family member or from someone who might know them a little bit better or can tell what's been going on. Because even though someone appears to be normal in the emergency department, it might be that they've had confusing episodes or have had concerning symptoms over the last hours to days. And it's very important that you try and get that information. When we're approaching altered mental status, there's a very broad differential. There's lots of different things that could be causing it. Dyspnea or shortness of breath is one of them, and dyspnea generally causes it by hypoxia, so your oxygen levels get very low, and that can cause altered mental status. Or if you are unable to ventilate appropriately and you have elevation in your carbon dioxide levels, that's another thing that can cause altered mental status. So it's very important that you get a history from the patient or from their medical record to see if they have a history of lung disease. Head trauma is something else that can make patients be altered. And it can make people be altered in various ways. So it can make them be altered because they have a concussion. It can make them be altered because they have bleeding in their brain. So there's various ways that a blow to the head or a head strike could make people be altered. Head trauma can happen if someone was in a car accident, if someone was, hit by a car, on a bicycle, lots of different mechanisms for head trauma. Fever is another thing that can cause altered mental status. It's very important when we're thinking about fever that we think about the most accurate way to measure temperature. So oftentimes temperature is measured orally by putting the thermometer in someone's mouth. And sometimes the temperature is measured with a forehead thermometer or with a thermometer in the ear. The most accurate temperature reading you can get, though, is a rectal temperature. So if you're worried that your patient has a fever that's not being detected using the other methods of taking a temperature, you may need to go ahead and go that extra step and take a rectal temperature for that patient. Electrolyte abnormalities also included in the differential here. The most common electrolyte abnormalities that can cause patients to be altered are a low sodium level. You can get low sodium levels by a variety of mechanisms. So by drinking too much free water, drinking too much water basically from the tap. Sometimes drinking too much beer can actually cause a low sodium level. Other electrolytes that can cause altered mental status would be an elevated potassium level, and then also an elevated sodium level as well can make patients be altered. And then infectious symptoms is something else that can cause altered mental status. So patients who have meningitis, which is an infection around the brain, patients who have pneumonia, patients who have a urinary tract infection, especially in elderly women, if they have a urinary tract infection, sometimes the only symptom they may present with is actually altered mental status. So very important to make sure that you're thinking about infection as a cause here when patients present with confusion. So what are the four most common causes that we want to make sure we're thinking about? So systemic disease that is affecting the central nervous system. And we talked about some of those already. Infection is definitely one of them that can do that. Fever sometimes as well. Primary intracranial disease. A classic thing here is if someone has something called a hemorrhagic stroke, which is basically bleeding into the brain tissue itself. Subarachnoid hemorrhage is another cause that can potentially cause people to be altered or confused. Exogenous toxins, those are substances that patients may ingest, whether they're illicit substances like alcohol or benzodiazepines or opioids, or medications that are prescribed also can sometimes cause patients to have altered mental status. And then drug withdrawal withdrawal states are very important to consider. The classic drug withdrawals that will cause altered mental status are alcohol withdrawal and benzodiazepine withdrawal. And when we're thinking about those are going to be reflected in the vital signs for patients. So patients can have an elevated heart rate, elevated blood pressure, and confusion. Some patients may present with seizures as well. So those are that's something definitely you want to make sure you're considering. Sometimes, again, that history can be challenging to get from a patient. So the medical record or talking with a family member or a friend or someone who knows the patient may benefit you. When we're thinking about patients who present confused, it's important to think about what doesn't cause altered mental status. So what are things that don't cause confusion or that we're not necessarily talking about here? Psychosis is one of them. Psychosis is a disorder of reality testing or a thought disorder, and it's primarily caused by underlying psychiatric illness. So patients who have schizophrenia can present with psychosis. There are also sometimes substances that can make patients or cause patients to be psychotic. And if you are concerned that someone has those, you can potentially send a toxicologic screen to think about that. Strokes and tumors are the other thing that rarely cause global cerebral dysfunction. So rarely will they make a patient globally altered. Patients who have strokes may present with weakness in a certain area of their body, but rarely does it cause overall confusion. Things that may mimic confusion, though, are if a patient is aphasic. So if a patient is unable to speak and not able to communicate with you, you can imagine that that patient may come across as confused. The same thing goes for any kind of visual field abnormality. If a patient isn't able to move their eyes a certain way or look at you, that also may mimic confusion. What are the first things that we want to do when patients present with confusion to the emergency department? The first and primary thing you want to do is you want to make sure that you check a blood sugar because hypoglycemia, a low blood sugar, is a classic thing that can cause altered mental status. We want to make sure that we think about this every single time because if we're not thinking about it, then we won't think to check it. The other thing you can do is you can administer D50. D50 is a concentrated glucose solution, and if you're not able to check a blood sugar quickly, you can go ahead and give that D50. You also want to consider giving thiamine prior to giving glucose administration. And mainly you want to do that in patients who you're concerned that they may be malnourished. So a patient who is a chronic alcoholic or a patient who doesn't have regular access to food. Because if you give glucose prior to giving thiamine, you can precipitate Wernicke's encephalopathy and cause further problems for the patient down the line. Naloxone is the other medication you want to consider giving when patients present with altered mental status. What naloxone does is it reverses opioid intoxication. So you want to think about giving this to patients in whom you're concerned that they used opioid medications, and that is what led to their altered mental status. Opioid medications can be used via injection drug use. So heroin is the classic thing that we think about, but there's also a lot of oral opioid medications that are prescribed. Oxycodone, Dilaudid are two common medications that patients may be prescribed as outpatients. So it's important that we know not to limit this just to patients who are injecting drugs. Patients who have overdosed on opioids, the classic thing that they'll present with is pinpoint pupils and or respiratory depression. So their respiratory rate will be very low, down to about 10. Now in Baltimore, where I come from and where I practice emergency medicine, opioid overdose is very common. So this is a medication that we frequently give when patients present with altered mental status. But definitely you want to think about giving this if at all you're concerned about it. It will rapidly reverse the opioid intoxication, and your patient will generally wake up pretty rapidly thereafter. The last thing that you want to think about doing is applying oxygen to your patient. So if your patient is hypoxic, you definitely want to go ahead and put them either on nasal cannula oxygen or a face mask. And if you're worried that a patient is having ventilation issues, if you're worried that their carbon dioxide level is very elevated, and that may be based on a history of obstructive lung disease, then you want to think about starting your patient on BiPAP. BiPAP stands for bi-level positive airway pressure. And what that does is it helps the patient with both oxygenation as well as ventilation, and it helps them exhale that carbon dioxide. So what is a good clinical pearl here for you to take home? It's important to remember that hypoglycemia is a common thing that people can present with, and it's rapidly reversible. Especially in your patients who are diabetic, who are on insulin, you definitely want to be thinking about low blood sugar. You always want to check a finger stick on patients who have altered mental status. I've been fooled before and thought that hypoglycemia wasn't the cause, and I've admitted someone actually to the medicine floor without checking a blood sugar. And you definitely want to make sure that you do this before you go ahead and think about other causes of altered mental status. Now, if you're unable to check a finger stick for whatever reason, your glucose monitor isn't working, you don't have a nurse available to get it for you, but you have rapid access to D50, go ahead and administer that medication. Now, if your patient doesn't have an IV, if they have very challenging IV access, again, if you don't have anyone available to get that, but you do have access to a medication called glucagon, you can go ahead and give that instead. Glucagon is a medication that's administered intramuscularly, but it can take a little bit more time to work. And you also want to think about the use of glucagon in a malnourished patient, because essentially what glucagon does is it goes and it acts on the liver, and it causes release of the glucose from the liver. So in order for glucagon to work, your patient needs to have adequate stores of glucose in their liver. Now, if a patient doesn't have adequate stores of glucose in their liver, glucagon really might not be as effective.
Okay. So, so next topic po natin guys, since tapos na po tayo sa primary assessment po. So we'll proceed na sa airway management natin. Kasi we'll be discussing po how to maintain an airway patency ba. And next, we need to know how to open an airway. Na? If ever kung ang patient pa natin is may suspected po na C-spine na mga injuries po or kung wala man. Ayan. Sige po, so we'll proceed na sa next topic po natin. So we have the airway management. Now, for the airway management, that usually begins with the airway adjuncts. Ano ba yung mga types ng airway adjuncts po natin? So we have the OPA, ayan, or the Korean ba yan? No, it's the oropharyngeal airway adjunct. Next, we have the NPA or the nasopharyngeal airway adjunct. Familiar with the BVM? Ayan guys, hindi po siya tinatawag na ambubag kasi ambubag is it's a brand name. So it should be properly addressed, known as the BVM or the bag, the valve, and then the mask. Now, just so you know lang din, as part of the updates ng COVID po, now for the COVID kasi guys, kailangan pong may filter dapat na yung mga BVMs po natin. Tapos, dapat airtight seal din po ang mga BVMs po natin. So, OPAs po or OPA are usually given if the patient is unconscious. Okay, so we have the unconscious patient po. Now, pag NPA naman guys, or the nasopharyngeal, pwedeng conscious. And so we have the conscious patient or the semi-conscious na patient po. Ulitin ko lang ha, pag OPA kasi, syempre mouth yan. So dapat hindi ma-stimulate ang tinatawag na the gag reflex na. So para hindi po ma-stimulate ang gag reflex natin, since mouth naman talaga ang natin, ang entry natin, so, make sure na unconscious si patient. Now, pag conscious naman, walang problema kasi ilong naman or semi-conscious. But take note guys, pag gagamit po tayo ng nasopharyngeal airway adjunct or NPAs, make sure na wala pong basilar skull fracture ang patient natin kasi mas lalo magkukos ng tinatawag na complication. Okay? Next, we have here the BVM or the bag, the valve, and then the mask. Using the easy clamp technique. Dapat may E, may letter C, clamp technique. Mamaya, I'll show you a video regarding the easy clamp technique. Okay? So, OPA, NPAs, and BVM. These are the airway adjunct. Now, kanina ba tayo gumagamit ng lubricant dito? Malamang si NPA, ginagamitan po yan ng lubricant. It should be a water-based lubricant by the name of what? The KY jelly po. Ayan, so we have the OPAs or the oropharyngeal airway adjunct. Diba? Ito yung mga J-shape po natin. Paano ba mag-measure? Ayan. Ayan, sir, from the corners of the mouth, towards, the tragus, of the ear. Diba, corners ng mouth mo towards the tragus, of the ear. Dapat hindi siya, na too, let's say, too small, na, or too, lengthy din, diba? Kasi pag too small yan, it will, push, the tongue further backwards. Ayan, pag masyadong, ayan, for a while ha, ayan, ito, problems natin. Pag masyadong short siya, ipupush niya mismo yung tongue mo. So mismo si tongue mo tuloy ang magkukos ng obstruction. If that's too long naman, siya mismo magkukos ng obstruction. Ito kasi ipupush niya si tongue. So na-occlude, di ba? So make sure na properly dapat na measured po Kasi para ma-avoid ang too short and then the too long din. Don't worry, I can share you my slides din. Na? So we have the OPAS. Ayan, properly, what? Na-check dapat. Paano ba mag-insert? Guys, disregard mo muna itong mga letters na nakalagay kasi parang ewan ko kung paano nasama dyan. So, pwedeng ganito. Ayan, pwedeng ganyan pagpasok. Tapos, i-rotate lang po natin. 180 degrees. Ayan, or pwedeng, mas mabilis to. Ayan, nasa side ka na para isang, rotate lang. Na 90 degrees lang, okay na, pasok na. Ito kasi kanina, ayan, 180 degrees pa yan. I-rotate mo pa. Pero ito, half na lang. So, we have here the 90 degrees na lang po. Diretso na siya. Pasok. So, anong itsura? Ayan, dapat ganyan ang itsura, guys. Okay? Tapos, pwede tayong mag-suction. So, basically, to maintain an airway patency, ayan, para pwede mo ding ma-suction si patient. So, therefore, you need to have the OPAS or the oropharyngeal airway adjunct. Ayan. Next, we have the NPAs. NPAs. Or the nasopharyngeal airway adjunct. So, ganito ang itsura. Papasok sa ilong. Ayan ni patient po. Di ba papasok? So that is to maintain nag-patent airway po. Now, paano ba mag-insert, paano ba mag-check, guys? This should be from the nostril, guys. Ayan, towards the tragus of the ear na naman. Okay? So we have from from the nares ayan, towards the tragus of the ear. Yung kanina naman, from the corners of the mouth towards the angle of the jaw. Ayan, ito tragus, of the ear po. Okay, that's the NPA or the nasopharyngeal airway adjunct. Usually, ginagamitan po yan ng tinatawag na what? Ayan, that's the water, base, na lubricant po. Na? So, known as the KY, ayan, jelly po natin. Ayan, paano ba siya i-insert? Na dapat slowly lang, guys. Na? Dapat wala masyadong friction since well lubricated naman siya. If there will be a form of obstruction, parang nahirapan ka na mag-insert sa isang nares, try to remove it, you check for obstruction, and then you reinsert it ulit. Pero pag ayaw pa rin, on the second attempt, then, baka ang patient mo, guys, may blockage sa nasopharynx niya. So, it can be a congenital problem po. Na? Ayan, so dapat ganyan ang itsura. Di ba? Parang nakapatong lang. Pero may tubo talaga yan. And that's the NPAs po. And this is the bag mask ventilation. Now, for the bag mask ventilation, pansinin mo ang kanyang mga daliri. Na? Tignan mo, guys. This is the C. The C must be holding the what? The mask. And then the E, 1, 2, and 3. Yung 3 fingers po natin dapat nasa jaw ng patient po. Tapos ililift na yung jaw. Ang tawag, E, C-clamp technique. Ito si E. Ito si C. Kaya nga, easy clamp technique po. And that is to what? Nag-keep, ayan na let's say, the airway patent. Kasi in every bagging kasi, you need to lift, the jaw of the patient. Na? Para papasok talaga yung ventilation po natin. Yung bag, na binabag mo si patient. Okay? Ayan, so that's the BVM. Now, ito naman, guys, ganito ka, magli-lift ng tinatawag na airway if ever kung, wala namang spine, fracture ang patient, or let's say cervical spine fracture. Pero pag suspected po ang patient, ayan, with cervical spine fracture, you need to maintain the alignment. Anong tawag dyan? It's the jaw thrust na din. With, in combination sa tinatawag na, BVM po natin. So, ginothrust ni si patient. Ito kasi, it's the head tilt chin lift na the usual pag walang C-spine injury. Pag may C-spine injury na po, ang tawag natin, it's the jaw thrust maneuver. Now, for the for the advanced airway naman, guys, syempre, ito na yung mga tinatawag natin na what? Intubation, na yung mga supraglottic airways po natin, ay yung mga combi tubes natin, na I'm sure you're familiar with this one. Na the combi tubes na usually ginagamit natin yan na after pneumonectomy, di ba? Kung gusto mo yung isang lung, lang ang magpa-function, yung isa hindi, then you need to have the combi tube. Ayan. Usually, for blind shooting, we have the LMAs. Ayan, ito, mga LMAs po natin, mga laryngeal mask airway. When we say LMAs, guys, syempre ginagamit natin yan for blind shooting. And usually used by anesthesiologists pag may mga difficult intubations. Now, pag anesthesiologist kasi mahirap, madalang lang po na nahihirapan sa intubation. Kasi ang pinakamagaling talaga mag-intubate, guys, mga anesthesiologists. Na, ayan. But, okay, sa OR case kasi, let's say, mabilisan talaga, kasi may mga difficulties po, then LNAs ang ginagamit nila. Na, those are what we call as the laryngeal, okay, the mass, okay, airway for LNAs. Ang mahal nito, siguro nasa mga 15,000 na to 16,000. Yeah. Tapos, this should be disposable. Pero ano ginagamit ng mga guys, ng mga government hospitals, nire-reuse nila. So instead of saying disposable, it's reusable. Na? So, yeah, yung iba nga, in-autoclave, yung mga ganun. Na? Ayan, so we have the LMAs, na diretso lang, kung ano yung tsura niya, papasok lang din. I hope maka-attend po tayo sa training, tapos you need to inflate that one, na ganun lang din. Ayan, so we have the tracheal intubation. Now, for the tracheal intubation naman, guys, this is really important kasi pag paramedic ka, you are really allowed to intubate. Pero pag hindi po paramedic, you are not allowed to intubate. But for the 911 sa Davao, this year, mag-intubate na sila kasi paramedic level na po sila. Na? Even ng mga non-medical na nasa 911, basta naka-attend lang ng paramedic na training, they can intubate. So, di ba? Amazing. Now, guys, usually kasi ang mga endotrach, natin, yung mga laryngoscope, it should be where? Left or right? Nasaan kaya? Left or right ng kamay ng doktor? Left or right? Ideally, it should always be at the left hand of the doctor. It should be at the what? At the non-dominant side dapat. Kasi ang tube po natin, endotracheal tube, should be at the dominant. It should be at the right hand of the doctor. So dapat ganito ang itsura. Tapos naka-C-shape yung tube po natin or the endotracheal tube. Right? Ayan, we usually intubate a patient pag less than, ilan nga yun? Pag less than 8 po, ang kanyang GCS. Or basically, pag ang kanyang O2 sat, guys, na less than 84%, intubatable na pang patient natin. So we have the tongue blades natin. Pag straight yan, guys, letter L, ulitin ko lang. Pag letter L, syempre straight one. So anong tawag natin? Miller. Ayan, Miller po ang tawag natin doon. Pero pag letter C naman po, ayan, it's what we call as the Macintosh. Ulitin ko lang. Pag straight one, similar. Tapos pag letter C, si Macintosh. Ano kaya ang pinaka-common na ginagamit? It's the what? It's the Macintosh. Ayan, no? By anatomical position kasi. Di ba? Pag ganun yung, may tsura ng tinatawag na anatomy natin, yan, para makapasok talaga yung tinatawag na laryngoscope, then it should be a C-shaped one. Okay? So that's the Macintosh. So you need to check pa rin the completeness of the supplies, lalo na pag walang battery po ang tinatawag na laryngoscope po natin. For sure, itatapon yan ng doktor sa'yo. So ideally, based on ethics po, it should be 3 plus 1. 3 attempts plus 1 last attempt. Pero pag failed na po ang tinatawag na intubation, and that will be another management. Later I will be showing you na ano ba yung mga alternatives, guys. Familiar with the cricothyroidotomy? Ayan, kasi meron po tayong updates, guys, based on the PAN, and American Hospitalization po, na society together with the World Health Organization. Ayan, so once again, saan nga yung Miller dito? Left or right? Left or right? Nasaan si Miller? Pag Miller po, the straight one, that's the Miller. Sino nga to? Si Macintosh. Na? Ayan, so that follows the shape. Ano pinaka-common? It should be the Macintosh po. Ayan, so this is the tracheal intubation. This is the EP tube. Ayan. Sige nga, let's discuss ano ba yung mga niya? Ano ba yung mga parts? So we have the chest test tube, the tube connector. This is what we call the connector po. I-attach kasi natin yan sa neck vent eh. Ayan, we have the pilot, balloon or the balloon tip catheter. And this is the pilot tubing. Di ba, air dapat? 10 ml of air or the 10 cc dapat of air. Ayan, to secure. And this is the balloon tip, catheter po. And then, we have itong opening, guys, ang tawag dyan, it's the Murphy eye. Ayan, the Murphy, eye po. Ayan, so we have the syringe, dapat naka-attach na yung syringe natin, para ma-ready po. Pag na-insert mo na, automatic, you push, the 10 ml of air. Okay? Ayan. So, the usual problems kasi sa intubation is the timing. Di ba? And then the skills also, yun yung pinaka-issue. Kasi pag hindi po marunong mag-intubate, guys, there's something wrong. It can be sa positioning ba? Kasi we usually intubate a patient, dapat po naka-sniffing position ang patient natin para may direct visualization din po. Okay? Ayan. So, we have the preparation of the equipment. So, we have the laryngoscope. You check the batteries. You check the light bulb. Kasi sometimes it will become busted. So pag sinabi po natin busted, na malamang hindi na siya iilaw din. Next, we have the tongue blades. No? For Macintosh, it should be a what? The curved one. Pag straight naman, it should be the Miller. For the tube sizes po, for the adult patient, usually 8 to 9 millimeter. Guys, this is US base. Na? US yan. Ayan, mga Amerikano. 8 millimeter to 9 millimeter. Okay, tube. Pero pag Pinoy kasi, usually 7 to 8 millimeter yan. Na pag adult male. Pag adult female, US, 7 millimeter to 8 millimeter. Pero pag Pinoy naman po, usually 6 to 7. Pero pag buntis, dapat 7.5. Okay? Ayan. Next, we have the endotracheal tube cuff. Dapat ma-check mo din yung pressure. Dapat 23 to 25 millimeter mercury to prevent tracheal necrosis. Ayan, so advantages ng tracheal intubation po natin, it maintains, the airway patency, di ba? For suctioning ng mga airway secretion, ano pa? Ayan, giving off high concentration of oxygen, plus the route of what? Administration of certain drugs. Ano nga yung mga example ng mga drugs po na pwedeng ibigay via the endotracheal tube? Ayan, familiar with the NAEL? And may technique tayo dyan eh. So we have the Narcan, naloxone, ano pa, amiodarone, ano pa, epinephrine, and then we have the lidocaine. Usually, ginagamit po natin yan on the emergency setting po because these are the emergency drugs na very common. So, pag binigay mo, via IV line, pwede rin ibigay via what we call as the endotracheal tube. So, we have, ulitin ko lang, Narcan, naloxone, letter N, letter A for amiodarone, letter E for epinephrine, and letter L for, the lidocaine. And then always, guys, always protect airway from what? Na aspiration. Ayan, are you familiar with aspiration pneumonia? When I attended this seminar sa UST, guys, ang sabi doon, pag ang patient nagkaroon ng aspiration pneumonia, 75% mamamatay si patient. Only 25% pwedeng mabuhay ang patient. So we need to be very careful, in dealing with what? The aspiration pneumonia, in which it's really common to pediatric and even to the elderly patients, guys. And that's the aspiration pneumonia. Okay? Ayan, questions? Ayan, so what are the complications ba? Number one, na very common guys, ang trauma. Ayan na naman yung word na trauma. Ayan, ni-revive mo ang patient, nag-cause ka nga ng trauma. Yes, no? Ayan, just by giving the benefit of the doubt din, kasi mas maganda din at least na nabigay mo talaga ang supplemental oxygen na needed by your patient. Sige lang, trauma will always be there, nasa lips, sa teeth. But as much as possible, if you want to avoid that, then much better. Next, for the bronchial intubation po. Ang bronchial intubation kasi, malalaman mo yan, upon doing the 4-point auscultation, the 5-point, kasi may tinatawag tayong 5-point, auscul, ayantation. Anong nangyayari sa 5-point? Ayan, ganito ang 5-point, epigastric area, 2, 3, 4, 5. Na ito yung chest ni patient, lungs ni patient, tapos may epigastric area. Paano ba mag 5-point auscultation? Ilagay mo daw dito ang tinatawag na stethoscope. Ayan, yung circle ha. Ayan, no gurgling. So meaning, walang epigastric. Intubation. Kasi pag may gurgling sa epigastric area, mali na po ang na automatic na intubation natin. Hindi na siya endotracheal. No, but gastric intubation na yon. Ayan, delikado po for na aspiration. Na? Ayan, so no gurgling. Next, good air entry. Next, good air entry. Next, good air entry. Next, good air entry. So the patient was successfully intubated with equal and bilateral air entry at the level of 23, 24, 25 cms. Guys, ano ba ang mga problems natin? Ganito nag-insert na tinatawag na endotracheal tube ang doktor. Pag-check mo sa epigastric area, yan, pag-check mo ha, yan, ganito ang result. Check. Grrr. Doc, there's gurgling. So, ang tawag doon gastric intubation. You need to extubate dapat. Or mismo si doktor ang mag-extubate. Ang importante, narinig ng doktor, Doc, there's gurgling. So, maling-mali na ang intubation niya. Kasi dapat, di ba, sa trachea dapat na hindi po sa gastric area. Pag gastric area, guys, NGP ang i-insert mo at hindi endotracheal tube. Or baka baliktarin mo rin. Ang NGT mo, no, either ginawa mong catheter, okay, na Foley-cath, or baka, okay, gagawin mo rin what? No? Ayan, endotracheal tube. So, maling-mali yan. What if ganito ang nangyari? Bigyan ko kayo ng situation, ha? No gurgling. Ayan, no air entry. Pak, walang air entry. Yes, may air entry po. No air entry. Yes, okay, to air entry. Diba? This is the right side, and this is the left side.
Places where you belong, but you will find that there is a purpose. It's been there within you all along.
When you're near it, you can almost hear it.
It's like a symphony. Just keep listening, and pretty soon you'll start to figure out your part. Everyone plays a piece, and there are melodies. Each one of us. Oh, it's glorious. You will know how to let it ring out as you discover who you are. Others around you start to wake up to the sounds that are in their hearts.
It's so amazing what we're all creating.
It's like a symphony. Just keep listening, and pretty soon you'll start to figure out your part. Everyone plays a piece, and there are melodies. Each one of us. Oh, it's glorious. Glorious, glorious, glorious. That you feel and don't spill. You will see. It's like a symphony. Just keep listening, and pretty soon you'll start to figure out your part. Everyone plays a piece, and there are melodies. Each one of us. Oh, it's glorious.
Hi, so good morning po. So let's check the participants po. Let's check the connection. Sir Gilbert, kamusta naman po yung connection natin dyan, sir? Pa-chat na lang po kung loud and clear naman po. Ayan, for our rapu-rapu, okay, nurses po, kamusta po?
Hi, sir. Hi, sir. Good morning.
Good morning, ma'am.
Good morning.
Kamusta? Ayan, si Ma'am Maria Yolanda Aquino. Ayan, ma'am, kamusta po yung signal natin?
Hello, sir. Okay naman po, sir.
Ayan po, good morning po, all the way from Vigan.
Good morning po. Good morning po.
Good morning, ma'am. Si Sir Mark na lang po ang wala pa ata, ma'am, no?
Sir, medyo malate si Mark.
Sige lang, walang problema.
Kahabol na lang po, sir.
Sige, it's okay. Ayan, yung PDMDH po natin, kamusta? Kamusta ang connection natin? Okay naman po ba? Ayan, si Sir. Ayan, si Sir Gilbert, hindi pa ata nagre-reply. Sir Gilbert. Ayan, pa-chat na lang po ha. So our topic for this morning will be all about the circulation, hemorrhage, and shock. And then later po guys, we will be discussing the kinematics of injury such as yung mga motor vehicle or paano ba siya nangyayari. Now we have the falls also, and then we have the mga blast din ng mga injuries. whether low energy na mga medium at saka may mga high energies po tayo. Tapos I'll be showing you videos kung paano ba mag-check ng mga DCAP Btls po natin as part of the secondary assessment. Okay? Ayan, sige po. So let's begin na po our day by simply having the discussion. So once again, good morning po sa lahat. This will be our last day for the sa trauma. Ayan, usually kasi guys, ang tinatawag namin na let's say basic trauma course kasi when we say basic po, it will be a 2-day activity. And usually kasi on the second day, ayan, it's more of return demonstration such as paano ba mag-perform ng primary, paano ba mag-perform ng secondary, assessments po natin. Pero ang gagawin po natin today, it will be purely lecture po na plus videos po. And now it's up to you kung mag-attend po kayo ng actual talaga na nonetheless po lahat na makukuha yung certificates guys ay magagamit niyo po for your DOH approval po natin. Okay? Yun naman talaga yung goal natin. Alright? Ayan. So we have the first topic known as the circulation, hemorrhage, and shock. Ayan. So we have the circulation, ayan, hemorrhage. Ayan. So we have the word hemorrhage. Ayan. And then we have the word shock. Ayan, pag sinabi natin circulation, hemorrhage, and then we have the word shock, di ba it boils down to one thing This is brought about by what? By blood loss. Guys, always remember this. If you are dealing with circulation, hemorrhage, and shock, as our topic, guys, always remember, ang pinaka-common reason talaga nito, this is brought about by what? Hypovolemic shock talaga. This is brought about by hemorrhage. Ito talaga ang pinaka-common reason kung bakit may problema tayo. And we usually assume bakit kaya nagkaroon ng shock ang patient. This is brought about by what? Na syempre, a massive blood loss. Now, when we say massive blood loss, always assume hemorrhage po. Now, pag sinabi natin circulation, guys, hemorrhage and shock, today we will be discussing the hypovolemic shock. Ayan. So aside from hypovolemic shock, we have the distributive shock also. Na itong distributive shock natin, sulat natin later yan. Ayan, tapos we need to discuss the cardiogenic shock also. Ito yung mga major shocks talaga guys. Now, when we say hypovolemic shock, ayan, pa-chat na lang po kung maganda po ba yung signal natin guys para at least na mag-a-adjust po tayo. Now, when we say hypovolemic shock, is this the most common one? Yes, this is definitely the most common type of shocks po. Now, this is due to what? No, a massive, blood loss. When we say massive blood loss, this is due to what? No, what we call as the hemorrhage. Diba? Ayan. Grabe po, there is a massive loss. Ayan, the massive, loss, of RBC. Guys, always remember this, that in dealing with what? No, in dealing with, bleeding, in dealing with shock, ayan, no? Ang pinaka-importante dito is that we need to count for the RBC. Why? Diba, as we all know kasi, sa RBC po, meron tayong what? Hemoglobin doon. Tapos, pag may hemoglobin ka, that's the what? May auto-carrying kasi na part ng blood. So, meaning maganda ang perfusion, papunta sa brain mo and other systems po. Pero if you are suffering from what? May massive blood loss, then expect guys na yung perfusion papunta sa puso mo, or perfusion papunta sa brain mo din, is what? Na inefficient na po. Okay? Now, as a golden rule, always assume. Okay, always assume hemorrhage po. Now, if you're going to assume what no hemorrhage, then meaning to say ang causes talaga ng shock, it boils down to what? No, to massive bleeding po. Now, pag sinabi naman po natin hypovolemic shock guys, so we have the 4 classes po. So we have what we call as the class 1, and we have the class 2. Then I will define kung kamusta ba ang patient mo dito. Is my patient anxious ba? Ano ba ang presentation ng patient natin? We have the class 3, and then we have the class 4. Now, pag sinabi po natin class 1, of course, na mild lang yan na? Pero pag sinabi mo ng class 4, ito na yung massive talaga. Ito na yung mga nakakatakot na bleeding po. Sir, kamusta ba ang bleeding natin sa class 1? So we have the word blood loss. Ayan, per ml. Now, for class 1, guys, this is what? Na less than 750 ml na blood loss. And then, take note, na your patient here is kinda anxious. Ayan. So, si patient natin dito, guys, is, ayan, anxious po. Ayan, sir, ano ba usually ang management po natin later na yan? Next, sir, pag sinabi po natin, class, 2, Now, your class 2, guys, is definitely may blood loss siya of 750 okay, to 1,500 ml. Kamusta ang patient natin dito? The patient is mildly okay, anxious. Ayan, mildly anxious po ang patient natin. Ayan, sir, kamusta naman po ang class 3 po natin, guys? Now, for the class 3, you need to expect that there will be a blood loss of 1,500 okay, up to 2,000 okay, ml okay, ng blood loss natin. Now, kamusta ang patient mo? Now, the patient here, guys, is what? Anxious. Ayan, tapos, your patient is confused. Ayan, confused po ang patient natin pag class 3 na. And then you need to take note na pag class 4 na po, which is, okay, what? Greater than 2,000 ml okay, of blood loss, the patient basically here is what? Confused. Ayan. Confused na po ang patient natin. And the patient is basically what? Lethargic in nature. Ayan. So, here are the classifications. So, we have the class 1, class 2, class 3, and then class 4. Kung saan very, sakto pa lang ang class 1. Pero nagsistart na tinatawag na blood loss doon. Next, pag sinabi mo naman class 4, ito na yung pinaka-nakakatakot na, guys. Now, how do we manage ba? Ayan, paano nyo ba siya minamanage sa hospital po natin? Pag sinabi natin, okay, class 1, we usually give what? IVFs lamang po. Okay, intravenous fluids po natin. Ayan, pag sinabi natin class 2, guys, ayan, syempre IVFs lang din. Ayan, pero pag sinabi po natin, okay, what? No, class 3, ayan, this is a combination of IVFs, okay, plus plus blood transfusion. The same din po with your class 4. You need to manage, okay, the patient by simply having your, okay, the IVFs, okay, blood plus your blood transfusion, guys. And that's, okay, what? No, with your class 3, and then we have the class 4. All right? And so, partly, guys, tapos na po tayo sa hypovolemic shock. And next topic, okay, to discuss will be, okay, your distributive shock. Example man will be the neurogenic shock. When we say neurogenic shock, this is brought about by spinal cord injury. Okay, so we have the word distributive, and distributive shock, guys. Ayan, for the self-distributive shock, okay, the most common, okay, one, this is the neurogenic, shock po. Ayan, pag sinabi po natin neurogenic shock, syempre may mga brain injury ang patient po natin, di ba? Ayan, ano bang nangyayari dito sa distributive shock, sir? There will be a decrease. Sulat natin. Okay, there will be a decrease. Okay, systemic. Okay, vascular resistance. Ayan, vascular. Ayan, resistance po. Ayan, due to vasodilation. Ayan, due to dilation, guys. Ayan, pag sinabi po natin distributive shock, okay, example will be the neurogenic shock. Ayan, ano ba ang common cause nito? Ayan, pag sinabi po natin distributive shock, so the common cause at wala nang ibang sagot, and that's basically the spinal cord injury. Ayan, the spinal cord, ayan, injury po. Now, for the said spinal cord injury kasi it might be brought about by motor vehicular accident. Kaya you need to check, okay, for the cervical spine, the C3, 4, and 5. Diba? Ang sabi ko, to keep the diaphragm alive. Kaya nga, diba, sa DCAP Btls mo, unahin mo muna yung head ni patient. Ayan, tapos, okay, i-check mo yung face ni patient. Ayan, yung mga mata, yung ilong niya, you check for what? Na yung mga, let's say, mga bleeding ba? Tapos, ayan, down ka sa likod ng, okay, C-collar spine po ni patient or the cervical collar spine. Ayan, to check for what? Na bleeding and the deformities ba? Kasi pag may mga deformities, guys, then expect for spinal cord injury. Okay, ayan, so we have the distributive shock, which is the common cause, okay, will be the spinal cord injury. I'll be showing you a video later, okay, regarding the spinal cord injury. Now, next topic, we have the cardiogenic shock. Pag sinabi po natin cardiogenic shock, guys, what comes in your mind ba? Cardio, meaning, okay, what? No, trauma, okay, sa heart ni patient. It can be a blunt trauma. Pag sinabing blunt trauma, general, it can be brought about by motor vehicular accident. Or pwedeng, okay, what? Pwedeng penetrating. Sorry. So we have the intrinsic, okay, intrinsic causes. And then, okay, we have the, okay, extrinsic. Pag sinabi po natin intrinsic, inside. Pag sinabi natin extrinsic, guys, okay, it can be an outside, environmental factor po. Now, pag sinabi po natin intrinsic, ayan, this is brought about by, okay, a blunt, ayan, cardiac trauma. Ayan, pag may blunt cardiac trauma ang patient natin, it's a form of intrinsic, okay, cause. Or it can be a valvular, ayan, And valvular, okay, disruption po. Ayan. Pag sinabi naman po natin extrinsic, it can be brought about by accident, di ba? Ayan, so we have with the pericardial, ayan, pericardial tamponade. Ayan, pericardial tamponade po. And aside from okay, pericardial tamponade, so we have the so-called okay, tension, ayan, ayan, pneumothorax. Ano nga sabi natin, pag tension pneumothorax, pag pneumothorax lang kasi guys, it's the presence of air. Pero pag let's say may opening ka na, ayan, so nagkakaroon ng tension pneumothorax. At ngayon mga signs po natin, pag okay, absent, okay, bilateral breath sounds. Ano pa? If there will be signs of hypoxia, ayan, if there will be signs of shock, then therefore those are signs of what? Of tension pneumothorax. Ayan, so later I'll be discussing also the difference between the tension pneumothorax and a simple okay, pneumothorax po. Okay? Ayan, so aside from that, sir, we need to do what? We need to assess the patient now. Ayan, so we have the what? No, assessment po natin, especially in dealing with shocks po. Ayan, so number one, ano bang i-assess natin? You assess for, okay, sulat natin, okay, hemorrhage. Ayan, you assess for hemorrhage first. May bleeding ba ang patient natin? Kasi if ever kung may bleeding, guys, you need to control it ASAP. Control it, okay, ASAP, as soon as possible, if ever kung may hemorrhage. So you need to assess for hemorrhage. Next, we have your, okay, the level of consciousness. Ayan. Bakit kaya may, okay, bakit kaya, okay, you need to check for, okay, level of consciousness? This is due to what? No, due to, okay, decrease cerebral perfusion. Ayan, kaya di ba may mga confusion po ang patient natin, guys. Kaya you need to check for okay, level of consciousness. Now, aside from, okay, due to decrease, okay, cerebral perfusion, now you need to assess also, okay, for the skin of the patient. Now, you need to assess, okay, for the color. Okay, wag naman pong judgmental. Okay, pag maitim, okay, may shock agad. Hindi, no? Pag sobrang pale, okay, shock na agad. Ayan, kasi we need to perform kasi several assessments, hindi lamang sa color din. But if the patient is pale, okay, clammy, tapos okay, cold, clammy patient, then that can be a sign of shock. Ayan, tapos i-check mo pa ang vital signs ni patient. Tapos, ang patient's okay, pulse rate is so increased pa, then expect for heavy bleeding. Kasi guys, malalaman mo pag may massive bleeding ang patient mo, if the patient, okay, what, presents what we call as here the word tachycardia. Diba? Pag masyadong mabilis po ang pulse rate ng patient natin, and that's the immediate sign kasi, that's the first sign of bleeding. Tulad ng pag nasa hospital ka, di ba masasabi mo na, okay, this patient is having okay, heavy bleeding after OR if the patient's okay, heart rate increases. Yung BP kasi, late na kasi yan. No, RR, late na din. Pero ang, ang heart rate talaga. Kasi the body will try to compensate it. Okay? Now, aside from that, okay, we have the word moisture. Aside from moisture, we need to check for the capillary, okay, refill time. Okay? Ayan. Now, aside from the skin, guys, okay, we have the pulse rate ni patient. Ito, pinaka-the best talaga, guys, I want you to put an asterisk, okay, with the pulse rate. Ayan, kasi if ever kung pulse rate po natin biglang nag-increase, then definitely, okay, may signs of okay, heavy bleeding po, okay, si patient. Now, you check for the heart rate. What's the normal heart rate ulit? And so, most likely, it's above, okay, 100 beats per minute po, para masabi mo, okay, may may bleeding tayo. You check for the quality. And if that's rapid and bounding, then definitely may signs of bleeding. Pero pag masyadong mahina na po siya, then definitely baka may shock na po na sobrang okay, magkakaroon na ng failure, guys. So we have the word, okay, location then. So we have the rate, you check, okay, you check for the quality, you check for okay, the location also. Ayan, A, B, C, D, E. So we have the word RR or respiration rate, or the respiratory rate. RR, guys, is not a vital sign, but respiration, okay, is actually the vital sign. No, RR kasi is it's a measurement. Kaya others sa atin kasi sabihin natin is RRA what a vital sign? No, it's a form of measurement. But respiration is the vital sign, right? Tulad ng pag sinabi mong okay, rashes, mali po ang word na rashes, it should be rash only. Ayan, kasi sa Merriam Dictionary, guys, hindi pa po nila accept ang word na rashes. It should be rash lang. Okay? Ayan. So, yeah, be careful, okay, of using what? The mga medical terms po natin. Alright? Ayan. So, aside from your RR, ayan, ano ba i-check natin sa RR po, guys? Okay, you check for signs of hypoxia. Check for, ayan, signs, okay, of hypoxia. Aside from checking for signs of hypoxia, ayan, you check also for signs of hypercarbia. Guys, when we say hypercarbia, in excessive levels of what? No, carbon dioxide. Sorry. Next, we have the acidosis. Ayan, so ulitin ko lang. Ayan, pag RR po, you check for, okay, what? No signs of hypoxia. And you check for signs of what? Respiratory distress. You check for signs of hypercarbia. Diba? Excessive levels of CO2. Then, pag may excessive levels of CO2 ka, ayan, may retention kasi, so acidic po. So, expect na magkakaroon ka ng acidosis. Okay? Next, guys, A, B, C, D, E, and then F. All right. So, we have here the BP. Now, kamusta naman po ang BP ng patient po natin? Okay? Ayan, usually kasi, if there will be a 30%, okay, blood loss daw, this is according to study ha, if there will be a 30% blood loss, then expect na, okay, dyan pa po bababa ang BP ng patient natin. Okay? Now, the goal, always remember guys, that the goal, okay, in what? In treating, and what we call it for the shock is to replace, okay, fluids, guys, and not, okay, to what? Not to, let's say, okay, return back, na, the BP to normal. Hindi yun yung, ano natin, yung goal natin. Okay, do not focus, okay, on the BP, but you focus on the general concept, okay? So there should be a fluid replacement at huwag ipabalik, okay, okay, BP sa normal. Hindi talaga yun yung focus natin kasi hindi naman to, hindi naman to cardiac arrest eh, di ba? It's a itong organ, okay, na problem, okay? So it should be as a whole dapat, okay? Now, aside from the BP, ayan, you assess also for, okay, complicating factors na, ayan, so E, F, G. So we have really complicating factors. Ano ba yung mga factors na nagko-contribute sa shock po? So definitely, we have the age, di ba? Pag too young and too old, okay, at risk for what? Developing shock. Next, we have the medications also. Next, we have etong si pregnancy. Di ba ang pregnancy natin, guys, may mga bleeding po yan. So we have the pregnancy. And next, we have the pre-existing and condition of the patient. What if, okay, may past medical history pala ang patient natin. So, mas lalo siyang, okay, at risk to what? To develop, okay, shock po. Okay? Ayan. So, aside from that, okay, let's discuss po, okay, shocks without obvious cause. Ayan. We have the next topic known as shocks, okay, without, and shock without obvious, ayan, cause po. Meaning to say, hindi po transparent ang reason. Ano kaya ang mga nasa isip niyo? Ito daw yung mag-lead sa shock, pero hindi po obvious ang mga simptomas. Ano kaya? Anyone? Okay, anyone from the group? Ayan, very good. So, present here ang bleeding. Malamang, kasi kung may bleeding, malamang that leads to, okay, shock. Kasi we need to assume, okay? Unless proven talaga, okay, na may specific cause ang shock na to. Pero kasi guys, pag shock, no, always, okay, bear in mind na this is brought about by, okay, massive blood loss. Massive blood loss, massive blood loss. Unless proven, okay, na may specific talaga, okay, so doon na magsa-stop ang hinala mo. Ayan. There will be, okay, what? No, pag without obvious cause, it can be brought about by internal bleeding. Ayan. Baka may internal, okay, bleeding po ang patient natin. Internal bleeding sa answer. Pwedeng sa chest, or pwedeng sa abdomen po, okay, ni patient. Guys, ang massive talaga ito. Number 1, grabe. Pag meron kang, let's say, okay, motor vehicular collision, natapos na tamaan yung chest mo, then expect for a massive talaga, okay, na blood loss. Pag si chest, large volume talaga yan. Pag abdomen naman, saktong, okay, okay, blood loss lang. Pero pag tulog ang patient mo, tapos may massive, okay, pala, or let's say may bleeding palang abdomen, then expect na hindi siya makakabangon. Okay, kasi patay na po ang patient. So we have the internal bleeding. Aside from internal bleeding, guys, it can be brought about by fracture. Ayan. When we say fracture po, okay, yung mga long bones po natin. Diba? Ayan. It can be brought about by, okay, the multiple fracture. Ayan. So we have the multiple, ayan, fracture. Pag sinabi natin multiple fracture, guys, it can be fracture ng long bones po natin. Anong example ng long bones? Familiar with the femur? Ayan, it's not femur, it's femur. Okay? Ayan, aside from long bones po, we have the pelvis. Ayan, di ba pag may pelvic fracture po ang patient natin, expect for a massive. Ito talaga, massive din talaga to. Okay? And that's the pelvis. Ano na-discuss ko kanina for the massive? Si chest, massive. Okay? Ayan, ang pelvis mo, massive din po yan. Okay, so we have the fracture ng long bones mo, to be specific, the femur. And then we have the pelvis po. Usually very common yan eh. Okay, especially for the elderly patients po natin. Right? Ayan, pwedeng brought about by, ito naman, mechanisms. Another topic po will be the mechanisms of injury, or let's say, di ba, may mga penetrating trauma. Kasi pag sinabi mong mechanism of injury, and shock, ayan, i-correlate po natin yan sa penetrating at saka sa blunt trauma. Na kaya nga may mechanism of injury tayo. Kasi two types yan eh. Mechanism of injury, guys, pwedeng penetrating, smaller area, smaller part. Pag blunt naman, as in like general, na yung body mo, ay nasagasaan ka, may impact, whole body mo, ang tawag doon blunt trauma. Pero pag sinaksak ka, it's a penetrating trauma. Okay? Now, mechanism of injury, and shock po, ayan, let's discuss, the penetrating. Guys, for the penetrating naman kasi, di ba may transverse tayo dito, or traverse rather, not traverse. Pag sinabing penetrating natin, this includes a smaller area po, which traverses, it travels rather, or the traverses, it traverses po. Now, ano ba ang nangyayari pag may penetrating trauma? Simply guys, may object tayo dito. Yung object na yan, nag-traverse daw. Okay? So, the object traverses to where? Pwedeng sa chest mo, pwedeng sa abdomen, pwedeng sa extremities po natin. So, we have the extremities po. Ayan. Ano ba ang nangyayari, sir? If that object traverses sa chest mo, sa abdomen mo, at saka sa extremities mo, then it injures. Ayan, anong mangyayari, sir? It injures, what? Organs. Aside sa organs, it injures, tissues din, di ba? It, what? It injures, what? Na blood vessels din po. So, ulitin ko lang. Pag sinabi natin penetrating, guys, on a smaller area, an object traverses po. Where? Pwedeng sa chest mo, pwedeng sa abdomen mo, at saka pwedeng sa extremities po natin. So, once again, guys, pag may online po tayo, make sure na may coffee tayo, right? May mga kakainin po tayo, na? At kung wala naman, edi yung katabi na lang po ang kakainin. Right? Ayan, so we have here the blunt trauma. Ayan. Pag sinabi natin blunt trauma, it's less, visible. Ayan, kasi wala tayong opening pag blunt trauma po. Ayan. If that's less visible, there will be forces. Ayan. Present po ang tinatawag na forces, applied, to trunk, and extremities po. So if there will be forces, applied, to trunk and extremities, guys, then ang tawag doon, blunt, trauma po. Okay? So, ulitin ko lang, ang na-discuss pa po natin, guys, na ay examples po ng, let's say, shock and without obvious cause. Shock, with mechanism, of, injury po. And so, meaning it can be brought about by penetrating, it can be brought about by the what? Na the blunt trauma. Alright? Ayan. Next topic, guys. Pa-chat na lang po. If, may kailangan bang balikan or nawala po ba? Ayan. Kung kailangan balikan, baka iba na yon. Okay? Ayan. Wag nang balikan kung hindi pala talaga siya para sa'yo. Alright? Ayan. Sige pa. So, we have the injuries. Ayan. Injuries. Commonly, associated. So that natin, injuries commonly associated with hemorrhagic shock. So the focus now will be what we call as the hemorrhagic shock. Ano daw yung mga injuries that leads to hemorrhagic shock? Simply, guys, expect for a massive blood loss here. Ano kayang mga sakit na yon? So number one, injuries that commonly associated with hemorrhagic shock. Okay, number one, we have the so-called traumatic aortic rupture. When we say traumatic, aortic, sulat natin, traumatic, aortic, rupture po. When we say traumatic aortic rupture, there is actually the rupture of the aorta, na? And basically, may tearing pong nangyayari dito. Ayan. So kung may tearing po, malamang kailangan ng surgery na tinatawag na intrathoracic surgery. Because guys, pag ikaw ay may traumatic aortic rupture, it can cause yung lahat ng mga dugo from that rupture guys, papasok po yan sa pleural cavity po natin. So papangit po ang tinatawag na intrathoracic pressure kasi mas lalo mag-i-increase. So hindi na magpapump ang heart mo. Okay? Ayan. Alam niyo ba guys, with traumatic aortic rupture po, there's the tearing of the aorta, di ba, sa heart po natin. Ayan, so expect po a 50% deaths. And there will be 50% deaths within hours po. Ayan, within hours lang of not of no treatment rather. So that natin of no treatment. Kaya nakakatakot to eh. Traumatic aortic rupture is the rupture of the aorta. Pag nasa States ka, it's aorta. And so we have the traumatic aortic rupture. Ayan. So aside from that, we have the word hemothorax. So that natin. When we say hemothorax, what comes in your mind ba? Anyone? There is actually a bleeding. Present po ang tinatawag na blood in the pleural cavity. Ayan, if there will be the presence of what we call as your blood in the pleural cavity, then usually this should be managed with the CPT or the chest tube thoracostomy. Ayan, your hemothorax guys, it can be brought about by blood trauma or it can be brought about by the pene and the penetrating trauma. Ayan. So we are done with the traumatic aortic rupture. We are done with the hemothorax. Ayan, next topic will be the abdominal, organ, injury po, or the AOI. Abdominal, organ, injury. When we say abdominal organ injury, syempre may mga hollow organs tayo, no? May mga solid organs din po tayo. Ayan, this is brought about by pwedeng blunt trauma, pwedeng penetrating, and trauma. So I hope na clear na po pag sinabi mong blunt, hindi siya obvious. Pag sinabi mong penetrating guys, syempre may penetration, may skin damage talaga, may opening, may tearing. Pag pag blunt kasi it's more of impact, di ba? Pero parehas po silang delikado. Now, when we say abdominal organ, injury po, there's an injury sa sa anong mga parts guys. So there will be injuries on the solid organs. Aside from the solid organs, there will be injuries guys sa what we call as the hollow organs po natin. Example ng solid organs. Anyone? Anyone who can give examples po regarding solid organs? So, number one, we have the liver. Ano pa? The spleen. Diba? Ano pa? The kidney po. So, kidneys po natin. Ano pa? Pancreas po natin. Now, sige nga, come to think of this. If ever, kung may injury po sa liver, sa spleen, sa kidney, sa pancreas, ano kaya ang mga may kita natin sa mga laboratory results? Actually, guys, there will be the presence of what we call as the enzyme. Ano pa? The bile. Ano pa? The urine. In the abdomen. Ay, okay. Kaya pala, sir, may presence of bile, may presence of tinatawag na mga enzyme ng mga urine. Di ba dapat lalabas lang siya sa mga urethra mo, di ba? Sa reproductive system mo, sa urinary tract, di ba? Pero bakit nasa abdomen po ang tinatawag na urine? So something is wrong, di ba? May impact na pong nangyayari, so damage na, right? Ang mga solid organs po natin, if kumalat na ang urine sa abdomen. Next, guys, we have the hollow organs. For the hollow organs naman po, we have the small, and large, bowels po natin. When we say small and large bowels, I am referring to the intestines. Right? Ayan. So how will I know ba na may damage po tayo sa tinatawag na hollow organs? Guys, you need to expect na and suspect din, especially if there will be a leakage. Ayan, leakage of contents. Mga GI contents po natin nag-leak, guys, na and sa the whole of the abdomen of the patient. Diba dapat nasa intestine lang siya, pero bakit nag-leak? Na bakit may kumalat na tae, di ba? Bakit may kumalat na mga foods po, na? So, that leakage of contents, are you aware na it causes what? It causes peritonitis. Ayan, so magkakaroon ng peritonitis ang patient natin. As we all know, di ba, peritonitis is actually a form of complication. Di ba, the rigid board-like abdomen po, which is actually a sign of rupture kung sa appendix, guys, or appendicitis rather, it's a form of a what? Na a complication of the peritonitis. Nag-rupture na po ang appendicitis po natin. Right? Na instead, yung mga McBurney's, okay, yung mga point na mga surgery po, ayan, di ba? Magiging what? Na XLAP na po, exploratory laparotomy na. Kasi kumalat na po ang tinatawag na infection po natin. Okay? Ayan, so we have the abdominal, okay, organ, okay, injury. Now, next topic po, aside from, okay, ayan, yung mga abdominal organ injury po natin. Ayan, let's move further. Ayan, sa pinaka-common na, okay, what? Na bleeding din, na nagkukos. So we have or let's say injury, and that's the word. Fractures. Ayan. When we say fractures, sige nga, everybody say fracture. Very good. Kahit hindi ko kayo naririnig, and just participate lang din. Na, ayan. Pag sinabi po natin fractures po, this can be, okay, brought about by a major fracture ba? Or it can be brought about by a multiple, okay, fracture po natin. Na, in which, guys, okay, they can cause a significant, okay, blood loss. Ayan. Pag may significant blood loss, okay, then, okay, you need to what? Na you need to be reminded na, okay, so medyo toxic nga ito, okay, na patient. Ayan. Sir, pag sinabi po natin fractures, okay, where? Saan ba ang pinaka-common na mga fractures po? Number one, we have the femur. Your femur, guys, is actually a long bone. And next, we have okay, the pelvis. Ayan. So we have the femur and then we have the pelvis. Kaya, di ba, sa DCAT Btls mo pa lang, and sa pag-check mo pa lang, sa general impression mo pa lang, makikita mo na yan eh, okay? Na, ayan, pag DCAP Btls, okay. So para may mga deformity tayo. No? There is pain also, di ba? And there will be a loss of function din. So malamang, okay, there will be fracture. Di ba yung mga piece natin, no? Yung mga pallor, loss of function, di ba? Ayan, so we have okay, kaya nga, pag may fracture, okay, ang patient, guys, the golden rule is never underestimate. Ayan, never, okay, estimate, okay, the patient, okay, who suffers from, okay, fracture po, na, ayan, ano mga example ng mga fractures po natin? Ano yung equivalent, okay, nila sa tinatawag na blood loss? Sige nga, I'll be discussing, okay, what, na yung mga fractures po. When we say fractures, let's say na-fracture ang tinatawag na, ayan, single rib mo na, ayan, single rib. Pag ang single rib, guys, okay, na-fracture po yan, ilang kayang ml ang nawawala sa'yo? Next, we have the radius and ulna. Ayan. Next, we have the humerus. Ayan. So we have the word humerus. Next, we have the tibia. Next to tibia, okay, si fibula. Diba si tibia, taba, fibula, payat. Na? Ayan. Next, we have the femur, which is a long bone. Next, we have the word pelvis. Ayan. Let's try. Now, this is based on, okay, the ano pa, Wikipedia. This is based on, okay, the paramedic score, let's say for the EMT. Ayan. If ever, guys, kung may single rib ka at na fracture, that's equivalent to 125 ml. Ayan, loss of blood. So, these are the loss, okay, of, okay, blood po. Pag single rib, 125 ml. Ayan. Pag sinabi mo namang radius and ulna, it's 250 to 500 ml. Okay, loss of blood. Pag humerus naman po, medyo pataas na po tayo. So there will be signs of what? No, shock here. Na? Kasi di ba pag 500 and above, okay, malamang, di ba? Tulad ng sa NSD or NSVD natin, di ba pag pregnant mother, okay, a 500 ml na loss po, guys, and is already a form of hemorrhage na po. Heavy bleeding na yan. Ayan, so we have the tibia and fibula, which is 500, okay, to 1,000, okay, ml. Pag femur naman po, okay, 1,000, okay, to 2,000, okay, ml. Pero pag sinabi mong pelvis, guys, okay, this is massive, na? So greater than 2,000 ml. Alright? Ayan, so ito lang. Ayan, I want you to focus on the word, okay, rib fracture din. Note lang ha, note lang tayo. Alam niyo ba guys, okay, na ang tinatawag na okay, rib fracture, ayan, this is the most common cause of thoracic okay, injury. Most, ayan, common, ayan, cause okay, of thoracic. Ayan, sulat natin, thoracic, ayan, injury. At pag sinabi mong rib fracture po, usually okay, on ribs, okay, 4 to 8. Ayan, ribs, ayan, 4 to 8 po. Usually dito eh. It can be brought about by impact, na? So tinatawag na okay, motor vehicular collision. Ayan, so once again, okay, ribs 4 to 8, very common okay, for the said rib fracture. And okay, this is the most okay, common cause okay, of what? Of thoracic okay, injury. Now, next topic guys, kasi tapos na tayo sa mga injuries eh, di ba? Ayan, commonly associated okay, with okay, hemorrhagic shock. Now, ang next topic ko, okay, will be, okay, injuries po. Sulat natin. Injuries, okay, commonly, ayan, sulat natin. Injuries commonly associated. Commonly, okay, ayan, shaded, ayan, with distributive shock. Ito naman, guys, pag sinabi natin distributive shock, malamang, okay, neurogenic shock. Diba? Brought about by spinal cord, okay, injury. So, ayan, we have the first topic known as the neurogenic shock. Ayan, pag sinabi po natin okay, neurogenic shock, okay, this is brought about by secondary, ayan, to spinal cord, okay, injury. Now, usually guys, pag ito ay may neurogenic shock, okay, secondary to okay, SCI or spinal cord injury, ayan, cervical, okay, spine down to T6. This is the cervical spine down to T6, okay, or thoracic 6 pa. Okay? Ayan. So, there will be a what? Ano ba nakikita natin dito? Expect for a loss, okay, of sympathetic. Ayan, ayan, thetic, okay, system, okay, vascular tone. System, and vascular, ayan, tone. If there will be a loss of sympathetic, okay, vascular tone, then expect for what? No? May mga nangyayaring vasodilation. And aside from okay, vasodilation, guys, what happens? Babagal po ang tinatawag na heart rate and bababa din po ang tinatawag na cardiac output ni patient. Okay? And then, ano nakikita natin, guys, pag neurogenic shock, usually ang skin ni patient, ito will be warm and dry. So pag may baba na tinatawag na heart rate, tapos warm and dry na po ang tinatawag na skin ng patient natin, then those are okay, what? Now, those are signs of what? Shock. Now, aside from okay, injuries, guys, commonly associated with distributive shock, let's discuss okay, injuries commonly associated with cardiogenic shock as for what? Na next topic po. So we have the okay, injuries commonly ayan, associated, ayan, commonly associated with cardiogenic shock. Pag ikaw ba'y broken-hearted, magkakaroon ka ba ng cardiogenic shock? Hindi naman po. Pero alam niyo ba guys, there's a study po na pag broken-hearted ka pala, may tinatawag na broken-hearted heart attack. Na, yeah, ito yung sa sobrang emotional ka na sa sobrang, alam mo yung guys, na sobrang affected ka talaga sa breakup nyo. Na, pero ako, to be honest, na hindi masyado ako affected sa breakup namin ng jowa kong doktor. Pero yeah, it's okay lang. Kung kayo talaga. Kasi, I believe din kasi sa well, kung kayo talaga, edi kayo. Kung hindi, well, that's fine. Char, nagmamaganda. Diba? Ayan, pero sige lang, darating din po ang para sa'yo. At para sa mga din naman, sa mga in love po, dapat alagaan niyo din po na ang relasyon niyo, right? Kasi ang relasyon naman din is, masasabi ko it's limited din, pero you can enjoy, okay, as long as, 'di ba, kayo pa, and magkasama kayo na ayan, sabi nga nila, 'di ba, pag nagmahal ka, ibigay mo na lahat kasi who knows what might happen tomorrow, 'di ba? Pwedeng pagkagising mo or pagkagising niya, hindi mo na siya mahal or hindi ka niya na mahal, 'di ba? Ayan, sige po. So anyway, so we have the injuries. Ayan, ako na po si Dr. Love ngayon. Ayan, commonly associated with the cardiogenic shock. Pero minsan guys, maganda din pag pag alam mo pag broken hearted ka kasi ma-realize mo yung yung sense mo na okay, yung sense of yung sa self mo din na yung worth ng self mo, 'di ba na mas mahalaga pala ang ang self-love din. Hindi puro yung mga love from other other na mga let's say for your part. Pero for me, yung love ng family talaga ang pinaka-the best. Kasi di siya namimili eh. Di ba? Regardless sa face mo ba, mga ganun po. Sa body mo ba, syempre family mo. Okay? So, sa may mga complete na family pa po dyan, you cherish po. Na, ayan, kasi ako dati, I don't, di ba, yung sa family mo daw, na don't kiss them, you kiss them kasi ayan, 'di ba? Kasi minsan lang daw ang buhay. Hindi masyado ako naniniwala that time until na dumating na sa point na nawala na yung father ko. Okay? Ayan. So we have the injuries commonly associated with the cardiogenic shock. Now, example. So we have the tension pneumothorax. Ayan, may tension. Okay, pneumothorax po tayo. Next to tension pneumothorax, guys, we have the simple. Ayan, Ayan, simple pneumothorax. Let's try to differentiate. Ano bang nangyayari? Pag ikaw ay may tension pneumothorax, so you need to expect na it can be brought about by a blunt trauma or it can be a penetrating. Ayan, blunt or penetrating trauma. Next, expect for a negative bilateral breath sounds. Ayan, negative bilateral breath. Ayan, sounds po. Ayan. Aside from the blunt or penetrating trauma, negative bilateral breath sounds, there will be a marked, a ventilatory distress. A marked ventilatory, distress po. So may respite distress ang patient natin. It's very obvious. Next, there will be a dynamic, compromise or hemodynamically, compromise po ang patient natin, guys. So again, pag sinabing tension pneumothorax, it can be brought about by penetrating, it can be brought about by blunt trauma. Ayan, ang pinaka-the best talaga is to auscultate for the breath sounds kasi pag absent po yan, then boom, it's your tension pneumothorax. There will be a marked, ventilation or ventilatory distress. Ayan, and the patient is hemodynamically, unstable po. So may compromise pa ang patient natin. So aside from the tension pneumothorax, so we have the simple pneumothorax. Expect for blunt or penetrating trauma din po dito. Pero ang breath sounds niya, it can be decreased lang or diminished breath sounds or absent po ang breath sounds ni patient. Hindi naman po talaga totally wala na it might be decrease lang. Pero pag wala na talaga, walang breath sounds, then expect for tension pneumothorax. Pero pag diminish lang, nahina lang, or decrease lang, then expect for a simple pneumothorax. There will be a mild to severe, respite distress po. And then lastly, guys, there will be no, dynamic compromise po. So absent po, guys, na ang tinatawag na hemodynamically compromised. So hindi mo siya mahahanapan ng may yung mga other complications po or hemodynamically unstable ang patient, hindi mo siya makikita. Kasi ang hemodynamically unstable patient is usually limited to tension pneumothorax but not for simple pneumothorax. Are you still with me pa? Ayan, sige po. So, let's move further. Another, yung mga injuries po, na nag-cause, na tinatawag na cardiogenic shock. Are you familiar with the pericardial tamponade? Cardial, tamponade. When we say pericardial, tamponade, guys, this is more of, a penetrating Ayan, it's more of a penetrating, okay, na mechanism of injury. If that's more of a penetrating mechanism, okay, what, na of injury, guys, as for the most common one, then expect for a presence of blood. Saan? Ayan, word na peri, so pericardial sac. There will be a blood in the pericardial, okay, sac po. If there will be a what, na a blood in the pericardial sac, then what happens now? It decreases, okay, what, na the, rather, it compresses, guys. So, it compresses. Ayan, if that compresses, okay, the heart, then what happens now? Parang simple, okay, pathophysiology lang to. It prevents, okay, adequate feeling. Ayan. It prevents, okay, the adequate, okay, feeling, okay, of the heart. Then what happens pag may, okay, ayan na, decrease po. Ayan, sa tinatawag na feeling, then expect for a decrease, okay, cardiac output. So that ko lang, guys, ha. So we have a decreased cardiac output. So once again, pag sinabi po natin pericardial tamponade, it's more of the penetrating, okay, mechanism of injury. Very common yan. Ayan, this leads to a presence of blood, okay, in the pericardial sac. Then what happens? It compresses the heart. At pag na-compress na yung heart mo, it prevents, okay, the adequate feeling. Then expect for a decreased cardiac output. Then expect for shock. Anong tawag doon? Cardiogenic shock. Ayan, next, guys, we have the blunt, okay, cardiac trauma. Next topic naman to. So we have the blunt, ayan, cardiac, okay, trauma. Ayan, or let's say injury. Pag sinabi naman po nating blunt, okay, cardiac, ayan, injury, ayan, there is actually an injury directly to the heart. There is the presence, okay, of injury, ayan, directly, okay, to the heart of the said patient. Di ba? Ayan. If there will be a blunt trauma daw, or let's say an injury, okay, directly to the heart, okay, muscle, ayan, lagyan mo ng muscle, heart, okay, muscle po natin, it causes what? Ano bang nangyayari? Na pag may tinatawag na blunt cardiac, okay, what? Na injury po tayo, expect for irregularities. Ayan, irregularities na tinatawag na, okay, rhythms po natin. If there will be, okay, what? Irregularities sa rhythms po natin, then expect for what? Dysrhythmia. Ayan. Bagka, okay, nagkaroon ng dysrhythmia ang patient po natin. Aside from, okay, dysrhythmia, ayan, irregularities po, there will be a right atrial, ayan, or, okay, right, ayan, ventricular rupture. Ventricular, ayan, rupture po. So aside from irregularities, aside from right atrial, okay, right ventricular, okay, rupture, guys, expect, okay, for valve, okay, rupture, valvular, okay, rupture po. And aside, okay, from the valvular rupture, then expect for a sudden death of the patient. Ayan, expect for, okay, the sudden death of your patient, guys. Ayan, so, kinda, okay, near na po tayo, okay, matatapos kasi I'm about to discuss, okay, the management, okay, of shock. Anyways, recorded naman po lahat. So, sa mga may problems po sa internet connection, you can actually ask na for, okay, the copy of the said recorded, okay, what, na discussion, guys. Now, since tapos na tayo sa mga injury na common associated with, okay, ganito, ayan, so let's discuss, okay, the management of shock. Ayan, management, ayan, of shock na po. Now, how do we manage ba? When we say management, okay, of shock, ano ba, okay, naiisip nyo? Of course, vital signs, tama? Ano pa? Okay, of course, fluids po. No? Ano pa? Ayan, the direct, okay, pressure po, okay, para ma-stop ang bleeding, di ba? The usual management. Ano pa? The continuous monitoring of your patient, okay, as a form of what? No? Magandang mga management po natin. Guys, in the management of shock, do not forget your, okay, the A, the letter V, the letter O, and then we have the letter C. Do not forget, okay, your what? No, your airway. Do not forget your, okay, the ventilation. Do not forget your oxygenation. And do not forget, okay, what? Na by simply continuously monitoring, okay, for the word, okay, and circulation. Diba? Sa airway mo, tatabang airway niya, ay shock siya eh. Ayan, ventilation, kailangan niya ba ng assistance? Let's say sa mga neck vent, mga ganon. Oxygenation, okay pa ba? Okay. Ayan, circulation, guys. Na, nag-check ba tayo? Maganda ba ang mga pulses niya? 'Di ba? Yun yung mga yun yung mga basic talaga dapat okay na malaman at saka i-manage din natin at gawin natin sa tinatawag na patient suffering from shock. Okay? Ayan, sige po. So we have your in the management of shock. Ayan, syempre kasi ang pagka-discuss ko nito is depende sa shock yun. So let's try to manage okay the hemorrhagic shock. Ayan, paano ba i-manage okay ang hemorrhagic okay shock po? Ayan, madali lang guys. Kasi 'di ba, pag hemorrhagic shock, ayan, you simply stop the cause. Ano ba ang reason ng what? Ng bleeding na to? In short, there should be a hemorrhage, okay, hemorrhage control. 'Di ba? Ayan, sir, pag sinabi po natin hemorrhagic shock, it might be okay, external factor, it might be okay, internal din na ayan, pag okay, external for extrinsic, 'di ba? Extrinsic okay, factor guys, you simply apply direct pressure lang. Ito yung management natin. Pag externally, extrinsic, direct pressure. Pwede rin po ang word na tourniquet. Guys, this is not tourniquet. It should be properly pronounced as tourniquet, not tourniquet. Binago na po yan. Dati from tourniquet, okay, ginawang tourniquet at ngayon naging tourniquet. Okay, sige nga, kayo nga. Everybody say tourniquet. Very good. Na, it's tourniquet. Okay? Ayan, so we have the immobilization. Ayan, you need to immobilize. Ayan, kasi the more, di ba, the more mong gagalawin yan, the more magbi-bleed yan kasi you're adding pressure eh. Na, you're adding trauma to it. So there should be rest. There should be immobilization. Tapos may mga hemostatic na mga okay, static, okay, agents po dapat tayo. Ayan, so we have the extrinsic. Okay, hemostatic agent, pwedeng mga yung hemostan mo, di ba, yung mga anti-bleeding po natin. Huwag kang magbigay ng ng aspirin, good luck later, di ba? Ayan, so aside from extrinsic, we have the intrinsic factor. Pag sinabing intrinsic, guys, paano ba i-manage yung mga internal bleeding? Of course, this is controlled in the OR. Controlled, okay, in the OR na po, operating room. Kasi intrinsic yan eh. Di ba? Internal yan eh. Right? Now, aside from that, okay, we have the fluid therapy. Kung alam mo, okay, na this is a hemorrhagic shock, then you need to have the fluid therapy. Guys, for the fluid therapy kasi, the goal is to maintain the BP to 80 to 90 po. This is basically the systolic BP. That's to maintain the BP. Pero pag may brain injury naman ang patient, guys, careful. Ayan, kasi you need to maintain the BP dapat to 90, to 100, systolic BP. Only po. So to maintain a BP, dapat para masabi mo, sabi nga 'di ba ng American Heart, dapat 90. Pero pag sa paramedic level naman kasi, pwedeng 80 to 90, walang problema. Ayan, pero pag si patient daw ay may brain injury, you need to maintain a BP, dapat within 90 to 100 systolic BP. Right? Ayan, now for the IV solution, guys, it should be what? No, LR, or lactated ringer solution, or the plain LR. Ayan, or plain NSS. So pwedeng plain LR or pwedeng plain NSS. Pero kasi pag trauma, guys, na-proceed with plain LR. This is the best. Ayan, kaya nga 'di ba ngayon, sa mga ER din, ayan, kung magaling po ang ER na yan, guys, na mas marami dapat plain LR. Especially sa pag-ER kasi, and lahat ng mga trauma patients po ay dinadala po sa ER. And dapat pag sa ambulance din, it's more of plain LR dapat. Na, ayan, pwede bang i-mix si plain LR, guys? With the blood transfusion. It's actually the last resort, pero pwede naman, but it's a last resort. Ang pinaka-ayaw lang naman ng blood transfusion is yung may glucose eh. Alam niyo ba kung bakit? Because it can cause hemolysis. So if that can cause hemolysis, so more of potassium po ang papasok kay patient kasi patay ang RBC mo. At kung more potassium si patient, so that leads to hyperkalemia. Kaya pala may peak T waves po tayo, so ang patient po na cardiac arrest. Okay? Kasi diba ang potassium kasi needed by our heart for contraction. Pero pag nasobrahan ka naman, good luck naman kay patient. Alright? Ayan. So aside from that, ayan, ideally po, in battling hemorrhagic shock, there should be a warmed na LR, or plain NSS. Dapat warmed, dapat. Ayan, so we have the pediatric patient. Ayan, pediatric. Ayan, pag pediatric patient naman po, it's 20 ml per kilogram. Okay? It's basically bolus. Na? Ayan, bolus. Parehas nito. It's yung IV solution mo, na 1,000 Ayan, to 2,000 ml. That's basically bolus. Pero careful ka. Before ka kasi magbo-bolus, guys, you check for crackles also. And kasi alam mo naman, di ba, ang crackles, no, are signs of a fluid-filled lung. So pag auscultate mo with your 4-point auscultation, ayan, 1, 2, and then 3, 4. And pag auscultate mo sa lungs ni patient, 1, 2, 3, 4, may mga crackles naman. Okay, crackles, okay, noted. Then that's a sign of pulmonary edema. So careful tayo sa pagbigay ng fluids. Guys, ganito. Pag may signs of pulmonary edema, then do not give fluids. Usually we give what? Yung mga epinephrine, di ba? Ayan, no? Yung mga norepi, right? Mga dopamine. Usually, ang drug of choice talaga is the dopamine eh. Ayan, tapos the rest will follow, yung epi, na, and norepinephrine. If ever talaga guys kung may, ayan, popping sound ang patient mo, kung may crackle siya, ayan, tapos you want to increase the BP, ayan, kung may crackles po, never kang magbigay ng fluids, but you need to give drugs such as the dopamine, epinephrine, norepinephrine. Pero pag si patient naman po ay mga walang signs ng crackles, then you can give fluid resuscitation, right? You give bolus. Na, ayan, sige po. Now, aside from that, nagbigay ka na ng fluids, guys. Alam niyo ba, meron tayong tinatawag na reassessment of what? Na fluid therapy na ginawa mo. Ayan, there should be a reassessment of the fluid therapy, guys. Bakit kaya kailangan may reassessment? Kasi para malaman natin kung nakontrol na ba ang bleeding at kung nakontrol ang bleeding, you need to what? Kailangan ba siya ng surgery ba? Mga ganon. So guys, in reassessing po, so we have the responses. Ano mga tawag sa responses? Number 1, we have the rapid responses. Next, we have the transient. Transient responses. And then we have the minimal, or no response. Ayan, ito yung mga responses po natin. When we say responses, guys, ayan, let's say rapid na. For the rapid reassessment response, pwedeng hemorrhage has stopped. Hemorrhage, ayan, has stopped. Ayan, may still require surgery. May still, ayan, require. Ayan, but may still require surgery po. Pag ang hemorrhage daw na stop na, ang tawag doon rapid response, but still requires surgery. Ang tawag doon, rapid, ayan, response. Next, we have pag transient naman po, there is a significant blood loss. There is a significant, ayan, blood loss. Ayan, tapos requires, urgent dapat. May urgent surgery ka. Yes, na-treat mo ang patient mo, with the use of the fluid therapy. Pero that requires, urgent surgery pa rin. Ang tawag doon, transient response. Ayan, pag sinabi mo namang minimum, or no response, guys, there is a massive, hemorrhage ongoing. Ayan. Massive, hemorrhage ongoing, and may require, immediate surgery. Ayan, so may require immediate surgery po. So ulitin ko lang. For the responses, guys, we have the rapid, the transient, then we have the minimum, or no response. Now, this is a form of reassessment kasi kung effective ba talaga ang tinatawag na fluid therapy mo. Yes, na-stop mo ang bleeding, pero kailangan niya pa rin ng surgery. It's a rapid response. Yes, there is a significant blood loss and may require urgent surgery. That's a transient response. Yes, may massive ongoing heavy bleeding si patient and that requires immediate surgery. That's a minimum, or no, response po. Nakuha? Ayan. So aside from, the management, of what we call the hemorrhagic shock, let's try to manage po distributing shock. Ano nga ang papasok sa isipan natin pag distributive shock? Neurogenic shock. Genic, shock po. Na, paano ba siya i-manage, guys? Sabi ko nga kanina, pag hindi pa talaga alam kung ano ang major cause talaga nito, you always expect na what? That this is brought about by hypovolemic shock. This is brought about by massive bleeding. Unless napatunayan nyo na may brain injury pala si patient, and then you proceed with the distributive shock. Alright? Ayan. only guys ha, pag na-rule out na talaga ang shock na to, na okay, this is not brought about by hypovolemia, but this is brought about by, okay, what na spinal cord. Okay, let's say spinal cord problem. So we have the distributive shock, guys. Ayan, so we have your, okay, the management. Paano ba i-manage ang distributive or neurogenic shock? Of course, we have the spinal, immobilization. Aside from spinal immobilization, there should be a fluid. Okay, fluid administration po. This is how you're going to what? To treat distributive shock. To be specific, the neurogenic shock. Now, sir, aside from distributive shock, let's try to treat naman po your cardiogenic shock. Paano ba mag-treat ng cardiogenic shock? Depende kasi sa, cause na to eh. Pwedeng extrinsic cause. At saka pwedeng, intrinsic cause. Intrinsic at saka extrinsic. Guys, pag extrinsic meaning external. What if, may tension pneumothorax ang patient natin? If the patient suffers from tension pneumothorax, then paano ba i-manage yan? Kahapon, naalala? At the second intercostal space, mid-clavicular line. Ano nga yun ulit? It's the needle. Decompression po. Pero pag ang patient po natin, guys, ay may pericardial tamponade, cardial, tamponade po, then expect for fluid administration as for our management. Fluid administration. Parang nawala po kanina si Ma'am Aquino, nawala ka po kanina, Ma'am. Gusto ko yung apelido ni Ma'am ang pangalan niya, Yolanda Aquino. Parang coincidence lang din. Kasi I have friends din po na biktima talaga ng Yolanda na so we have your extrinsic. So we have the intrinsic naman po. Guys, to treat your intrinsic naman po, basically you need to treat dysrhythmia. Automatic, diretso ka na sa dysrhythmia po ni patient. Okay, dysrhythmias. You treat that and then you prevent fluid overload then. You prevent fluid overload po. Now, paano ba mag-treat ng dysrhythmias, guys? Usually mga lidocaine, mga amiodarone, di ba? Yun yung mga anti-dysrhythmic drugs po natin, mga procainamide, sotalol, di ba? So we have the extrinsic and then we have the intrinsic factors po natin. Okay, paano siya i-treat? Balikan ko lang. Pag extrinsic, tension pneumothorax, needle decompression. Pag pericardial tamponade, fluid administration. Pero pag intrinsic naman, more of the heart. Kaya you need to you prevent fluid overload. Baka ito pa yung mag-cause ng the worsening of the said problem. Kaya you treat dysrhythmias para ma-improve po. Ang tinatawag na perfusion patungo sa heart ng patient po natin. Okay? This will be the last topic na po, and that's the transport consideration. Kasi right after this, we will be having the video presentation po, guys. O di ba na maximum no 25 sheets na palang nagamit natin. So we have the transport consideration. Guys, pag sinabi po natin transport consideration, there should be an early transport dapat. May early transport tayo kay patient. Diba, it can be stay and play, load and go. Ito kasi pag may mga signs of shock na, guys, you need to na there should be a no delay dapat. Early transport dapat. No delay, please. Transport the patient as soon as possible. Alright? Kasi the goal here is to minimize complication. Sir, paano ba mag-minimize ng complication? Anyone? Paano kaya mag-minimize ng complication? So we have the word assess. No? Always assess the patient. Right? And recognize. Signs of shock. Madali lang naman mag-recognize ng signs of shock Hypo, tachy, tachy. Pag sinabi mong hypo, tachy, tachy, hypotension. Diba? Hypothermia. Ano pa? Mga earliest signs. So we have the word hypotension. Ano pa? Hypothermia. Tachycardia. Ito, pinaka-common yan. And then we have the tachypnea po. right? So we have the hypotension, then we have the hypothermia. Pero pag ikaw guys, ikaw ay may neurogenic shock, early kasi will be hypertension. Kaya hindi po sa lahat ng oras guys ay hypotaki-taki except for neurogenic shock. Ulitin ko lang ha. Yes, for the hypovolemic shock, pwede po ang mnemonic na hypotaki-taki, hypotension, hypothermia, tachycardia, tachypnea. But for patients suffering from neurogenic shock, may spinal cord injury guys, expect for hypertension. No? Ayan. Pero, okay, hypothermic pa rin ang patient. So, sa BP lang sila, okay, nagbabago po. Alright? Ayan. So, aside from, okay, assessing, okay, and recognizing signs of shock as a form of minimizing, okay, complication, guys. Ayan, we have your, okay, you need to assume hemorrhagic shock always. Assume. Ayan, okay, ragic. Ayan, shock po. Kaya nga, di ba, sa mga magagaling po na nurses po, always nag-assume talaga sila na yung shock na yan is brought about by hypovolemia. So it's brought about by hypovolemic shock. Unless proven na neurogenic shock pala siya. Na? So ano bang ginagawa natin pag ina-assume natin na hypovolemic shock? Malamang may controlling of bleeding, di ba may fluid therapy po tayo. But before you start with fluid therapy, there should be a 4-point auscultation sa lungs ni patient, and that is to rule out what? The mga pleural edema. Kasi pag may pulmonary edema ang patient mo, mas lalo siyang malulunod kung bibigyan mo siya ng fluids. Kaya guys, hindi po sa lahat ng oras ay IV ang sagot. Kasi pwedeng ang IV din, ang intravenous din, ang fluids din, ang pwedeng reason kung bakit namatay ang patient. Kaya always bear in mind na you always check for crackles, di ba? Auscultate for crackles, alright? Especially sa ER po. Okay. Ayan. So aside from you assume hemorrhagic shock, guys, there should be there should be a restoration. Ayan. And maintain restoration, and maintain a good airway, a good ventilation, a good oxygenation, and a good circulation po. And then guys, always prevent always prevent hypothermia. Ayan, always prevent hypothermia. Alam niyo ba kung bakit? Because shock, guys, plus hypothermia, expect for a very bad prognosis, a very bad result. Na alam niyo ba, guys, hypothermia creates a worsening, shock. Na? So, always prevent hypothermia. So, you need to keep your patient warm. Na? Ayan, kasi shock and hypothermia, bye-bye kay patient po natin. Alright? Ayan, sige pa. So, at this point in time, I will be showing you a video, ayan, regarding, the spinal, cord na na problems po. More of videos na naman po tayo. Okay? Ayan. Saan ba yung video ko? Yeah, the thoracic, the spinal, trauma, and the traumatic brain injury. And so more of neuro tayo ngayon.
Traumatic injury to the spine, imaging can play a key role because So in this lecture, we'll be discussing spinal trauma. When a patient comes in with a traumatic injury to the spine, imaging can play a key role because it can help you exclude an abnormality that can lead to a long-term complication in the patient, such as paralysis. So when a patient comes in with a cervical spine trauma, if there's any kind of suspicion of a spinal fracture, the patient's neck should not be moved because an unstable fracture can compromise spinal cord integrity. So the first thing that's done is a trauma protocol, which involves a cross-table lateral radiograph of the neck. And this ensures that there's no fracture or subluxation of the cervical spine prior to obtaining further imaging, which may involve manipulation of the patient's neck. Common mechanisms of spine trauma include a flexion injury, an extension injury, a rotational injury, or a shearing abnormality. So these are some common spinal fractures. The most common fracture of the spine is a compression fracture. We can also have what's called a burst fracture. A burst fracture is caused by an axial loading injury in which the disc above is pushed into the vertebral body below. This can result in a comminuted fracture of the vertebral body, and it's often associated with retropulsion of bony fragments into the spinal canal, which results in an unstable fracture that can cause neurologic deficits. So this is an example of a radiograph and a CT scan that demonstrates a burst fracture. So you can see that there's a comminuted compression fracture of the vertebral body, and there's displacement of bony fragments posteriorly into the spinal canal. So if you look at the posterior vertebral line here, when you get to the level of the fracture, it's displaced posteriorly, indicating posterior retropulsion of fragments. On the CT scan, you can see that there's a fracture of the vertebral body, and the fragment is pushed posteriorly into the spinal canal. There's what's called a chance fracture, and a chance fracture is also called a seatbelt fracture, and it's usually caused by a lap belt in a motor vehicle accident. This is a type of flexion distraction injury, and you have fracture through the vertebral body, the pedicles, and the spinous process. This can actually be associated with an increased interspinous distance, and you have separation of the facet joints. So this is also a very unstable fracture, and it can be associated with neurological deficits. Often this is associated with abdominal visceral injuries as well because of the lap belt. So here we have two CT scans, sagittal images, which demonstrate a fracture through the vertebral body and the spinous process. So this is an example of a chance fracture. Often these are associated with an epidural hematoma and possibly a cord contusion as well. So Jefferson fractures are axial loading injuries. You have offset of the lateral masses of C1 with respect to the lateral margins of C2 when you do an open mouth radiograph of the cervical spine. There are also fractures of the anterior and posterior arches of the C1 ring, and this is best seen on a CT scan. Usually, these are not associated with neurological deficits. So let's take a look at this example of a Jefferson fracture. This is what's called an open mouth view, and it demonstrates lateral displacement of the lateral masses in a Jefferson fracture. So here we have lateral displacement of the two masses laterally. When you compare it with the lateral margins of the C2 vertebral body, you can see the prominence of the lateral displacement here. When you compare it with a normal film here, you can see that this is well aligned. So the lateral margins of C1 and the lateral margin of C2 is actually well aligned, while with the Jefferson fracture, it's not, and you see a step off on both sides. On a CT, you can see a fracture involving the anterior and posterior arch of C1. So here we have a fracture involving the anterior arch, and then here we have a fracture involving the posterior arch. So when you're taking a look at a CT and you see a fracture of either the anterior or posterior arch, you want to take a look for a second fracture. Because this is a ring, usually rings fracture in two different places, not just one. So if you see one, you may be missing a subtle second fracture. A hangman's fracture is actually a hyperextension compression injury. So this can occur in patients such as an unrestrained passenger who hits their forehead on a windshield in a motor vehicle accident. This is not truly associated with the judicial hanging, which actually ends up causing hyperextension, resulting in distraction of C2 and C3 and distraction of the cord. Imaging findings include a fracture of the posterior elements of C2, and the posterior aspect of C2 is actually separated from the anterior aspect of C2. So this results in anterior displacement of C2 on C3. This is actually not usually associated with neurological deficits. So this is an example of a hangman's fracture. This is a lateral cervical radiograph which demonstrates posterior displacement of the spinal laminar line. So you can see here the line drawn with a posterior displacement right here, and then again it moves anterior here. The line should actually remain symmetric all the way up and down. You also have anterior displacement of the C2 vertebral body, and you have fracture of the posterior elements of C2. So we've gone over several of the common spinal fractures that you may encounter. Again, these are very important to recognize because they may have chronic neurological deficits associated with them.
Discussion of traumatic brain injury under the section of trauma. Let's start with the clinical scenario. Take a look at this picture. The driver, a 25-year-old man, sustained a high-speed rollover motor vehicle accident who now arrives in your trauma bay is not responsive. Do you know what to do next? I'll give you a second to think about it. Remember, back to our previous initial assessment and management discussion, always begin with the ABCs. Now that you've ascertained an intact airway, a breathing patient, and a patient who has intact circulation, we move to the D of disability, where we ascertain a Glasgow-Coma scale. The Glasgow-Coma scale has 3 components. It's a global assessment of the patient's neurological status. Take a look at this table. You'll notice that there are columns for eye, verbal, and motor examinations. The coordinated effort of a patient who is able to open their eyes, speak to you, and move their extremities is one that is an oriented patient. Glasgow-Coma scales are scored from a minimum of 1 to a maximum of 6 points. We assign the best exam finding. Remember, the best exam finding. When presented on an examination of what is the GCS score, always look for the best exam finding. The eye exam is listed from 1 to 4, the verbal examination is listed from 1 to 5, and the motor exam is listed from 1 to 6. There's no precedence or importance of one exam over another, because although it appears that motor is heavily weighted. Important to remember that you just have to spend a few minutes looking at this slide and memorizing. Unfortunately, I don't have any simple ways of memorizing the GCS EVM scoring. The patient does not open his eyes, respond verbally, or move. My question to you is, what is this patient's Glasgow-Coma scale? Again, the patient doesn't open eyes, has absolutely no verbal, and is not moving at all. This is a common trick question. The minimum GCS is 3 because the lowest score is 1 on a 1 to 6 scale. So, the minimum score GCS is 3 in this completely comatose patient. And as a side note, if the patient is intubated, clearly you can't assess the verbal. But remember, the gestalt is very important. The placement of an ET tube, if that is the only limiting factor for a patient's ability to speak, we assign a T for endotracheal tube at the end of the GCS score. Let's transition to a discussion of traumatic brain injury, but first let's discuss the anatomy. On this image you see the first layer as the skull, and right underneath it is the superior sagittal sinus containing venous drainage blood. The yellow outlines suggest a subarachnoid space between 2 arachnoid and pia matters. I like to start the discussion of specific traumatic brain injuries with a discussion of subdural hematomas. Classically, subdural hematomas, or any intracranial bleeding, is associated with high impact to the skull. They are traditionally associated with tearing of bridging veins between the brain surface to the durosinus. As you can see in this image, bleeding in the subdural space results in a semilunar, or often called moon-shaped crescent hematoma. The reason is because the blood separates the arachnoid away from the dura. It is not, however, bound by the sagittal sinuses. There may or may not be medial deviation or elevation of the intracranial pressure. Remember, any space-occupying lesion in the brain may lead to elevations of intracranial pressure. We will come back to this concept. How do we manage subdurals? Based on the clinical status and the severity of the subdural, management is guided by midline shift, intracranial hypertension, clinical pictures such as a comatose or worsening GCS patient, or particularly large subdural hematomas, as defined by bleeding hematomas greater than 1 centimeter in thickness. If these findings are present, consider calling your neurosurgical colleagues for surgical decompression of the hematoma. Of course, if the patient doesn't have any of these significant findings, then our job as trauma surgeons is to prevent secondary injury. What does it mean to prevent secondary injury? With any trauma, just like when you bang your knee, some swelling is bound to happen. We want to decrease swelling and also prevent ischemia or low perfusion of your brain. Let's move on and discuss epidural hematomas. Once again, epidural hematomas are associated with high impact to the skull. Unlike subdurals, which are associated with bridging veins, the epidurals are associated with middle meningeal artery. In a clinical scenario, this often describes classic lucid interval, where the patient immediately following the trauma may actually be lucid, and after about 30 minutes to an hour has a second comatose episode. I caution viewer, though, that the classic lucid interval is much more discussed and seen in real life. And seen on this CAT scan, you notice the lenticular shape or biconvex shape, which is limited by the suture line. How do we manage an epidural hematoma? Most epidural hematomas, unlike subdural hematomas, require surgical decompression. If a clinical scenario is presented to you where a patient sustains high velocity or high impact brain trauma and they demonstrate a lucid interval, I encourage you to hold epidural hematomas high on your differential list and elicit surgical decompression. Once again, like any traumatic brain injury, we want to try to prevent secondary injury. Let's discuss skull fractures. Once again, skull fractures are associated with high impact mechanisms, such as an assault with a weapon. It's a classic scenario to have a patient undergo assault with a bat or a metal instrument, direct blow to the head. Remember that skull fractures are often associated with cervical spine injuries. This likely has to be the association due to the high impact injury. Some very important classic signs include the raccoon's eyes, which is a bruising around the eyes. Remember, raccoon eyes and battle signs are signs of a basilar skull fracture. Battle sign is bruising around the mastoid process. Just to review, raccoon's eyes is bleeding or bruising around the eyes, and battle sign is bruising of the mastoid process just behind the ear. And depending on the severity, the patient can have a CSF, cerebral spinal fluid leak. Most skull fractures are largely managed non-operatively unless a couple of caveats exist. One, significant depression of the skull. This may require elevation of the skull. And most importantly, an open skull fracture uniformly requires exploration and elevation. Earlier, I mentioned that one of the clinical signs to evaluate the patient for is intracranial pressure monitoring and to try to prevent intracranial hypertension or high ICPs. A very useful and practical equation to remember is the cerebral perfusion pressure. The cerebral perfusion pressure is the difference between the mean arterial pressure, that's the systemic circulation, minus the intracranial pressure. Again, the cerebral perfusion pressure is the difference between your MAPs and your ICPs. In severe TBI patients, where their GCS is less than 9 or considered comatose, intracranial pressure monitoring may help with diagnosis of further deterioration. Remember, comatose patients will not likely participate in your neurological examination. Patients in whom we cannot follow the examination, for example, a comatose patient or one who's on severe sedation or anesthesia, may also require intracranial monitoring.
Okay guys, so let's now have a 10-minute break muna. Ma'am Joy, magbe-break muna sila, ma'am.
Okay po,
Okay
sir.
po, sir.
Okay.
Guys,
Pwede po
i-code po
i-code po
ninyo.
ninyo. At
Dyan po
dyan
namin
po namin
mga
mga
certificate.
certificate.
By the way, naman po namin hard copy ng and
ID
to
to
LBC.
LBC.
Kailangan
Kailangan lang po na
add nyo po.
add nyo po.
Yung video discussion po yesterday, i-upload namin po yun sa website link na sinend namin po sa inyo. Pero baka po after 2 days. Kasi medyo mahaba po yun, i-edit pa, i-render pa, at i-upload pa po.
Joyce, ano po yung hinihingi mo kanina?
Alright guys, so let's continue now. Mag-i-end po yung lecture natin guys, mga before 12 o'clock. And then you will be receiving po the certificates na po based sa instruction po, okay, ni Ma'am Joy. Kaya dapat i-send nyo din yung mga address nyo din po. Kasi as Ma'am Digital Ma'am, no? Tama ba Ma'am? At saka may ano din, may print out din na certificate. Tama
Yes.
po ba Ma'am?
Yung digital muna po yung isa-send namin.
Okay, alright po.
Out po, bukas po namin ipapaship.
Ay, nice po. Ayan, sige po. So, guys, this is actually the first time na we go online, especially with the basic trauma course. And then, tapos na din po kami sa BLS and ACLS last week. So, most likely mga next week or next week, na baka may another online na naman kami na mga courses po. Right? And sige po. So, today, this will be a part ng last topic po natin. Okay, these are the kinematics of trauma. When we say kinematics of trauma, ano ba yung mga gagawin po natin in approaching aka scenario? So, pwedeng may mga motor vehicular collisions, di ba? Pwedeng may mga falls, pwedeng may mga blast trauma. So, this is okay based on the pre-hospital trauma life support or the Btls. Kasi kung mag-international ka na guys, yung inattendan ko, okay, kasi instructor din ako na ITLS, pero hindi ko na siya ginagamit kasi medyo mahirap yun kasi may mga extrication pa, kukunin mo si patient na sa let's say sa car, 'di ba? Ayan, honestly nahihirapan ako doon, no? Kasi syempre sa laki mo, 'di ba? And all. So, this will be an overview lang po na of the kinematics. So basically it involves surveying the scene, 'di ba? Whether is the scene safe ba? Ayan, ilan bang involved okay sa scene na to? Ano ba yung mga specific na management po natin? So by the way, i-share po natin tong slides na to. Kasi ang gusto ko lang makita nyo is yung mga pictures po sa penetrating, sa mga blunt trauma, na it boils down to what? Na to, syempre, safety pa rin. So the general principle po, so you need to consider the pre-event phase of the trauma incident. So we have the event phase, and then we have the post-event. So ano ba ang highlight natin sa tinatawag na pre-event phase? On the pre-event phase, guys, syempre so before the said scenario. So you need to determine the patient's age, the size, whether the patient is a morbidly obese ba, payat ba ang patient, malnourished patient ba, may mga involved ba ng mga drugs or alcohol, may mga pre-existing medical condition ba, baka ang patient mo may DM, kaya po na-trauma ang patient, or let's say kaya na-accident ang patient, kasi nagkaroon ng hypoglycemia. So, it can be brought about by medications ba, may dala ka ba medications, and the use of what? Na safety equipment po natin. Sorry, excuse me. So, we have the event phases po. So to consider, we have the direction of what na energy change. Is the scene safe pa rin ba? Ayan, yung pagpasok mo, nung pag-arrive mo sa scene na yon, is it a motor vehicular crash ba? Is it a fall ba? So ano ba yung mechanism of injury? Is it penetrating? Is it a blunt trauma? Ayan, so that focuses on the event phase. Now, so event phase, syempre nakikita po natin dito na ayan, so may mga blunt trauma ang patient natin from that blunt trauma. So ang chest ni patient guys, ayan, apektuhan po. So expect for, di ba, pag may rib damage tayo, or let's say mga rib fracture, then expect for tension pneumothorax later. Right? Some of you here, naka-witness na po. And some of you here, who knows, di ba? Baka may na-experience na din before. And I hope hindi naman siya may experience right after this. Okay? So I'm praying for everyone's safety. Always dapat yan. So we have the post-event naman guys. This is the transport na po sa tinatawag na patient natin. And the reassessment stage naman or reassessment phase naman po. Right? The more early daw ang transport, mas the more po maganda ang tinatawag na prognosis ng patient natin. It's more of the transport naman pag post-event. Kasi after the said what na pagpunta mo sa isang case, then you transport the patient now. In the Newton's first law of motion kasi, sabi dito, a body at rest will remain at rest. Pero ayan, hindi na po siya magiging at rest guys pag may mga outside force tayo such as an impact, 'di ba? Pag nasagasaan ka, or let's say pag may mga motor crashes po, vehicular crashes po, right? Ayan, so that's the law of motion. Ayan, pero kung naka-rest ka lang, tapos wala namang nangyari, let's say wala mga force, edi you will remain at rest. Ayan, we have the law of conservation of energy, guys. So sabi dito, energy can be neither created nor destroyed. It can be in the form of heat. Pwedeng sumabog, di ba? Pwedeng noise, the squeaking noise. Pwedeng vehicular deformation. Okay, as you can see on the picture, guys, may collision pong nangyayari dito. And which involves also the person. So baka may mga tissue damage po, may mga laceration. Ayan. Ayan. So we have either it can be your blunts, or the penetrating trauma. Ayan. Ano tayo, wait lang. Mag-focus muna tayo dito sa yung mga i-give emphasis ko po. On the left picture, guys. So we have it on the left and then we have it on the right side. Sa left side po, this is an example of a what? Is it a blunt trauma or is it a penetrating trauma? Anyone? If, na larger, let's say larger part ng body mo, it's a general concept, it's a blunt trauma. So this is an example of a blunt trauma. Ito naman, guys, on the right side, this is a penetrating na trauma. Kasi meron tayong di ba, may entry tayo, na may cuts po tayo. So basically, it's penetrating, right? It's more visible po, ang tinatawag na penetrating trauma. Ayan. So sabi dito, for the blunt trauma, the focus will be the blunt trauma. So it's more of, na pwedeng, nag-involve ng velocity, pwedeng, may direction of impact, diba? Ayan, depende kasi sa part, na body, na may compression, no? May deceleration, may acceleration. So it's more of a larger scale talaga pag blunt trauma. Na-emphasize na po natin yan right? And sa motor vehicular crashes. Ayan. So pag penetrating naman trauma, guys, so may mga cavitation tayo. When we say cavitation po, syempre may opening po tayo. Right? Ayan. So we have the mechanical principles of decompression. Kasi dire-diretso na po tayo up to the motor vehicular accidents na, guys. So as you can see sa picture po, brought about by decompression. So from that rib area, na-compress din po ang heart ni patient, guys. So, it usually occurs daw ang compression from the word itself na compress. It traps, between, two objects of greater density. Example, itong heart ay na-compress brought about by the motor vehicular accident. So may shearing tayo. When we say shearing, guys, it's a combination of a perpendicular force plus a parallel force. Tignan nyo. As you can see, ayan. So examples po, aortic arc at ligamentum arteriosum. Ayan, may tearing po tayo dito and that's the shearing force. Ayan. So rapid deceleration kasi, when we say deceleration, may movement. So we have the motor vehicular accident. Ito yung mga i-discuss natin. Motor vehicular accident, we have the falls, and then we have the sports-related po na mga accidents. Na, may rapid deceleration. Rapid deceleration, guys, fast movement po. Right? Now, for the motor vehicular accidents, this is brought about by the collision. Ayan, nag-collide po. Ang dalawang, na object. Pwedeng car to car or pwedeng car to na poste. The usual naman na nangyayari din talaga. So we have the rapid deceleration, rapid impact. So pag nabangga ka, ano mangyayari? So itong manubela po natin, guys, yung chest mo ay may impact po. So ano mangyayari? There will be impact, guys, and there will be compression. Sana compression lang. What if may mga tearing tayo? What if may mga shearing forces tayo? Right? From that rib, mababali, tapos itutusok ang lungs mo. So may tension pneumothorax ka na. Tapos natamaan pa yung heart mo. So, may cardiac injury ka pa. Na? So, package ka na, a total package. Tapos may mga displaced na spleen, right? Ayan. Tapos may mga abdominal, organ injury ka pa. Na dire-diretso na. Kaya nag-leak ang mga tinatawag na urine natin sa abdomen mo, brought about by that crash, brought about by rapid deceleration. Ayan. So we have your the motor vehicular related crashes, may frontal impact, may rear impact, may lateral impact. Ayan, tignan po natin ang mga pictures na to. First things first is that we have the frontal impact. Example ng frontal impact, guys. Ito, ayan. Actually, ano to eh. 'Di ba yung front mirror po natin. Na? Ayan, front mirror. So, the head leads, right? Okay, up and over pathway po. So, tingnan nyo ang compression po ng C4 and 5 po natin. So, there will be a damage to the cervical spine, okay, causing compression, hyperflexion, and hyperextension. That's the frontal impact. Pwede rin po yung chest at saka abdomen mo. Yung nakita mo kanina sa picture, guys. Ayan, nasa steering wheel po natin or sa manobela po. Na pwedeng, okay, may blow doon, may impact doon. Ayan, pwedeng may down and under pathway din po. Tignan nyo. Ayan. Ayaw naman natin ma-experience yan, for sure. Alright? Ayan, so we have the rapid deceleration. Frontal impact. When we say rear impact, guys, okay, pag binangga ka sa likod, so what happens? Malamang ang spinal column mo din affected po. Lalo na pag sa mga passengers and even sa mga drivers din po. There will be hyperextension. Actually, guys, na-try ko na ang rear impact. Sa tricycle naman yan, nangyari naman yan sa Kabanatuan. So, binangga po yung tricycle ko doon ng isang kapwa tricycle lang din. At first, guys, hindi ko pa naramdaman yung sakit. Ayan, pero ayun, no? Kasi, syempre, dati masaya pa kami, so hindi ko pa naramdaman ng sakit. Pero, biglang, ayun, nasaktan ka na bigla. No, doon mo pa naramdaman. So, medyo late po yung sakit, guys, na, ayan. So we have the lateral impact. When we say lateral impact, binunggo po sa side, let's say sasakyan or tricycle pa. So pag may lateral impact ka, pwedeng mga natin, na yung mga clavicles po natin, pwedeng damage or pwedeng ribs po natin, na, or pwedeng pelvis mo. Depende kung nasa right side ba or nasa left side. Kasi pag sabi mong lateral, whether left or whether right. Usually nangyayari po to sa mga intersection, mga collision. Kasi sa mga crossing, di ba? Kasi pag crossing kasi, in different directions yan. May papunta ng left, may papunta ng right. Ayan. So next, we have the rotational impact. Guys, itong rotational impact, pag nabunggo mo yung island, di ba? Sa isang daan, ang tawag doon, okay, magro-rotate talaga kayo from 90 to 180 degrees. Ang tawag natin doon, rotational impact. Ayan, may rollover impact din po tayo. Pag yung sasakyan nyo is gumulong-gulong talaga. Ayan, may nakita akong news kahapon guys sa Cebu, as in like nag-rollover po ang sasakyan. Ayan, kasi 'di ba, yung ibang area kasi, yung tipong alam mo yung masyadong excited talaga sa sa pag-lift ng liquor ban rather. Alam mo yung nangyari sa Bicol guys nung nilift po ang liquor ban. As in like dumami talaga ang cases ng motor vehicle accident. So it can be an alcohol intoxicated din talaga na client. Na? Kasi aminin natin, na pag once kasi na let's say intoxicated ka sa alcohol, sometimes guys na mas alam mo yung mas ganado ka mag-drive, di ba? Kasi parang feeling mo na stress ka, so parang na-relieve yung stress mo. Well, in fact, sobrang delikado yun. Kasi, yeah, for others po na nakaka-control, that's good. But for others, guys, na hindi na nakaka-control, yun na yung downside na yun, pangit na yun na part. Okay? Restraints also, tignan niyo pagkalagay ng restraints. Pag nakaganito ang restraint, guys, pwedeng mga abdominal mo, yung mga internal organs po natin. Pag ito naman, partly baka ribs naman po. And this one also, baka ribs naman din. Okay? Ayan. So, yung mga restraints natin that can cause also an impact. Although, at least, mas lesser naman din, guys, na ang tinatawag na effect na to. At least hindi ka, okay, lalabas ng sasakyan mo at maitapon. Next, we have the motorcycle crashes. Pag motorcycle po, yes, very common to. Kahit may ka pa, kahit may helmet ka pa, pag yung helmet mo nabunggo, ayan, so it's still an head-on impacts pa rin. Pwedeng sa mga objects, usually mga sasakyan or pwedeng poste. Basta yung head mo tumama, it's an head-on impact. We have the angular impact naman po. Ayan, pa-side naman po. Right? Pag ang motorcycle mo, ayan, na-strike po sa, let's say, sa sasakyan, ayan, or let's say mga objects po. Basta pa-side, guys, it's an angular impact. Ayan, so ito, this is an example of an injection. So pagkabunggo mo, ayan, as in like naitapon ka talaga. na yung impact po ng high energy, right? So an example of an injection. Naitapon, di ba? Ejected. Ayan. So basically guys, so for to promote po the injury prevention. Now for the injury prevention naman, helmets po talaga save lives po. Now with that incidents kasi tinatawag na motor vehicular accidents, nadodoble naman po ang survival rate po if ever kung naka-helmet. Pero di ba may napansin ka, may nakita nga akong video kahit naka-helmet guys, kasi like labas pa rin po ang mga utak ng patient, right? So well, nakakasad lang. So we have the pedestrians po. Alam niyo ba sa pedestrian guys, meron din tayong mga blunt trauma doon. Meron din tayong mga accidents doon. So ganito usually ang mga itsura nila. Pwedeng ito ang natamaan. So we have the leg of the patient. Or pwedeng ang ulo ni patient mismo matatamaan. Or simply, the whole of the patient guys. Pwedeng likod din ng patient natin. So nahulog siya mismo from that car. Ayan, tapos, ayun, drop na sa floor ang patient natin. So these are the adult patterns. Pag pediatric patterns naman guys, iba naman ang pediatric kasi nga diba, ang bata kasi masyadong maliit pa. Tignan mo as in like kasama niya yung ulo niya, kasama pa yung internal organs niya, chest and then the abdomen, kasama pa yung mga upper legs niya. Tapos, eto pa, naakyat pa siya. Tapos, ayun, may ulo pang natamaan guys. That's for the pediatric cases naman. So, di ba iba ang itsura ng adult? Pag adult, ganito ang itsura. So, pag pediatric po, brought about by the height of the said patient, ganyan ang itsura. So, we have the falls. Now, when we say falls, anong sabi ko nga? Pag nahulog, pwedeng, pwedeng mga feet na, or pwedeng nauna ang ulo. Depende kasi sa presentation ng fall po natin. So we have the feet first. The feet first, malamang vertical po ang pagkahulog ng patient natin. Kaya nauna ang tinatawag na, feet ng patient po natin. Kaya feet first ang tawag doon. If there will be feet first guys, expect for hyperflexion, expect for compression, injuries po natin. Don't worry, i-share ko yung slide na to sa inyo. Para at least may babasahin pa po kayo. Pwede rin po ang outstretched arms. Ito, masakit ng outstretched arms. Usually, nangyayari po yan sa what? Basketball, di ba? Or simply, yung mga gusto magpapakamatay talaga, na outstretched arms yun, which includes the wrist. Okay? Ano pa? Clavicle. Okay, ano pa? Shoulder. No? May mga dislocations po tayo. Ayan. So, we have the outstretched arms po. Ayan, example, ito din. So we have the feet first. No? So yeah, the fall po. Known as the feet first. So sports injuries guys. Na, ayan, sa mga taga Bicol po, di ba very common po yung mga ATVs po natin dyan. Yung mga ATV. So sport injuries po, mga boating natin, di ba yung mga paddling, mga contact sports, na bicycling. Ayan, name it. Right? Pwedeng may mga, may mga rapid impact talaga. Fast movement, pwedeng may mga torsion, may mga shearing, may mga compression na nangyayari. Very common po sa sports po. So, basketball, very common din po. Right? Ayan. Ayan. Next slide. Ayan, blast injuries. When we say blast injuries, guys, syempre, yung mga IEDs po natin, di ba, yung mga improvised explosive devices, such as mga warfare, example, na example, IEDs po natin, biglang sumabog. Ano pa? Yung mga, let's say, yung mga bomba, right? Ayan. Ano kayong hinagis, guys? Yun yung sa, nakakita ko lang kahapon, na? So, we have the warfares. Ayan. So, for the blast injuries kasi, pwedeng primary, pwedeng secondary, at saka pwedeng tertiary. Tignan nyo, sa primary po, guys, it's more of the energy, na? Pero pag, pag secondary na po, may mga shrapnels na po tayo. So basically, pag primary, it's more of the energy, yung parang, the force. Pero pag included na po mga objects, guys, such as shrapnels, then, secondary na po yan. Tapos, pag ito naman, na-hit ka, sa isang surface pa, ang tawag doon, tertiary na po. Ayan, tignan natin. So, pag primary lamang po guys, there will be what? Disbursement, pulmonary contusion, pneumothorax, okay, air emboli. Ayan, it's more okay of the okay over okay pressure wave. Ayan, so may impact kay patient. Ayan, so this is the primary. Pag secondary naman po, ito na, may mga shrapnels tayo, mga fragments, na may mga penetration na po tayo. Kanina kasi it's more of blunt eh. Ngayon kasi it's more of, okay, may mga penetration na po. Ayan, di ba may mga glass, auto parts, na pag sumabog ang isang sasakyan, malamang auto parts, at may mga metals, at may mga building materials. Pag included naman po, let's say sa mga work po natin, at nangyari sa mga buildings. Shrapnels as well. Ayan, when we say, okay, tertiary naman po, ayan, may impact na nga, di ba? Tapos na-crush ka pa sa isang structural, okay, na area. So let's say, okay, may pressure na, tapos kung bigla kang binalik ng pressure na yon kasi tumama ka sa wall, then that's your, okay, the tertiary na po. Ayan. Let's proceed na po sa, ano guys, sa, ayan, ito. The penetrating, okay, trauma. For the penetrating trauma, based, okay, on the law of physics and kinetic, okay, energy, guys. Ayan, syempre kasi may, ano eh, may transverses, okay, or let's say nag-transverse kasi, leading to a what? May penetration. So, yun ang nangyayari, okay, sa trauma. Or let's say, penetrating trauma. Example, na may direction of travel tayo, let's say for the bullets. Tapos, okay, malalaman kasi, lalo na pag mga crime scene, okay, investigator, guys, alam nila kung saan yung entry at saka saan yung tinatawag na okay, exit din, tinatawag na okay, bullets. So, ricochet ang tawag doon, right? The what? Na the exit okay, of the said bullet. So, ricochet. Ayan. So, for the penetrating trauma, so we have the low energy pag sinaksak ka. And just wag naman sana. So, we have the low energy ang tawag doon. It causes injury brought about by okay, the sharp objects or the sharp point or edge. Low energy yan. Pero pag gagamit na po ng mga pistols, guys, let's say ganitong pistols lang. Ayan. It's a medium energy po. Usually mga handguns. Okay, some rifles. Pero pag mga hunting, di ba, Diyos ko Lord, na itong mga ganito na, mga Armalite na, whether it's a baby Armalite pa, it's a high energy na po. Na penetration. Ayan. Okay. So let's proceed na po sa ano guys, sa management. Okay, or basically ito na. The summary. The knowledge of anatomy, okay, energy exchange, na kailangan po yan. Okay, and you apply kinematics on how to approach a scenario. You need to acknowledge also, okay, the energy being exerted by patient, whether nag-cause pa siya ng blunts or whether nag-cause pa siya ng penetrating trauma. Okay? Nonetheless, guys, na you need to have your what? Na your safety din. Aside sa safety mo, there should be the safety okay, of the said personnel. Okay? Now, I'll be showing you videos. Ayan, I'll be wrapping na from the very first topics po natin okay, up to okay, the last topic po natin via a form okay, of a video na po. So let's begin with the trauma okay, assessment. Hinaan ko lang ha, kasi medyo malakas to. So guys, this is on the BT, ayan, yung mga ano natin, the DCAP Btls. So pag sinabi mong DCAP Btls, it's part of the secondary assessment. Meaning to say, si patient po is conscious, di ba? Ayan, so malamang you need to what, na stay and then you play. Kasi usually pag na-achieve mo ang secondary assessment, meaning nag-stay and play ka. Pero pag hanggang, okay, ano ka lang, hanggang, let's say, letter C ka lang, circulation, wala nang disability, sir. Wala nang, okay, hanggang, ano ka lang, hanggang yung rapid scan, di ba? Tapos nag-decide ka, ayan, sabi mo, I need to load and go. And pag load and go, you need to transport the patient. Pero, nung nag-decide ka, nag-rapid scan ka, okay naman si patient, conscious naman, so I need to stay and play. So this is an example of a stay and play. So meaning, nag-secondary assessment tayo, nag-DCAP Btls. Check for deformities, diba, contusions, na Ayan, discoloration. Ano nga yun ulit? Ayan, yung mga abrasions po natin, di ba? May mga penetration ba tayo? May mga burns ba? May mga tears ba tayo? Right? May laceration ba? Na? Ayan, sige po.
Welcome to the Patient Assessment Trauma Skill Station. In this skill, you will have 10 minutes to perform your assessment and voice treat all conditions and injuries that you find. Just as you would in the field, conduct this assessment communicating with the simulated patient. If you need to, you may remove the patient's clothing down to their shorts so that you can better assess them. Specific clinical information not obtained through visual or physical inspection, for example, blood pressure, will be given to you only when you ask, following a demonstration of how you would obtain the information in the field. You will have 2 partners available to assist you that are trained to the same level of care that you are. They will correctly perform the verbal treatments that you ask for. I will acknowledge your treatments and may ask for additional clarification if needed. Do you have any questions?
I do not.
You respond to a report of a high-speed T-bone collision between 2 mid-sized cars. Your patient is a 28-year-old female who was removed by bystanders prior to your arrival. She is lying on the pavement when you arrive.
BSIP, my scene is safe. Mechanism of injury is a motor vehicle accident. Number of patients I have here is 1 patient. I'm going to go ahead and request for more EMS help, and I can cancel if needed. Due to the mechanism of injury and a motor vehicle accident, I'm going to put this patient in C-spine precautions, and I'll have one of my partners hold a manual inline stabilization of the head and neck. My general impression of this patient is a motor vehicle accident with possible multi-system trauma. The level of consciousness, ma'am, can you hear me? Okay, so response to pain. And so chief complaint would be possible multi-system trauma. I'm going to go down ABCs. So airway, I'm going to look, listen, feel. Do I see any secretions or obstructions in her airway?
No secretions, her airway is open.
All right, so her airway is patent. Breathing, I'm going to visually look at the chest rise and fall, but I'm also going to listen to breath sounds.
The patient is breathing at 24 times per minute and it is shallow.
Okay, and I'm going to go ahead and place an oral adjunct. And can I also get an SpO2?
The SpO2 is 92%.
Okay, and place her on with a non-rebreather with high flow oxygen. Circulation, I want to go ahead and check for radial pulses.
Her pulse is 112 beats per minute.
And skin?
Her skin is pale and cool.
Okay. Due to her breathing, the mechanism of injury, and the mechanism of this accident, I'm going to request this is a priority transport. I want to get a full set of vital signs. I would assign one of my partners to get a blood pressure, breaths per minute, get a pulse again, and also get SpO2.
The blood pressure is 92/64. Her pulse is 112 beats per minute. She is satting at 94% with the oxygen that you're administering, and her respiratory rate is 22 breaths per minute.
Okay. Due to her level of consciousness, I cannot obtain a sample history. So at this time, I'm going to go ahead and run through a head to toe. While doing that head to toe, I'll also expose my patient and check for any possible injuries. So I'm going to start here, the forehead, checking the skull, check around the back of the head. Do I feel anything or see any abnormalities?
No, you know no abnormalities.
Okay, I'm going to also check around cheekbones, eye sockets, and check the eyes, check the pupils for responsiveness.
Pupils are equal and reactive. You note venous bleeding to her right cheek.
Okay, checking the ears for any secretions.
No secretion.
Okay, I'm gonna reach behind and feel her cervical spine.
No deformities noted.
Okay, just checking the neck. Do I see any jugular vein distension?
No jugular vein distension, and your trachea is midline.
Okay, checking it down, feeling her shoulders. I'm gonna palpate her chest.
It's normal.
Okay,
No crepitus.
no crepitus. I don't, and her breathing is bilateral, chest rise and fall.
Yes.
Okay, I'm gonna palpate her abdomen.
Her abdomen is soft. No traumas noted.
Okay, and with her pelvis.
Pelvis is stable.
I'm gonna go down each individual leg and palpate each leg, checking for blood as I go along, and crepitus, any abnormalities.
Nothing noted on the right side.
Okay, as I get down, I'm gonna check fetal pulses.
You have fetal pulses present. Both legs.
Okay, I'm gonna work myself up. As I go up, I'm gonna expose the leg, and I'm gonna check again for any blood, any crepitus, anything.
You note swelling on her left femur.
Okay.
And the leg is short.
Okay. Is there any rotation?
There's no rotation present.
Okay. And it's midline?
That is correct.
Okay. Due to the nature of that, I have a possible femur fracture, and since there is no crepitus in her pelvis, that we can move along with a traction split, long bone for a long bone injury. So I'd have one of my partners go ahead and place a traction splint on the patient. I'm going to go ahead and come back up to the arms, check those really quick.
Right arm is normal.
Okay. Checking.
And the left arm is normal.
Okay. All right. So I want to go ahead and come back, manage any of the secondary injuries. I want to reevaluate the traction splint. I want to bandage up those venous bleeding that was on her head, and just basically monitor vital signs. And I want to get my patient ready for transport, so I'll go ahead and place her on a backboard. And I need to evaluate the spine as well when we do that. So. We're going to go ahead and roll her towards myself. Feeling her spine. Do I feel any crepitus, any deformities?
No crepitus, no deformities.
Okay, so we'll slide over. And on heads count.
1, 2, 3. 1, 2, 3.
And so got her on the backboard. We want to reassess CMS once we get her all packaged up, and reassess vitals, and our patient every 5 minutes in training.
So we'll have the spinal immobilization in a patient in a supine position.
Welcome to EMTprep.com. This is the spinal immobilization of a supine patient skill.
Welcome to the supine spinal immobilization practical assessment. Here we will evaluate your ability to properly secure a patient to a long backboard. During the assessment, you will have an EMT assistant. Your patient's vitals are stable. When you move the patient to the long backboard, I'd like you to use both mine and the EMT assistant's help. You are in charge of ensuring proper directions that are given to your partners. You may utilize any of the equipment shown before you, and I'd like you to review that now.
BSI, is my scene safe?
The scene is safe.
All right, so the first thing I'm going to do is I'm going to direct my partner to come in and place the head in an inline neutral position, and then I'm going to direct my partner to maintain C-spine stabilization. So once he's doing that, I'm going to check CMS. I have bilateral pulses. Can you squeeze my fingers for me? Awesome. And can you tell me which fingers I'm touching here?
My pinky.
Okay. And now I'm going to move down to the feet. Take the shoes off. Assess pedal pulses. And can you push down against my hands? Perfect. Now pull back up against them. Okay. Can you tell me which toes I'm touching?
My big toe.
All right.
Pulses, sensation, and motor function are intact in all extremities.
All right. So the next thing we're going to do is we're going to put a C-collar on. So I'll size my patient for a C-collar, select my C-collar, and set it to the appropriate size. Preform my collar a little bit. And then apply the C-collar, ensuring that I'm not moving the neck around too much. All right, can you open your mouth a little bit for me? Perfect. All right, now we have the C-collar on. The next thing we're going to do is we're going to log roll the patient and place her on the board. So I'll have my other assistant come in and help me with that. So on the heads count, we're going to roll the patient towards us, and then I will check her back, and then I will position the board, and then on the heads count again, we will roll her flat. Okay. 1, 2, 3. So I'm going to assess the back really quickly, checking for any deformity, any wounds. Position the board. All right. And on the heads count, 1, 2, 3. Okay, so now we're going to position her properly on the board. So we're going to move up and over in one swift motion. All right, on the heads count, 1, 2, 3. Perfect. Now we will secure the patient to the board using our straps. So coming over the chest. All right, I'm going to put this underneath your arms here. We're going to tighten this up real quick. So if you can pick your hands up for just a minute and you can cross them again. Sure, I've got that. Got one secured.
Maka-X po. Ang mga straps na ito.
Take that underneath your arm there. So the torso is secured. Again, I would check to make sure. Let's see if I needed to pad anywhere. I don't need to pad anywhere. So next I will secure the head. All right, patient's head secured. And then move down the body to secure the feet, the legs and the feet. All right, so the patient's secured to the board. Now I'll reassess CMS. Good pulses. Can you squeeze my fingers? Okay, can you tell me what
reassessment ulit.
Okay, moving down to the feet. Good pedal pulses. Can you tell me which toe I'm touching?
My big toe.
Okay, can you push down against my hands? All right, and pull back up against them. Okay.
Pulses, sensation, and motor function are present in all extremities.
Alrighty.
Is there anything else you'd like to do?
Nope, that's it.
Okay, thank you.
Okay, so we have the spinal immobilization on a seated patient.
Spinal immobilization seated patient skill.
Welcome to the Seated Spinal Immobilization Practical Assessment. Here we will evaluate your ability to properly secure a sitting patient to a KED. Your patient is sitting in a vehicle that has been involved in a motor vehicle accident. Your scene has been cleared and you arrive with your EMT assistant partner. Verbalize moving the patient to the long backboard. You are in charge of ensuring proper directions that are given to your partner. You may utilize any of the equipment shown before you, and I'd like you to review that now.
All right, BSI, is my scene safe?
Your scene is safe.
All right, so the first thing I'll do is have my partner place the head in an inline neutral position, and then I will direct my partner to maintain C-spine immobilization. Once he's doing that, I'm going to quickly assess CMS. So I have pulses bilaterally. Can you move your fingers for me? Okay, and can you feel me touching you here? All right, then I'll do the feet. I will take the shoes off, and then I will find pedal pulses. I have pulses. Can you wiggle your toes for me? Okay, and can you feel me touching you?
You have pulses, sensation, and motor function in all extremities.
Okay. Now that CMS is complete, I'm going to size my patient for a cuff, or for a C-collar. Select the appropriate size, reform my collar, apply my C-collar. Okay. All right, could you open your mouth for me a little bit? Perfect. All right. Now that I have the C-collar on, we're going to position the KED device behind the patient. So I'm going to take over C-spine. All right, I have C-spine. Good. And what we're going to do is we're going to have you sit forward just a little bit, and my partner is going to put the KED behind you. So on 3, 1, 2, 3. Perfect. So if you can position that behind her and get those chest flaps up underneath her armpit as much as possible, that would be awesome. All right. Okay, so we have that now. So on 3, we're going to sit you back into the chair. 1, 2, 3. Okay. So now I'm going to turn C-spine back over to you. Are you ready? Mm-hmm. All right. Now, I will make sure that the device is positioned how I want it. And starting on the torso, I'm going to secure the device to the patient. Making sure not to move the spine too much as I do this. All right, so now I've got them all connected. I'm going to go back through and I'm going to tighten them up a little bit more. Can you take a deep breath for me? Okay. All right, now that I have the chest straps done, I'm going to place the ischial straps. All right, so I'm going to have to place these straps between your leg, and then I'm going to kind of have to move them up. All right. And once I have both of the ischial straps in place, I'm going to secure the head. So first, we'll go underneath. And I would pad behind the head as appropriate. With her, there's no padding necessary. Okay, so the head's secured. Now we would transition the patient onto a long backboard and secure her to that. And once we had her secured to the long backboard, I would again reassess CMS, feeling for pulses on both the feet and the arms. Checking sensation, and then having her move both of them for me.
And circulation, sensation, and motor function are all present in all extremities.
Awesome.
Is there anything else you'd like to do?
Nope, that is it.
All right, guys. So my last video po will be the trauma assessment. Ayan, in an intra-hospital setting. Nangyayari po, okay, inside the emergency room po. Ayan, so get ready na po kasi about to finish na po tayo. Ma'am, clear pa naman yung audio natin, ma'am, no? Ma'am Joy? Ma'am? Hello? Sige, mag-check na tayo ng estudyante. Ma'am Aquino, naririnig pa naman po ang video, ma'am? Pa-chat na lang.
Yes po, sir.
Okay. Sige po. So this will be the last video. So an ABC assessment inside an emergency room. So this will be an hospital po trauma assessment.
Welcome to the emergency medicine course. I'm going to start off by talking about the approach to the undifferentiated patient in the emergency department. So the first question you want to ask yourself when you see a patient in the ED is this patient sick or are they not sick? If your patient is sick, you know that you need to act quickly in order to get the situation under control. So first and foremost, you're going to get help, especially if you're a relatively junior trainee. You want to make sure you have some backup so you can take good care of the patient. You want to also prioritize your sick patients over your not sick patients. Clearly, the ones who have life threats should get cared for first. You want to rapidly assess the patient so you can get to the bottom of what's going on. But you want to simultaneously stabilize them at the same time as you're treating them so that you can start making them feel better and decrease the likelihood that they're going to have a bad outcome. And you want to expedite their diagnostic workup and management. So when somebody's sick, you really want to get to the bottom of what's going on as quickly as you possibly can. When we assess the acutely ill patient, we're going to start off with the goal of identifying and treating immediate life threats. That's going to be the mantra we repeat to ourselves while we're taking care of this patient. And we're going to accomplish that by performing an A, B, C, D assessment on each and every patient, each and every time. Whenever somebody's sick, we want to say, oh my. That stands for oxygen, monitor, and IV access. Oxygen, obviously, to help with breathing, monitor so we can keep tabs on what's going on with the patient, and IV access so we can treat them if they need it. Like I mentioned before, the goal with sick patients is simultaneous assessment and treatment. So while we're assessing our patient, if we identify a life threat, we don't want to just keep going along and assessing them. We want to address that life threat immediately. This is not the time to sit down and take a leisurely history and perform a physical exam and then start thinking about treatment. We need to be able to do everything all at once to get the ball rolling for our patient and get them stabilized as rapidly as we can. So we're going to start off talking about the ABC assessment. And as you've probably heard before, ABC stands for airway, breathing, and circulation. When we think about the airway, clearly anybody who's talking, that's a good sign. They have a patent airway. But even for a patient who's able to speak and phonate normally, they could possibly have future airway obstruction, and we want to be prepared to deal with that. So look for signs of edema, either in the face or the pharynx. Look for blood, vomit, or other foreign material in the airway, and listen to their breathing, not with a stethoscope, but just with your naked ear. Anytime a patient is breathing in a way that's noisy or easily audible, That's obstructed breathing, and the louder it is, the more concerned that you should be. Regarding breathing, the best thing we can do is just get a gestalt sense of how hard the patient is working to breathe. If the patient is using the muscles in their neck and in their chest, and if they're doing push-ups when they try to breathe, those are all signs that they could potentially have impending respiratory failure because they're not going to be able to maintain that high level of work of breathing indefinitely. We want to listen to their breath sounds, and we want to check their pulse ox. The pulse ox is the single most important vital sign for breathing. The whole purpose of the lungs is to get oxygen into the bloodstream, and even if the patient looks and sounds great, if they're hypoxic, you've got a problem with B. Lastly, we want to check circulation. So part of circulation is just a general gestalt look at the patient. If the patient is mentating well and they're nice and pink, that's a really good sign that they're perfusing their brains and the rest of their bodies adequately. Whereas if they're pale, cyanotic, altered, they may potentially not be perfusing as well as we'd hope. We also want to feel peripheral pulses. Now, clearly, a patient who's awake and talking to you obviously has a carotid pulse, right? They must be perfusing their brain. But if they have a weak or absent peripheral pulse, that's something that we want to be aware of because that could tell us potentially that they're not perfusing the periphery as well as we'd hope. We also want to look at their vital signs, the heart rate, the cardiac rhythm, the blood pressure. These all give us important clues about the adequacy of circulation. So let's start off with A and B. Now, A and B are usually assessed together, and the vast majority of A and B problems are really B problems. They're usually caused by pulmonary disease rather than primary airway emergencies, although we do look at the two things together. So again, respiratory rate is an important vital sign for A and B. A patient who's breathing very quickly, you want to be concerned about the possibility that they're going to tire out and not be able to sustain that respiratory rate. I also want to mention that respiratory rate is often not documented correctly in the chart, so this is one that you should really check yourself. You should bust out your watch, look at the patient, count their respirations over the course of a minute so that you can get a really good sense of how quickly they're breathing. Pulse ox, we already mentioned, is absolutely critical. It's the most important vital sign for A and B. And again, that work of breathing. If a patient is using a lot of metabolic energy to get air into their lungs, they're not going to be able to sustain that indefinitely, meaning that they're not going to be able to continue oxygenating and ventilating normally in the long run. And they're at risk for developing respiratory failure. Anytime you suspect a problem with A and B, you want to start off by giving them high flow oxygen. That's going to obviously address hypoxia and hopefully also reduce their work of breathing because they'll be able to oxygenate with less effort. You want to be ready to manage the airway. That's not to say that every single patient needs to be intubated right this minute, but you want to have the necessary equipment, medications, and personnel available so that if you do need to manage the airway, you'll be ready. You want to auscultate the lungs, and that's really important because auscultation doesn't tell you if there's a problem with airway and breathing, but it can help tell you why. It can help narrow your differential. So if your patient is wheezing, you're going to manage them differently than if they have crackles versus if they have unilaterally absent breath sounds. So different lung sounds are going to help us understand what the underlying problem is and treat it accordingly. And then lastly, we want to get a stat chest x-ray. Any patient with any degree of respiratory distress deserves to have a picture of their lungs so we can get a better sense of what's going on with them physiologically. Let's move on to C. So we already mentioned some of the things we want to check for C. I want to also stress the importance of vital signs for circulatory assessment. So anytime a patient is tachycardic, there's one of two things going on. Either A, they're having a cardiac dysrhythmia, and you want to make sure that you address that rhythm disturbance as a primary disease process. Or two, if they're in sinus tachycardia, so their cardiac rhythm is normal, but their heart rate is fast, then you want to recognize that they are trying to physiologically compensate for some underlying derangement, and you want to figure out what that derangement is and take care of it. Blood pressure is kind of like pulse ox, right? It's the bottom line on circulation. It's the bottom line for C. The whole point of the circulatory system is to send blood to the vital organs. And if your blood pressure is low, then the perfusion pressure for those vital organs is going to be low, meaning that your circulation is inadequate. So even for a patient with a normal heart rhythm and rate, if they're hypotensive, we have a C problem and we need to take care of it. Anytime we suspect a problem with C, we want to make sure we get 2 large bore IV catheters, not 1, but 2. And that's so important because we want to make sure that we have the ability to rapidly infuse fluid or blood products if the patient needs it. And in the event that one of our IVs infiltrates or falls out, we want to always have a backup so that we're not facing interruptions or obstacles in trying to treat our critically ill patient. We want to make sure that we get a good look at the monitor and differentiate those patients who have non-sinus from those who have sinus rhythms. And again, if they have a non-sinus rhythm, we want to think about treating it. And lastly, we want to consider IV fluids. Now, not every single patient with a circulatory abnormality needs IV fluids, but the vast majority will benefit. There are some cases like cardiogenic shock where the underlying problem is really pump failure. The heart's not squeezing adequately to perfuse the body. That's a situation where fluid isn't going to benefit you. But in the vast majority of cases, filling up the tank or optimizing intravascular volume is going to be the first step in stabilizing C.
Okay, guys. So that ends our basic trauma course. So congratulations po sa nag-subscribe kasi for you have completed po the 2-day lecture of the basic trauma course. So I am open now for questions and clarifications po. So this will be much more appreciated if you're gonna join the return demonstration, let's say the actual. And kasi kompleto po ng gamit guys ang VPOC, training center. And please inform also your friends that we will be having next week na po, we will be having the Btls, ACLS, and then the trauma. Pero depende pa rin po sa VPOC kung kailan po yung next schedule po natin. Okay? And so I hope na may mga dagdag learnings po tayo. Right? Especially for those na nasa hospital setting po. And for those na wala pa naman or hindi pa nag-hospital, walang problema. Ang importante, ma-apply po yung learnings po natin. Thank you po.
Thank you, Sir Mark.
Thank you, ma'am.
Guys, meron po tayong next schedule ng basic ECG interpretation. Kung gusto niyo pong mag-attend, 1,500 lang po yun. 1 day lang po. Basic ECG interpretation po on June 14. Meron din pong Btls, ACLS po on June 15 and 16. Kung gusto po mag-attend.
Okay.
Inform also your friends po. Yun guys, lahat na po meron ng email na receive ko na po yung email nyo. Expect nyo po yung certificate and ID nyo po later this day. Send ko po dito sa email nyo. Tapos yung hard copy po ng certificate ID and yung official receipt nyo po, i-send po namin through GLEC or JNT. Tomorrow na po ito. Yung address nyo po, hihingin ko sa email nyo po. So magre-respond po kayo doon sa email na send ko sa inyo. Together, hihingi din po kami ng feedback po sa training namin. Feedback sa module, sa instructor, sa coordinators na nag-assist sa inyo. Yan. Tapos po kung may mga questions po kayo, punta lang po kayo sa Facebook page po ng WIPAM. Type ko po, WIPAM.
Ma'am, kinabahan ako sa kay sir na naka-white.
Bakit?
Yung sa sa PDMDH. Akala ko si X. Kinabahan ako tuloy. Akala ko si Doc.
Payat naman eh. Payat naman eh.
Ay guys, okay lang ba tayo? Mag-group picture tayo?
Yes, sige.
Sir Gilbert, pakita ka naman, sir. Pakita mo yung kagwapuhan, sir. Yung nurses po natin dyan. Si Ma'am Maria, And ma'am, para picture-picture po tayo. Tapos i-upload nyo din sa Facebook, guys, para sabihin nila, wow, ang talino naman ito. Nag-training talaga. Ganun lang naman talaga yung purpose na.
Tag na lang po ang PPAM.
Ayan, sige po, mag-1 tayo, guys. Para networking. Sige, 1 po tayo. Ayan, mag-1. Ayan. 1, 2, 3, smile. 1 po. Wait lang. 1, 2, ay. Si ma'am, magko-connect si ma'am muna. Ma'am Maria. Ayan. Connecting pa ba si ma'am? Or nawawala si ma'am kanina pa eh? Ayan, sige po. Again, waki na guys. Waki.
Ay, waki. Mga master, paano mag-waki?
So, ayan guys, na yung training natin kasi, depende kung i-apply nyo yun. Ayan, so depende din kung let's say pag-arrive nyo sa scene, sabihin nyo the scene is not safe, edi wala kang gagawin. So nasa sayo lang din, di ba? Kung gusto mong ma-toxic, edi you stay and then you play. If the scene is not safe, edi wala. No? Bye-bye agad, di ba? Sa rapu-rapu, mag-ingat po kayo always.
Thank you, sir. Thank you, Sir Mark.
Thank you. Ingat always. Salamat po sa lahat. PDMDH, na DLCV.
Thank you po.
Bueno, Mama Kino. Thank you.
Thank you, sir.
Thank you, Sir Mark. I miss you.
Yeah, miss you too. Ingat po always.
Ikaw din, mag-ingat.
Sige po.
Mag-ingat sa puso.
Yeah,
ano na yun? Ano na yun? Hindi, yung heart. Ano na yun? Broken heart. Ano na yun? Attack. Broken heart.
Wako pa naman tayo. Nakamaroon din. Hi, sir.
Yes.
Hi sa nakamaroon.
Marami pang doctor dyan. Oh.
Marami pang doctor pala. Hi sa nakamaroon. Pa-add naman sa Facebook.
Hindi na sumali yan sa sunod, sir. Hindi na sumali sa atin sa sunod.
Why? Ingat kayo, sir. Sino yung naka-red, ma'am? Baka siya na yung forever ko.
Baka si ano yan, Sir Mark.
Parehas pala ng name din.
Baka si Jesus. Sino po sa inyo Jesus? Yung naka-white.
Yung naka-white kasi kamukha ni X.
Sir Jesus po yan? Yung naka-white po sa Sir Jesus?
Sir Jesus, kamukha ni Vince.
Payat naman si Sir Jesus. Mataba naman yung ex mo.
Kaya nga. Hindi, ka-aura sila, ka-aura.
Ka-aura.
Yan. Yan. Si Ma'am Aquino. Hi, Ma'am. Ingat ko always dyan. Thank you for the trust also. And, Ma'am,
may iba po kayo sa ibang online trainings.
Punta ka na dito sa Rapu-Rapu, sir.
Invite nyo kami, ma'am. Mag-training kami ulit sa Rapu-Rapu.
Yes, ma'am. Pag wala ng COVID. Inshallah, pag walang COVID.
Inshallah.
Inshallah.
Kailan nga yung last namin dyan, ma'am?
Last year lang yun, ma'am eh.
Opo, last year. October 29, 2019.
Nagbarko kayo, sir? Nagbangka?
True.
Kasama mo
nandito siya sa original na air condition na room.
Kasama mo siya sa
walang light paggabi.
Kasi yung mga nurses natin sa PDMDH, nag-lunch na ba kayo, sir?
Magla-lunch pa lang may plato.
Magla-lunch pa lang. Nagpapakit silang dalawa eh.
Yeah. Guys, pag gusto niyo mag-attend ng actual demo, pag nag-schedule po kami sa Legazpi, kung saan malapit, sa vegan naman, nag-schedule kami, pwede po kayong mag-attend. Basta dapat naka-follow.
Thank you, ma'am. Inshallah. We-pump ito sa FB, di we-pump.
WePump Center for Learning.
Sa FB ito, Ma'am Joy.
Opo, FB page po yan, WePump.
Eh, naka-zoom na ako sa TD-NDA. Ayan. Alam ko na po yung address niyo. Alam ko na po yung mga asawa niyo, yung mga anak niyo. Nag-background check na po ako, sir. Ay, hello po sa nag-offer ng cake. Sana all, ina-offeran. Hi, sir. Ingat kayo, ah. I'll see you soon. Ingat po. Pwede naman din po, while waiting, I can play po yung updates ng COVID na I can play naman po ngayon. This is based on the World Health Organization, okay, sa COVID updates po nila. Okay, and then you can actually leave na din if ever kung ayaw nyo naman. Pero yeah, maganda din na updated din po tayo sa COVID. Sige po. So, ma'am, I will play na, okay, the COVID video. Saan na ba yung COVID natin? Ayan, guys. Updates on COVID.
SARS coronavirus 2. SARS coronavirus 2, beginning in 2019, a physician and then several physicians in Wuhan, China, began to notice the emergence of a fairly severe respiratory illness, beginning with mild upper respiratory tract infection signs, but rapidly progressing to severe underlying or lower respiratory tract disease. This illness was also characterized by high infectivity and an incredibly high caseload. Because of that high infectivity and the impact on healthcare systems and certainly on patients with severe lower respiratory disease, that virus or that infection began to gain notice internationally as the cause of a potential following pandemic. In fact, ultimately, the virus identified causing this infectious process was a member of the coronavirus family and aligned very closely with former outbreak viruses, including Middle East Respiratory Syndrome, MERS virus, and Severe Acute Respiratory Syndrome, SARS virus. And to that end, the virus has now been named Severe Acute Respiratory Syndrome, or SARS coronavirus 2, the second one in the lineage of SARS respiratory type illnesses. The disease associated with SARS coronavirus 2 is coronavirus infectious disease 2019, or COVID-19, as it has been nicknamed. And it is characterized, again, by that high infectivity, high attack rate in a population, and potential progression to severe pneumonia, including acute respiratory distress syndrome and multi-organ dysfunction, failure, and severe acute respiratory syndrome. The initial COVID-19 process began, as I noted, in Wuhan, China, but rapidly spread to other nearby provinces in China, followed by spread to other areas or countries in Asia, including South Korea and Japan, and then, unfortunately, and now to the rest of the world, where nearly every country in the world has checked in with cases. An incredibly unfortunate inclusion in this are cruise ships, which are floating hotels in which multiple patients in a closed space can be and have been infected and then must undergo quarantine. On March 2020, the World Health Organization named COVID-19 as a pandemic, in large part to stimulate all countries around the world to create and implement an intense global response with the goal of limiting internal spread and hopefully even limiting further global spread. The clinical aspects of COVID-19, first of all, high infectivity, high attack rate, very easy through respiratory droplet to be infected with the disease. Majority of cases are mild, as noted. In fact, at least 80, if not more, 85% of cases are indeed mild, those occurring in children, young adults, even some older adults. But severe disease can and does occur, most especially in patients with some risk factors, including those of older age, so age 60 and higher, those patients who have some degree of immunodeficiency, whether they are immunocompromised, immunosuppressed, or something like that. Certainly those patients who have pre-existing lung or even other organ disease, including those with type 1 insulin-dependent diabetes mellitus. The mortality rates estimated at 1 to 6%, although this is only an estimate as of this point because the N, the denominator, is not yet known. The virus testing is so far not complete, and so the number of mild cases who are not coming for testing are not known. Hence, it's hard to predict exactly what the true mortality rate is. That said, comparing mortality rates of COVID-19 to influenza, it is estimated to be at least tenfold higher, if not more. Those areas of either the world or patients who have a mortality rate of 6% typically are those with an older average age or those who are in a closed, unprotected environment, such as an extended care facility, a cruise ship, a nursing home, etc. Clinically, the incubation period for COVID-19 is thought to be 2 days to 14 days, with a tail end, however, of at least 21 days. Concerning evidence just emerging is that the virus itself, SARS coronavirus 2, may persist in an infectious state for at least 3 to 4 days, if not longer, on environmental surfaces, including countertops, utensils, doorknobs, etc., and so forth. After the incubation period, most patients present with fever. Over 60% may have a dry cough and myalgias. So far, a very influenza-like illness. However, shortness of breath occurring in over 30% so far is emerging as a symptom or a complaint which may be more specifically predictive of infection with COVID-19 versus influenza, rhinovirus, parainfluenza, etc. As noted, those patients who go on to severe disease do so by entering into respiratory failure, followed by hypotensive shock, multi-organ dysfunction, etc. Diagnosis. Well, first and foremost, as one would anticipate, given that COVID-19 occurs simultaneously with other respiratory illnesses, it is important to evaluate for and hopefully exclude other such illnesses, such as influenza, parainfluenza, rhinovirus, even other coronaviruses causing upper respiratory tract infection, and even including bacterial pathogens such as pertussis and mycoplasma. However, to specifically evaluate or screen for COVID-19 infection and the SARS coronavirus 2, one can send a nasopharyngeal or oropharyngeal specimen, a swab, for nucleic acid amplification testing, which can be done fairly rapidly, both commercially as well as by county health department labs. Other diagnostics are emerging, including molecular diagnostics, and also a blood spot testing for immunoglobulin M/G for presence of SARS coronavirus 2. It remains to be seen the utility of these testing strategies in a screening process versus reserving their use for confirmatory testing. Treatment, unfortunately, as with many other viral infections, is scant. There are no confirmed yet antiviral therapy agents with known effectiveness against SARS coronavirus 2, although multiple agents are being evaluated. There is emerging evidence that some antiretroviral therapies may, such as what we see used in HIV infection, may have some impact. Passive immunotherapy, including treatment with monoclonal antibodies, is also being evaluated for impact. This is very similar to interventions used in Ebola virus disease, initially in West Africa and currently in the Democratic Republic of the Congo. Refractory cases. This is a concern, whether it's because patients are progressing into severe disease despite initial supportive care, or for those patients who appear to have been clinically improving and then apparently relapse, who enter into respiratory failure and shock. There's a suggestion in a manuscript just published in Clinical Infectious Diseases that patients who are male, who present with anorexia and an absence of fever may have higher risk of developing refractory cases. Ultimately, the best treatment is prevention, and to that end, at least 6 vaccine products separately are being developed as I speak. At least one of those has been administered to live human volunteers in California in the States. It remains to be seen the utility or efficacy of the vaccine products. Until a day in which vaccines can be appropriately developed and are effective, then social distancing and quarantine are the 2 most robust interventions possible. Social distancing, limiting contact with other human beings within at least 6 feet, avoiding large gatherings, practicing, of course, good cough etiquette, etc. And then the more invasive, if you will, intervention, that being quarantine. And this involves closing borders, closing restaurants, pubs, concerts, sports events, any area in which humans may be too close to violate that 6 foot distance rule. Or quarantine and that degree of intervention was ultimately used very successfully in Wuhan, China. And it is hopefully being rolled out around the rest of the world as I speak. It remains to be seen if this is too little too late, however. The two challenges that are anticipated and one is attempting to avoid via quarantine. Number one is to limit the number of patients at risk who progress into severe disease with COVID-19. This is a fear because the sheer number of patients who might develop this progression have high potential to overwhelm the healthcare system of any country in the world, and certainly overrun the use of ventilators and healthcare providers, hospital beds, even hospitals available to care for them. And this was found to be a major challenge in the initial province in China, in Wuhan, which experienced exactly those complications. The other concern that's being addressed with quarantine is to try and limit the insertion of SARS coronavirus 2 into the viral milieu of humans in the world, such as has happened with influenza both A and B. Viruses that are so inserted have the potential for seasonal recurrence and the same impact in terms of morbidity and mortality as we're currently seeing with COVID-19 and C many times in a decade with influenza A and B. So the more that one can be effective in preventing spread of COVID-19, the more successfully we'll see our way through this particular pandemic. But this is just one of many, many, many more to come. So until then, continue to support vaccine development, continue to develop antiviral development, and wash those hands.
Hi, so that ends our lecture for today. Mag-ingat po sa lahat ng mga nandirito po. I'll see you. Bye-bye po.
Thank you so much, Sir Mark. See
Thank you po. Thank you po.
guys. I-end na po namin yung meeting. Kung may questions po
Okay po.
Sa FB page na lang po ng WIPAM. Again, WIPAM Center for Learning.
WIPAM Learning Center po yun, Ma'am Joy. WIPAM Learning Center.
WIPAM Center for Learning po.
Ayan. Baliktad pala.
Opo.
Ayan na, nakita ko na yung picture ninyo.
Opo. Again po, thank you so much po.
I-end na daw yung